டவுன்லோட் பண்ணிக்கலாம் சார். Well, I just say the first album. immense joy to welcome the inquisitive minds that have gathered here for the fifth JIPMER surgery update. After the exciting alumni meet yesterday, here we convene to participate in a two-day event that will enrich our existing knowledge in the field of surgery in the form of exciting guest lectures, case presentations, inquisitive quizzes, and a lot more. So without further ado, let's dive into the first session of today. To begin today's session, we have a case presentation by our postgraduate students, Dr. Indushekar and Dr. Ratul, on oral malignancy. I request the examiners, Dr. Robinson Smile, Dr. Narajan, Dr. Sethil, and Dr. Srinath to kindly come to the dais. Ratul and Indushekar.
YouTube link share मेरे
இதுல ஷேர் பண்ணல வேர் ஒரு நிமிஷம் வேர் இஸ் இட் இஸ் ஆல்ரெடி நாட் ஷேரிங்
permission sir you can share இல்ல வாங்க
நான் அது பண்றேன்
டேபிள் பண்ணிட்டீங்க
Good morning. We'll start with first stage oral malignancy. Can you introduce yourself? How many of you? Two, huh?
Good morning, sir. I am Ratul, and this is Indushekar. We are going to present on oral malignancy case presentation. We are final year here. Starting with the history. We are presenting a 60-year-old woman, a farmer by occupation from Dindivanam, who belongs to the lower socio-economic status, who came with chief complaints of ulcer in the inner aspect of the left cheek, which was present for 1 year duration. History of presenting illness. She was apparently well 1 year ago, following which she noticed an ulcer over the inner aspect of the left lower cheek, which was insidious in onset, initially over the lower inner aspect. Initially over the lower inner aspect of the left cheek, which gradually progressed posteriorly and onto the lower gums to reach the current size. It was associated with bleeding on touch and excess salivation. She also gives history of loosening of the left lower molar teeth, for which she sought dental extraction 6 months back by a native medical practitioner, and she was advised no further treatment. She gives no history of pain or ulcer or any ear pain. She gives no history of discharge. She gives no history of difficulty in speech, no history of difficulty in swallowing, no history of restriction in mouth opening, no history of any sharp tooth previously or any trauma or any use of dentures, no history of any white or red patches in the oral cavity. She gives no history of halitosis, no history of any high-risk behavior, no history of chewing tobacco. She gives history of chewing tobacco for the past 15 years, about 2 to 3 per day, and no history of quid placement. No history of any swelling in the neck, no history of any loss of weight or loss of appetite. She gives no history of cough, breathlessness, or hemoptysis. She has no known comorbidities. She is a non-vegetarian by diet. She has normal bowel and bladder habits and normal sleep and appetite. Her Obstetric history is P2L2, both normal deliveries. She's not sterilized and she's postmenopausal for 15 years. Past history, she gives history of loosening of the lower incisor teeth and dental lower molar teeth and dental extraction, which she underwent 6 months back. She also gives history of spontaneous falling of the upper teeth, which happened 1 year back. There's no history of radiation exposure, no history of any surgeries in the past, no history of any high-risk behavior. She has no significant family history. Coming to the summary, a 65-year-old lady from Dindivanam came with complaints of ulceroproliferative lesion over the lower gingivobuccal sulcus, which was insidious in onset, progressive over the past 1 year, which bleeds on touch and is associated with excessive salivation. She also gives history of loosening of the lower molars and dental extraction of the lower teeth 6 months back. She gives history of tobacco chewing over the past 15 years. Based on the history, presence of an ulceroproliferative growth which bleeds on touch, associated with excessive salivation and spontaneous loosening of the teeth, I would like to think of an oral malignancy in this case.
What would be the history of referred fail to ear?
So involvement of the lingual nerve could be referred through the auriculotemporal nerve, and that could cause ear pain. Develop sarcomas, developing verrucous carcinoma as well.
And family history, what do you expect? No history of family, what do you expect?
Certain syndromes like Bloom's syndrome, Fanconi syndrome have been known to be causes for oral malignancy.
About chewing tobacco, she takes only tobacco.
Yes, sir. She gives history of chewing only tobacco.
No,
No history of replacement in the past.
no. So she takes along with that Aricanat.
No, sir.
Yeah?
No, sir. Only tobacco leaves she gives history of chewing for the past 15 years.
She takes it and keeps it in the cheek.
Sir, we asked history whether she places it in the gingivobuccal sulcus. She says only chews and for about 20 minutes, about 3 times a day.
She chooses on the left side, same side.
Yes, sir.
Did you ask for any loss of sensation?
Yes, sir. Since there was no history of loss of sensation or the mental chin and pain.
Why should you ask?
So involvement of mandibular nerve, inferior alveolar nerve involvement in a case of if mandible is if the mandibular erosion, cortical involvement is there is a risk of inferior alveolar nerve involvement and a branch of which is mylohyoid branch and mental branch. So there would be loss of sensation over the chin.
Why it is important?
Presence of mandibular involvement might, if cortical breach is there, there is a need for reconstruction.
It need be bone involvement. The growth is there, everything you know the left side. So it can involve the nerve. So what is the significance of nerve involvement in oral carcinoma? It's a good prognostic sign of bad prognosis.
Bad prognosis.
Neural involvement is very bad prognosis. You should ask for, especially this growth in the posterior involving the gingiva, involvement, clinical involvement of inferior alveolar nerve. Has she got any other study apart from the oral cavity? They asked.
On history, no other study.
Yes.
Yes.
Where relating to last study?
Any other neck swelling?
No, apart from the inside the oral cavity.
Any other swelling away from the primary lesions? There is risk of other primary lesions for which she gives no history.
When do you say it's a primary lesion? What is the period?
Within 6 months is a synchronous lesion. So more than 6 months is metal.
Like can have multiple lesions, patient who is taken to
Multiple primaries are also possible.
Any other pre-malignant condition you asked for, the history?
Yes, sir. History of any white patch or red patch I
No,
have.
actually got everything.
No, no other.
What about the bad thing which is falling on its own? Is not a predisposing factor.
Yes, sir.
No. Okay. Anything else? Any other?
Denture exposure, no history of denture use or sharp tooth, sir.
Okay. Then
No history of any white patches, no history of any high risk behavior.
what is the white patch called?
Leukoplakia.
What is the definition of leukoplakia?
It is a white patch which is clinically and pathologically cannot be identified, characterized as any other lesion.
How do you differentiate from the candidates?
So it cannot be peeled out.
That is another picture, which cannot be scraped out. The which can be fungal thing is another
What is your shade?
malignant, which should be differentiated. Right?
Start well.
What is the important pre-malignant condition?
Yes, so pre-malignant conditions can be classified into high risk, moderate risk, and low risk. High risk lesions are among leukoplakia, speckled and proliferative verrucous leukoplakia are high risk pre-malignant lesions. Erythroplakia and also moderate risk is oral submucous fibrosis and syphilitic glossitis. Low risk features are patients with lichen planus, despite lupus erythematosus and sideroblastic dysphagia.
How do you define second primary in the oral protein?
Yes, sir. It is based. The criteria is based on two lesions which are separately biopsied and proven to be malignancy with normal tissue in between.
Any distances?
2 centimeters. So possibility of second synchronous lesions in the lung are also possible.
Lung is
Lung, nasopharynx, oropharynx, and oropharynx also.
oral carcinoma, lung carcinoma, the lung secondaries are not common. Isn't it? When you get lung secondaries in the upper aerodigestive tract cancer.
Usually only if the lower cervical nodes are involved, there is a higher risk of lung secondaries.
Primary, any primary particular lesion which will give rise to secondary in the lung.
Soft tissue in oral sarcomas.
Examination. After informed consent, patient was examined under adequate light and exposure in sitting position. She was conscious, cooperative, oriented to time, place, and person. She was moderately built and adequately nourished, well hydrated. Body mass index of 23.61. Pulse rate was 80 beats per minute, regular in rhythm, normal in volume and character. Blood pressure was 126/88 millimeters of mercury. Respiratory rate was 18 cycles per minute. Her ECOG status was 1. No pallor, icterus, cyanosis, fetal edema, clumping, or generalized lymphadenopathy. Oral and dental hygiene was failed. On local examination, mouth opening was adequate and she was hidden to us. Yes. She had an ulcerative growth of 7 cross 2 centimeter, irregular shape and margin, extending from gingiva of central incisor along the alveolar arch up to the lower first molar tooth, also involving the gingiva buccal surface inferior. The ulcer were everted edges, irregular margin, lower bound by tumor tissue with overlying slug. She had complete loss of memory. There was no leukoplakia or erythroplakia, no other synchronous lesion. Tongue was freely mobile, floor of mouth was normal, soft and hard palate was normal with ula in the center. Opening of parotid duct was normal, right gingival surface was free, bilateral retromolar trigone was free. On inspection, on palpation, inspectory findings were confirmed. She had an ulcer growth of 7 plus 2 centimeter, irregular shape and surface, formed to hard in consistency, irregular margins, extending from the gingiva of central incisor along the alveolar arch up to the first molar teeth, also involving the gingiva buccal surface. It bleeds on touch. Retromolar trigone was not involved. Left-sided mandibular irregularity with tenderness was noted. On examination of neck, trachea appeared to be mid-like. Left level 1A and 1B mobile discrete lymph nodes filled of size 1 cross 1 centimeter, which was hard, non-tender. Bilateral complicated pulsations were built. Examination of cervical spine was normal. Examination of ear, nose, throat, and skull was normal.
I don't know.
On systemic examination, respiratory system, bilateral air entry was equal and normal vesicular rhythm was heard. Cardiovascular system, S1, S2 sounds are heard. Parabdominal soft, non-tender, no organomegaly, no normal bowel sound heard. Central nervous system, no focal neurological deficits noted.
What's the diagnosis and what is TM staging?
Carcinoma, gingiva alveolar arch. My TNM staging will be T4B, N1.
So why do you say T4B?
Mandibular tenderness was noted, indicating that it might have eroded the mass.
Can you reconsider your TNM again?
Some other company.
T4A, sorry, T4A, T4A, not T4A. T4A and 1.
Clinically, can you say that it is T4B? So some features are there. Can you say it clinically? Basically, for T4B diagnosis, we need an imaging.
T4A.
No, but if clinically, can you say any label a patient as T4B? Any clinical features which you can?
As I told, like mandibular tenderness.
This is
No, like involvement of the skin erosion. And involvement of Christmas, the patient has.
no need to copy. No.
T4A.
I will look at Christmas.
No.
Based on mouth opening, there are 3 grades. If 3 fingers, that is 3.5, 2.5 to 3.5 or less than 1.5, 1.5 to 2.5, 2.5 to 3.5. We grade into grade 1, grade 2, grade 3. Or based on number of fingers that are accommodated, either 3 fingers or less.
When do you get Christmas?
Either due to pain, pain could be one reason. One more is due to mesenteric involvement or other muscles of mouth opening.
What are the muscles?
Medial temporal, lateral temporal, temporal.
Why do you think about it?
Temporal is in between, not different. Any other reason for
Involvement of TMJ.
this? Like you go there.
She had no.
Oral submucous fibrosis.
How do you palpate the mandible? We are likely to involve the mandible, no? How do you palpate them?
5 manual,
By manual. Put was your hand inside.
by digital.
By digital.
By digital.
What are the clinical signs of one involvement?
Mandibular tendon.
No, what to happen to the throat first? Is the patient mobile?
Fixed.
Did you check? Give check.
No, it was fixed.
No, you mentioned.
It was fixed.
Huh?
It was fixed.
Fixed to?
Uh, Fixed to underline.
No, what is underlying? So many questions you did not ask for. One answer.
Fixed to manual.
Fixed to the manual. Fixed. This growth is fixed to the manual.
Yes, sir, it was fixed to manual.
Fixed to the manual. Okay. What are the other signs of involvement on the board?
Mobility. Mobility was.
Okay. Yeah.
Tenderness.
And then that's. Yeah.
Clinically, like, environment of.
Now, what happened to the board? Can you get taken of the board? Yeah. Cortex involvement. Irregularity. Suppose it involves the entire cortex, what will happen to the matter?
There is a thinning of the mandible practice.
Huh? Thinning of
Break in
the.
the cortex.
What?
From this Windows 11 or what?
The thinning of the mandible
Windows 11,
later lead to
Desktop level.
like hairline fractures.
What is the fracture for? Suppose it goes tumor involvement and the fracture occurs.
This is yours also.
Pathological fracture.
Reduce it, T4 we committed T4 to reduce it.
Like T4B, when it involves the base of the terrified place, muscles of the mastication, then it is considered. And also skin.
What is the size of the lesion you said?
Sorry, it was 6 or 7.
What else you look for on palpation?
On palpation, I look for the tenderness.
That is
Then
it.
it fits into.
You say something which is very important. That 7 centimeter, that includes. Did you look for iteration around here?
Projected.
Around the surface, there was,
The project.
the introduction was restricted. That's the only.
That's all it extends, this iteration. Why is it important?
Margins, beyond the lining. Introduction, up to that.
And how much is here, this patient has got induration around the outside.
1 centimeter peripherally around.
You felt all around that.
All around the region.
What does it mean? Suppose induration is there.
It indicates that like that it is involved by the tumor.
Tumor infiltration, isn't it? Have you included that size?
That said, I am not. I mentioned that.
What are the lymph nodes?
Lymph node level 1A will be lymph node.
Right. Then, how will you describe the lymph nodes?
It was hard, discrete, and
Site, then? Site 1A and 1B. Right.
Site consistency.
No, you can find a what here.
And they forgot to put recording.
This
Yes.
patient had
But YouTube is recording.
Yes.
We can be
level 1A, 1B.
Today,
1 cross
then put up
centimeter.
video.
Discrete, hard lymph nodes she had. Hard non-tender.
Mobile fixed.
It was fixed.
No, lymph node is fixed.
Discrete mobile lymph nodes.
Mobile lymph nodes.
Your presentation is what number?
Single lymph node in 1A and 1B. Salivary gland.
We didn't,
To differentiate between submandibular salivary gland and the one B is the submandibular region, isn't it?
yes.
So when we record it, salivary gland can be.
Not if some really mobile, sir. Can bring it out of your.
Lymph node, I mean, salivary gland also mobile only. Why should it get fixed?
Bidigital palpation.
That's the answer.
Which is purple. Lymph node or salivary gland?
Gland is a
Huh?
salivary gland is bidigital.
Why it is purple inside the body?
Superficial and deep low. Lower.
Deep to flora of nose. Deep to myra. Minor hand.
The entire salivary gland is deep.
This was
Because
deep
it is-
low.
Superficial.
We should do this in the along with the. Your parents, if your parents will have to.
What are the gland is deep with So we are digitally, by digitally.
So coming to about this concurrent and the cervical spine is involved for the T stage.
What would you like to do? What would you like to do first? Management.
Next, I would do a.
The first routine pre-op workup of the patient, routine blood investigations. Then to confirm the diagnosis, I would like to do a punch biopsy from the patient. Then it's a peripheral part of the lesion, sir, which is absence of necrotic tissue from the edges of the tissue. Multiple biopsy till we know adequate bleeding from the lesion. Once to see, we want to see the histology criteria and based on percentage of keratin, if squamous cell carcinoma, based on the percentage of keratin pearls noted.
Not to look at the grade. These two things are important.
Then I would like to do an imaging to note the extent of the tumor, resectability, and also any bone involvement, and also signs of inoperability.
It's imaging.
For buccal mucosa, CT with puffed cheek.
Why is the concept important?
Because in this case it is involving the gingival-buccal sulcus, so it would be in contact with the alveolar ridges and hence
Proper delineation is possible.
What is the CT sensitivity here in the oral cavity or mandible marrow?
CT would not be able to pick up marrow involvement, but cortical.
Now compared to MRI, you're preferring CT. What is sensitivity of the CT scan compared to MRI? CT is preferred for the cortex, whatever the bone involvement. I'm asking the sensitivity of such a CT scan to ahead of this MRI. MRI for the marrow.
Before you go to biopsy, would you like to do any other investigation or examination?
Yes,
Oral carcinoma.
yes.
What is it?
Triple endoscopy to look for other synchronous lesions.
Sign endoscopy should be done, isn't it? Urology?
Other synchronous lesions.
You do the imaging before biopsy or after biopsy?
Before biopsy, we will do that.
Before biopsy. So what are the imaging, what imaging investigations you do this? What does CT you do before that? For bone involvement, what is it?
Ortho.
CT, apart from bone involvement, what else you do? No oral person.
Extent of the lesion.
Huh?
Extent of the lesion
Hmm.
in
Hmm.
then also notes of we can synchronous lesions,
Which are missed could be.
which are missed on pan endoscopy.
Then. What do you see the lymph nodes? Lymph nodes CT is better or MRI better?
CT.
CT. Yeah, so CT will tell you. What are the features of the secondary lymph node on CT? You
Loss
must
of
be able to make up. Huh?
loss of fatty head and increase in the size.
Basically. So depends on this. Even inflammatory you can do.
More than one.
More than one thing.
What are the
Surrounding.
no, CT finding. What are the CT finding? Tell you it's a second. You go contrast. So what you find? Yeah, one of the features is that this is secondary for any lesion, not only one carcinoma. Any lesion. Enhancing where? Which part of the gland?
Peripheral
Peripheral and central necrosis. And irregular. Regular. These are very good. What are characteristic features of a secondary? So CT can find out non-target which are secondary, apart from bone involvement can. Biopsy, any other important feature you would like to know apart from data? Prognostic.
Depth of invasion.
Yeah?
Depth of invasion.
Depth of invasion and depth of invasion from where?
From the basement.
Basement. So you have to take the entire full thickness and this will send that. Biopsy, what else you can make apart from data? Yeah, sending a big piece.
Histology, I had seen one, but
Can you make out lymphovascular? Huh?
No,
And neural.
perineural,
Important characters.
perineural.
you can achieve.
We must look for the biopsy. What is the common malignancy get? What type of person?
Pharmaceuticals.
Any other malignancy can occur with the biopsy? It can be psychiatric.
Melanoma.
Melanoma. Common than that.
Sarcomas.
So, all the best.
Adamantine.
Nice, okay. What does that? There are some of the glands are there in the
Salivary, minor salivary.
common.
Palate. Palate.
But it's not be surprised to people.
This is the CT image, which shows an ill-defined heterogeneous enhancing soft tissue lesion in the left buccal mucosa with involvement of the gingival buccal sulcus. It measures 1.7 cross 2.2 cross 1.3 centimeter. And the lesion is showing erosion and destruction of outer cortex of the left hemimandible. There is also a homogeneous enhancing lesion noted in the submental space, measuring 2 cross 1.5 centimeters, with lost fat planes of the right mylohyoid. Also, other homogeneously enhancing lesions noted in left level 1B and 2 nodes of SAD 6 mm.
Our diagnosis is carcinoma left gingival alveolar P2A M0 stage 4.
Metastatic imaging, what would you look for? Yeah, okay, fine. All right. So that's the standard that is required for this. Like you said, if there are lower lymph nodes below the level of the required, then probably even a CT chest. In a recurrent lesion, you would even do a PET, but otherwise chest X-ray is fine. So are we going to go ahead? You've got your diagnosis, you've staged your disease. What are you going to do? What's the management you're going to do? We're talking about inoperability. What would be some of the signs of inoperability in oral cancer? Probably not in this.
Presence of trismus.
Okay, that's just a clinical sign, but now we've gone through the radiology.
Vascular involvement.
So carotid. So one of the things is you just think about a tumor going backwards, upwards, and down. So back would be the prevertebral fascia, top would be the base of the skull, lateral would be the carotid, ends up in the carotids. And these are the general ones that we look. And the lesion that's too large going into the oropharynx. There's a concept of functional, basically, the more you resect, the more dysfunctional, the patient becomes. So you might even consider an elderly patient with oropharynx or patients going very posteriorly, you might even not consider doing so. But this one's more like an operable lesion. So what would be your answer? What would you do?
Three-dimensional wide local excision with a 1 centimeter margin. And since the patient has, I would like to do an FNAC of the nodes to confirm it will be malignant. If there's clinical node positivity, then I would do an ipsilateral MRND. And since there is cortical involvement, a segmental resection of the mandible with reconstruction.
Yes. Okay, I think that's fair enough. What about the contralateral nodes? This is a lesion that's from the pictures, you can see that it's kind of approaching the midline. So that's one thing you have to think about. About the primary, whether you will resect the bone. There are two reasons why you will resect bone. Can you tell what are the strategies of resecting bone? You said segmental. Is there any other strategy?
So if periosteum is just above it, then there is a role of excision with including the periosteum. If there is invasion,
it's called a marginal malablectomy. I think that's not required right now. That's probably not. But you should look at the opposite side neck. So that's one thing that you can look at in the gap. And then reconstruction as is, based on various factors.
The opposite, what you do? Opposite, when you almost the midline. Opposite is what you do.
Suprahomohyoid neck dissection could be done. Opposite side. For left side, MRND.
What type of MRI?
We would try for type 3, preserving all three.
What is type 2, type 1?
Type 1, we preserve only the spinal axillary nerve. Type 2, preserve spinal axillary nerve with IJV or sternocleidomastoid. Type 3, we preserve all three.
Planning the FNAC particle and all, because of our recent advances in the imaging, we can pinpoint metastatic nodes pretty well. And if there is local involvement in technical radiology, the risk of metastasis rises up to 60 to 70. So there is no need for targeting. There is no harm. Anyways, the next has to be addressed. Gustav, what are you going to do? So you have done your surgery. What are the things that you're going to take care of?
Okay, the histopathology, sir.
Can you tell me what are the indications for adjuvant radiotherapy and adjuvant chemo?
Lymphovascular inflammation.
You can start with tumor, start with the tumor things, then go to more, just go in some order. Right? That'll help you remember. So if you have PT3 or PT4, sometimes what is assessed as T2 might become T3. It's a combination of various strategies. So PT3, PT4, anything with a closed margin, which is defined as specified or a positive margin. Then if you have lymphovascular relation, the PNI. Nodal disease, you look at N2 and N3, N1 you may observe. So N2 and N3 definitely. And also, especially if the nodes are in the lower level nodes. These are high risk patients that go for adjuvant therapy. And adjuvant chemotherapy,
If there's extranodal extension,
and there's just one more. This is based on major big trials. It's the positive margins. And if you have external extension, you add on chemo again based on the performance factors. So you've done these things, you've advised these things. What else? Have you done? So you need to follow and you need to supervise abstinence or risk factors. Don't forget that abstinence from risk factors, getting them involved back into the social community. There's a lot of stigma associated with this disease. And a doctor's words go a long way into rehabilitating these patients. There are a lot of other issues with regards to swallowing and speech, which can be helped with therapy. Apart from all this, you will have to ask them to keep on a regular follow-up. So that's fine. 3 monthly or 6 monthly over the years. Extra nodal extension, what is the extension? N3B.
Yeah, it's there in the. What is the name of it?
Another important
What is the relax. I am very big, so it's different from the run around. You run around and do local. You go big.
Yes, you can self kind of with whatever surrounding.
composite flap would be needed since we are removing bone along with soft tissue. Free fibrillar graft would be considered.
Fully. My own infection. You are not mentally supposed to be salary. You can keep space because I will lose. This is a big point. I have learned this. Okay, now you be to
Thank you, sir. In our request,
Screen sharing stop.
award is a certificate of presentation.
even if I'm Korean, நீங்க யாரும் help பண்ணுங்க நான் எடுத்துக்கிறேன். இதுல oral cavity validation இருக்கு. Desktopல cover பண்ணுங்க.
I request Professor Dr. Krishnamurthy to come on to the dais to felicitate Dr. Robin Knight.
Oral malignancy JIPMER. Oh, now only to father again. Liar and cheat.
I had to buy it.
Yeah. Coming down. Technology.
Dr. Seth. Thank you, sir. I request Dr. Natarajan and Dr. Sethi to kindly remain on stage for the next talk. Now we have a guest lecture on the changing scenario of oral cancer management by Dr. Ranganath Ratnagiri. I request sir and the chairpersons, Dr. Ravishankar Pichai, Dr. Arun Peter, Dr. Natarajan, and Dr. Sethi to kindly come to the stage.
The pen drive has been stolen by one of the apps. It should be fine. One branch. This one.
Introducing the next speaker, Dr. Ranganath Ratnagiri. He's a surgical oncologist trained from India, with fellowship in head neck and skull base surgery from Dhaka Memorial, Bombay, and with a certificate course in endovascular surgery from the Institute. He's a very many publications in next journals and regular presented national conferences, and his special interest in breast oncology, hospital health, and university oncology. Over to you, sir.
My corporate. Six.
Yeah, check.
This is the one.
Good morning, everyone. For the last 45 minutes, I was really praying to God and thanking my stars that I was Dr. Smile postgraduate and not his examinee. I mean, really, the way he was examining, I was literally shaking in my pants. I've been asked to talk about the changing scenario in oral cancers. Now, I would request all the students here to take this as a subunit of whatever was discussed in the morning session. So combine the case presentation, the information you have got from the case presentation, the history examination, all the knowledge shared by the examiners. Combine that with whatever I'm going to say over the past 15 minutes, and you will, I hope, have a sort of comprehensive overview about what to talk about oral cancers, how to examine oral cancers, how to write a short note on oral cancers if asked in the exam. Why exactly do we talk about oral cancers, and why has it been the first case being discussed today? A huge range of cases in surgery, malignant, non-malignant. This is the reason why among all cancers, oral cancers form one of the most common cancers, not only in India, but the entire area of Southeast Asia. You look at this, the total number of new cases of cancer in India is about 13,24,000, and the number of deaths every year is around 8,51,000. The bulk of these cancers in males, the number one cancer in males, the single subside are the lip and the oral cavity. Very recently, last 2 years, breast cancer, the numbers have increased tremendously, and as a whole, breast cancer in males and females put together, it has become number one. But then what we need to realize is oral cancer is something which can be prevented. It is a completely tobacco dependent cancer for most of the patients. More than 40-50% of oral cancers are caused by tobacco. And therefore, this is something which is a very, very, very preventable cause of cancer death. When we speak about the oral cavity, I would take you through whatever subsections of oral cancer as it is. I will talk about what is the standard, what do we do routinely in the clinic, and I would also like to add, because my topic is about advances in oral cancer, I would like to add a few things about what else is going on in that particular area. Now, when we talk about the oral cavity, we have the American Joint Committee on Cancer. And this is technically, these are the subsites of the oral cavity. The oral cavity includes the upper and lower lip, the anterior 2/3 of the tongue, the floor of mouth, gingiva, upper and lower, the buccal mucosa, the retromolar trigone, and the hard palate. All right. So when we talk about, I don't know where the students are who are presenting the case. Are you guys here in the hall? Yeah. When you talk about clinical diagnosis, when you give a diagnosis, you actually say carcinoma of the lower alveolus or the carcinoma of the lower gingiva. How do you differentiate between the gingiva and the alveolus? When do you call it the gingiva and the alveolus? You call it the alveolus when there is a dentate mandible. When there is an edentulous mandible, the mucosa covering the mandible is the gingiva. So please never say in the exam, it is a carcinoma of the gingio-alveolar, whatever. Okay? Gingivo-alveolus is not a subset of the AJCC. It's either gingivum when there are no teeth, or if there is tooth and if you think it is coming from the bone, alveolus is fine. So that is one suggestion. You all know the TNM staging, the tumor node metastasis staging. Now, this is the tumor node metastasis staging. It goes through various iterations over 3 years, every 3 years, every 4 years, or every 5 years. There is a change in the TNM staging. And these changes occur because of newer knowledge coming in, newer research coming in. What is the latest TNM? What are the changes in the latest tumor node metastasis staging of oral cancer? In the T staging, we have included depth of invasion as a very, very important criteria. Now, clinically, it is very, very difficult to assess depth of a lesion. Most Indian patients, most Southeast Asian patients have this problem of trismus because of submucous fibrosis. So you are not able to bidigitally palpate a tumor. So the thickness of a lesion, very typically, when you talk about thickness of a lesion, it is easiest to clinically assess the thickness of a lesion only in two subsites, the tongue and the buccal mucosa. Now, the T staging, when it includes thickness, it has included criteria like less than 5 mm, 5 mm to 1 centimeter, more than 1 centimeter, more than 2 centimeters. So, clinically, and this is a clinical TNM staging. How do you assess whether it is less than 5 mm, less than 1 mm, less than 1 centimeter, more than 1 centimeter? The easiest way is to forget about this, forget about the numbers, just classify it as a thin lesion and a thick lesion. That's it. Any thin lesion, please consider it as less than 10 millimeter thickness. Any thick lesion, more than 1 centimeter thickness, depth of invasion, right? And the only way you can make out is you bidigitally palpate the tumor between your index finger and the thumb. And just beyond the edge of the tumor, if your index finger and the thumb approximate at the edge of the tumor, then it is not a thick lesion, it is a thin lesion. But at the edge of the tumor, if your index finger and the thumb are still separated, then you call it a thick lesion. That's it. That's the easiest way of assessing thickness of tumor. And that is what is recommended. That is practically the only way of telling it. We cannot measure 5 mm, 10 mm clinically. The second thing what we were discussing about, there was a problem with the staging in the previous case, T4A, T4B. T4A previously was skin, mandibular involvement and things like that. Now, in the latest AJCC 8, T4A is all moderately advanced disease. T4B is very advanced local disease. Essentially, what this means is the extent of surgery, the radicality of the surgery which we do has been going on increasing. So previously, what was considered inoperable, unresectable, we are able to resect now. And therefore, it has been, there is no, previously it was T4A operable, T4B inoperable. It's not like that anymore. So T4A is just moderately advanced, T4B is very advanced. For example, the most common cause of inoperability, local and regional inoperability in an oral cancer is involvement of the infratemporal fossa in tumors along the pterygoid muscles. So now that was considered to be completely inoperable. Nobody used to touch the case as a surgeon. But then people started going beyond whatever was the accepted boundary of surgery. And then they started doing surgery. They were able to do the surgery, get adequate margins, get negative margins. So even in the involvement of the infratemporal fossa, we have evolved into a classification called supra-notch infratemporal fossa involvement and infra-notch temporal fossa involvement. And this supra and infra-notch refers to the area between the condyle of the mandible and the coronoid process. That is called as a sigmoid notch. Any disease which is below the sigmoid notch of the mandible, that can still be resected with adequate margins. So previously that was considered unresectable, now it is resectable. Anything above the notch, it just goes and involves the skull-based pterygopalatine foramen and all the other major neurovascular structures there. Anything which goes above the supra notch is not resectable. A very important part of nodal staging which was changed is the addition of extranodal extension. Now, extranodal extension, even if it is a 2 centimeter node, if it has extranodal extension, it immediately goes to N3B, which is the last and ultimate stage in nodal staging. What is the significance? For us as students, for us as postgraduate students, it means that when you find a node, Sir was repeatedly asking, how do you describe a node? Any palpatory finding, any palpation of a swelling should start with temperature and tenderness. This is what has been drilled into us as students, as undergraduates, and as postgraduates right from the beginning in JIPMER. So when you have a node, you first describe the tenderness, the local rise of temperature, presence or absence, and then you go ahead to mobility, the consistency, and whether it is a single node or a matted node. Now, this mobility on clinical examination is what determines whether there is extranodal extension or not. If it is freely mobile, it may not be very freely mobile, but if it is freely mobile, then there is no extranodal extension. But if you find that there is restricted mobility, which is a term I use with a lot of fear in front of Dr. Jagdish, because he says either it is mobile or it is not mobile. There is no restricted mobility. Smiling. So if there is restricted mobility, then we consider it as a clinical indicator of extranodal extension. That has implications in nodal staging and also implications for further management. You were asked a lot of questions about pre-malignant lesions. The most common accepted pre-malignant lesions of the oral cavity right now are leukoplakia, erythroplakia, what we used to call varicose leukoplakia, but now it is called as proliferative varicose leukoplakia, lichen planus, and oral submucous fibrosis. These are the accepted pre-malignant lesions right now. Mucocutaneous candidiasis is considered to be not a defining pre-malignant lesion, but can be considered as an accessory condition which can be seen because of immunosuppression, which is caused by cancer and because of other conditions. What is advanced in this? There is a technical change of term. Most of these are not called pre-malignant lesions now. They are called oral potentially malignant disorders, because not all of them will progress to malignancy. About 20-25% of patients with any of these disorders will progress to malignancy. So they are called oral potentially malignant disorders. The labeling has changed. That's all. The standard of care, visual inspection, biopsy to establish the diagnosis was the standard of care. But the newer things to establish the diagnosis is the use of vital stains like toluidine blue and Lugol's iodine. You use them to stain the mucosa. The abnormal areas will get stained. The normal areas will not get stained. Sometimes you use acetic acid. The acetic acid, when you use acetic acid, especially on oral mucosa and cervical mucosa, the areas which remain pink are normal. The acetowhite areas, they are the abnormal areas. So when you have an entire oral mucosa where you don't know which of the areas are normal or abnormal, you can use any of these things to identify an area where you can, from where you can do a targeted biopsy, and that will help you in deciding management and treatment plan. The same way, another advance in the detection of these pre-malignant lesions is the use of autofluorescence and chemiluminescence. I don't know how many of you have heard in the olden days of something called a Woods lamp. These are advances on the Woods lamp. You shine an ultraviolet light of around 400 to 450 nanometers on what you think is abnormal mucosa, and if it fluoresces, then that particular area you can go in and do a targeted biopsy. It doesn't, the autofluorescence, obviously, you need a chemical, you need to inject some kind of a chemical, either indocyanine green or some other chemical, and then you use a light of the same frequency, near infrared spectrum, to look at areas which fluoresce under that particular light. So these are all extensions of the principles which we have learned in the past, and they have been modified to whatever equipment we have developed now. This is a new thing, been going on for a long time. Previously, saliva used to be looked at for exfoliative cytology, because squamous cell carcinoma, when it occurs in the oral cavity or in the penile region, the cells lose their intercellular adhesion and they easily exfoliate. Even in the cervix, for example, when we do a pap smear, that is what the pap smear is based on. It's based on exfoliative cytology. Previously, that was the only thing which we were using in saliva, but then we have a lot of biomarkers now. They will not only tell us whether there is any change occurring in the mucosal cells, but also exactly on this path of normal cells to dysplasia and malignancy on this path, how far these cells have gone. So these markers include IL-6, IL-8, TNF-alpha, and CD44. These are some of the markers which are validated. They look very good. Most of the numbers, even I don't remember, I have to look at it and then remember. Supposedly, there is a particular step in each pathway for which IL-6 is responsible. There is a step for which IL-8 is responsible, and that's how you decide whether it is normal mucosa, hyperplastic mucosa, or dysplastic mucosa. There are a lot of genetic markers being tested in saliva, but they have also not yet been validated so far. Liquid biopsy is the in thing in oncology in all cancers. He was talking about punch biopsy, taking a punch from the tumor and sending it for histopathological diagnosis. Now, this is good when you have a solid tumor. That is a standard way of establishing histopathological diagnosis. We don't plan any management. We don't talk about prognosis. We don't talk about staging unless you have a histopathological diagnosis. But then when we have in cancers where there is a lot of neoadjuvant therapy, preoperative therapy going on, and most of these cancers respond to therapy. At the end of this therapy, clinically and radiologically, there is no tumor. How do you know whether there is any tumor left in the body or not? There are a lot of imaging modalities available, but even they don't pick up once you clinically and radiologically you assess that there is nothing. How do you assess whether there are any tumor cells which have escaped whatever you are using to detect them? So liquid biopsy is that kind of modality. Liquid biopsy doesn't mean anything other than analysis of body fluids, saliva, urine, blood, whatever you want. And you look for fragments of tumor DNA. You know that squamous cell carcinoma of the oral cavity has some specific mutations, and those specific mutations can be identified by doing a genetic analysis. So you look for these particular mutations in ctDNA, which is circulating DNA, CF DNA, which is cell-free DNA. This when cells they break, the genetic material of the cancer cells go into the blood. So and miRNA and some exosomes are parts of these genes and chromosomes which are circulating in the blood. So you look at them, analyze them, search for them, and if you find them, you say that there is still residual disease, and we call it technically as a minimal residual disease. Now that's about pre-malignant lesions and advances in how to detect oral cancers. Now, once there is an oral cancer, how do you plan this management? The standard way of imaging an oral cancer, as Dr. Smile was telling, is an orthopantomogram. Most people, when clinically, if you know that there is loosening of teeth on history, there is widening of the mandible, or there is a pathological fracture, we can go ahead with a mandibular resection without even possibly an OPG. But then when you have a tumor in the sulcus, GB sulcus, or in the gingivolabial sulcus, and you need to know whether the mandible is involved or not, you need some kind of imaging to establish mandibular invasion. Now, conventionally, what we do is, I'll stop. Thank you. I'll just on to the neck to look at the nodes and an orthopantomogram to look at mandibular invasion. Now, mandibular invasion, the other investigations which can be used are a denta scan, which is essentially a CT scan with additional reformatted pictures to look for a subtler feature of mandibular invasion. Computed tomography and MRI. MRI will give us a better idea of marrow involvement of the mandible, and in addition, a perineural spread along the either the inferior alveolar nerves, or if you have an upper alveolar tumor, the perineural spread along the trigeminal or the mandibular branches or maxillary branches of the nerve to the skull base. PET-CT, not recommended. Just mentioning here because it is available. It is not at all recommended in oral cancers because remember, oral cancers 99% of the time have a local and regional spread. Very, very rarely they have a lung metastasis, which can be assessed by chest X-ray. Very rarely you will need a CT thorax. A CT thorax is useful or recommended officially only when you have a large volume supraclavicular nodal metastasis. Level 4, level 5, you have N2B or N3 nodal disease, then you are justified in asking for a computed tomogram of the thorax, but PET-CT not necessary for staging of a nodal cancer. I didn't listen to that guy when he said 2 minutes, so they stopped my PowerPoint.
No.
Yes.
Screen sharing.
Screenshot coming.
There has
Let's go on.
disconnect.
When we talk about surgery, we finished imaging and all that. When we talk about surgery for the primary, we talk about 3 things. Basically, assessment of margins and how much margin to give. Second, mandibular resection. And third is handling of the neck. Okay, these are the 3 things we talk about. So, margins for the primary, it's been a lot of debate. Right now, accepted margins are 1 centimeter and like beautifully put by them, 3-dimensional margins in 1 centimeter. But does 3-dimensional margins in 1 centimeter mean when you have a buccal mucosa lesion, you resect the skin and all the lesion and all the tumors? No, you don't need to. Okay, you don't need to do a full thickness resection of a buccal mucosa lesion along with the skin and make a big hole in the cheek. You don't need to do that. But then the third dimension, the depth of the tumor, the deeper margin, that should be microscopically free. All right. So that is what is important in margins. Very, very important 2 points here. Squamous cell carcinoma, the oral cavity is very notorious for submucosal spread. So whatever is a visible and palpable, visible extent of the tumor, there will be submucosal induration at least 5 millimeters to 1 centimeter beyond that. Look out for that on table. If required, go ahead and take a wider margin. All right. And if you have the facility, always do frozen section for all these cases. Do a frozen section for all the cases. Get yourself in the clear on table itself. You want extra margins, take extra margins. So another prerequisite of this is the person who resects should not be the person who reconstructs. Because if you resect and you reconstruct, whenever you're resecting, your brain will always be thinking about what kind of flap will I put there. The other important thing is about resection of the mandible. That is the most important thing. Maintains contour, gives support to the tongue, the floor of mouth, plays a very important role in speech, swallowing. So to resect it or not to resect it, and that's why we talked about imaging, about involvement of the mandible or not. Conventional or robotic, most cases, conventional, 99.9% conventional approach is the best. Also, transoral robotic surgery, very selected few early oropharyngeal cancers, you can do it. The problem with doing a transoral robotic surgery in India is the high incidence of submucous fibrosis. Most patients will have trismus, so will not be able to do that. As was being discussed, basically 2 main types of mandibular resections, a segmental mandibulectomy and a marginal mandibulectomy. A marginal mandibulectomy is done when there is no direct infiltration of the bone, all right, and Second criteria should be the residual mandible should be at least 1 centimeter in vertical height. Anything less than that, if you leave behind, with the force of mastication, the residual mandible will fracture. These are a few clinical photographs of intraoral listing. Evaluation is over, surgery is over. You resected and left a big defect in the oral cavity in the head and neck region. Reconstruction, the principles are, as far as possible, use like tissue to replace like. There is a reconstructive bladder used by all plastic surgeons. You can leave the raw area to heal by granulation. You can use split skin grafting. You can use a pedicle flap. You can use microvascular flap. Use whatever you have in your hands. Do the best job possible. That is what is recommended. The newer advances here are the use of 3D printing, not only for planning, but slowly we are getting materials which are biocompatible, and we can use these materials in the 3D printer, create a mandible, create a complex mandibular resection, create a facial-maxillary resection processes and put it in. But that is just starting. 3D printing for planning is very, very common in most centers. Most of us who do a lot of head and neck work, we use 3D printing as a prerequisite along with the other imaging modalities for planning our complex oral resections. This is a case where we have done an oral resection and put in a one. This lady has a radial forearm free flap, and the other person has a free fibula. N0 neck, comprehensive N0 neck, a selective neck dissection, sorry. Level 1, 2, 3 dissection, N plus, any N plus neck dissection. Instead of saying a modified radical neck dissection, I would have preferred if you had said a comprehensive neck dissection. So comprehensive neck dissection, the term includes the removal of 1, 2, 3, 4, 5 levels, irrespective of whether you remove the non-lymphatic structures, that is the sternomastoid, spinal axis arena, and the IJB. So that gives you a way out in the exam. You just say comprehensive neck dissection, levels 1, 2, 3, 4, 5. And N0 neck, you do a supraomoid dissection. What is new in addressing of the neck? In addressing the neck, sentinel lymph node biopsy. A lot of work is going on in sentinel lymph node biopsy in oral squamous cell cancers. It has not taken off, not become as popular as in breast, penis, and melanoma, partly because of 2 or 3 reasons. One, the number of skip metastases in oral cancers is very high. But neck nodal metastases in oral cancers do not follow a sequential pathway unlike breast or melanoma, number 1. Number 2, there is a shine-through phenomenon. The oral cancer, whenever you use a radioisotope colloid, the nodes are very close to the primary, so you will not be able to differentiate the radio activity of the primary, which will shine through onto the node. That is the second thing. And the third major thing is, most Indian surgeons are excellent surgeons of head and neck surgery. So there is absolutely, most people will not end up with any major morbidity after a neck dissection. So as N0 neck, level 1, 2, 3 dissection is still the gold standard. There is no morbidity for the patient at all. A few pictures of a neck dissection. Coming to the adjuvant therapy, this was not discussed. So the newer things in adjuvant therapy are the techniques to spare the parotid and the spinal cord, intensity modulated RT. There are radioprotective agents such as amipostin and mifenidazole, which are salivary protective agents. Immunotherapy in terms of addition of cetuximab to RT, and the use of preoperative chemotherapy. Rehabilitation plays a very important role. Talk about rehabilitation right from the first visit to the patient and keep talking about it throughout and throughout. Tobacco cessation is the most important point. Counseling, right from the first visit, you do an excellent surgery, do an excellent reconstruction, keep him under follow-up, give him adjuvant radiotherapy, adjuvant chemotherapy. But then if the patient doesn't stop taking tobacco, then there is no, absolutely all your efforts are futile. 2 major concepts, tapering of tobacco use versus cold turkey. Stop it all at once. Cold turkey works better. So what are we doing at NIMS right now? We are looking at 3 major projects in oral cancer. We are doing a project on immunohistochemistry for P53 at the resection margins. We are also doing looking at alterations in the copy number of the cyclin D1 gene in oral cancers. And we are also looking for P16 in saliva for human papillomavirus. All the new things are okay. But you remember phantom? There is an old jungle saying, and that always holds true, that prevention is always better than cure. Thank you, and sorry for taking, I think I took 10 minutes extra. Thank you. Any questions? Good morning. Sir, can you please elaborate about current concepts of neoadjuvant chemotherapy and response assessment in oral cavity melanoma? Chemotherapy has a role only in those patients who are considered to be borderline resectable, in the sense that you will not suggest any preoperative chemotherapy for patients where you know you will get a negative margin, where R0 resection is possible. Wherever tumors are there, where you think surgically you will not be able to achieve negative margins, one way of going about it is give chemotherapy. Now, there are trials called the TAX 234 trial, which has used taxanes, cisplatin, and flyfluorouracil, a 3-agent regimen, okay, in patients of borderline resectable oral cancers, and they have shown a 25 to 30% response rate. The problem with this is the number of chemotherapeutic agents, when you increase the toxicity of the regimen increases. Most of these oral cancer patients in India are already malnourished. They are not able to take orally. Most of them are not able to complete the entire course of neoadjuvant chemotherapy. So what actually happens is, when we start off with a good intent, the patient drops out of the chemotherapy regimen, number one, or the disease progresses. All right. Disease assessment is very, very easy in oral cancer. It is just by clinical examination. Very few, only 10 to 11% of patients will have a complete response. 90% will have either a partial regression or a stable disease. Thank you. Thank you.
Thank you, sir. I now request the chairpersons to felicitate Dr. Ranganath Ratnagiri. I request Professor Dr. Robinson Smile to felicitate the chairpersons. Dr. Ravi Shankar Pichaya. Dr. Arun Peter. Thank you, sir. I request Dr. Ravi Shankar Pichai to remain on to the dais. Next, we have a guest lecture on a very pertinent theme: mastectomy or BCS for breast cancer, making a rational choice, by Dr. Ankit Jain. And I request the chairpersons for the lecture, Dr. Kadambari, Dr. Ramya, and Dr. Ravi Shankar Pichai on the dais.
How to take it full screen now?
Good morning to ma'am and everyone. First of all, I would like to thank you, Dr. Vishnu Prasad, Dr. Kadambari ma'am, and also Nagin team to give me this opportunity. The topic of the today's talk is mastectomy or BCS of breast cancer. How to make a rational choice between the two. I am working in Unit 5 under Dr. Kadambari in Unit of Breast Surgery, Department of Surgery.
Screen how to make it bigger. I should you from big, not view. Yeah. Full screen. Okay, I'll sign off. That
What we are going to discuss today is, can we offer breast conservation treatment for a patient? If we can, why should we offer to a patient? And once we are sure that we can offer that choice, how to decide whom we can offer this choice? And how to expand our indications, or how to expand the patients which can be included in this criteria for breast conservation treatment. So first question to ponder is, can we offer breast conservation therapy?
make it better.
This is based on the dictum, like there is an equivalence in the terms of disease outcome when we talk about breast conservation therapy or mastectomy. And these are the two meta-analysis of systemic review. One was done in 1995 for a 10-year survival data, and another was done in 1987. So these included trials which had a 10-year data previous to that. So breast conservation therapy is in the scenario for since 1980s and before that. And in 1995 itself, it was proven like local recurrence rate may be little higher, but overall survival is not difference between the two.
This sir is not.
Then the scenario changed to the current that people continue to carry out further randomized control trial. And we have come to a situation, then we have found like actually the disease outcomes are better for breast conservation therapy. It's not no longer we say like outcome or survival is similar. The outcome in the sense like disease specific survival or overall survival is better for patients who undergo breast conservation therapy as compared to mastectomy. These are the two randomized control trial, and these are dated, one is dated in 2020, other is dated in 2005. This is the other one. This was done in from 1999 to 2008, and the other one which shows like in early breast cancer, the both are similar. And this is the recent one which was done, and it has shown like not even in early breast cancer, if we give a neoadjuvant therapy to control downstage the tumor, the overall survival and disease specific survival is similar between breast conservation therapy as well as mastectomy. So better survival has been proven or seen from breast conservation therapy, irrespective of age and menopausal status of the patient, tumor size and nodal stasis as well as TNM stage, phenotype of the tumor, grade of the tumor, hormonal status, whether the tumor is screen detected as is common in Western countries, or palpable tumors like in our countries, or whether we do upfront or neoadjuvant. The last one is still in the stage of saying like equivalent, but other points have been proven to be better survival in breast conservation therapy. Now, how survival changed for the breast cancer, which have led to all this result and caused the surgical de-escalation. Surgical de-escalation, we mean like initially there was an era when we were talking about radical mastectomy, extended radical mastectomy, and now we have come to a stage where we are talking about only a breast conservation type of thing. So this surgical de-escalation was possible due to change in the adjuvant therapy. There has been addition of the radiotherapy and the modification in the techniques and dosing of radiotherapy. There has been introduction of different hormone therapy, drugs like aromatase inhibitors, different durations of the drugs used. HER2/neu was identified, its therapy was available, and it has become quite easily and cheaply available. As well as there has been an improvement in the imaging technology as well as the surgeon's experience. Not all, even the radiologists, even the surgeons are more experienced in now doing themselves and reading the scans. And all these has helped us in de-escalating the surgery from the radical to a more conservative approach. Once we have seen like the results are similar, now the question comes, should we offer breast conservation therapy or not? And this can only be answered because we have already talked about the oncological outcome. Let's talk about the social or the physiological aspect of the surgery. These are the studies which date as back as 1990s and 2000, where it was proven like mastectomy causes more social and physical distress, more problems with the sexual relations, self-body conscious image. It hampers with the daily, how the patient views herself on the daily basis. And it has an overall effect on her daily life. Even with the mastectomy and the reconstruction, the breast conservation therapy is better option as compared to a reconstruction. As well as this meta-analysis, it shows complications like lymphedema is also less in patients who undergo mastectomy as patients who undergo breast conservation therapy as compared to BCS. So BCS versus mastectomy, the inference can be made is like the mastectomy has twice the rate of complication, which leads to sometimes delay in the adjuvant treatment. Whereas with BCS, the delay is seen less common as compared to mastectomy. With mastectomy, generally people will opt for reconstruction, which turns out to be a more costly option as compared to a BCS thing. As we have already talked, better survival is there in early breast cancer, and equivalent survival has been there in patients who are undergoing neoadjuvant therapy. And overall, the effect on cost versus quality of life, body image issues, psychosocial thing, personal feeling, and all is better with breast conservation therapy as compared to mastectomy. So all these points answer the question whether we should offer BCS or not to a patient. Now the question comes like, we are sure we should offer the BCS to a patient. Whom we should offer this BCS therapy to the, which are the patient we can offer this? This question takes me back to my residency days when the questions was asked to us in the exam, tell us the indication of BCS. We used to enumerate 3-4 points, and beyond that the answer would have been mastectomy. But now when we see a patient, the first thing which should come to our mind is, can this patient qualify for BCS? And we start enumerating the contraindications. So the first indication you see for a breast cancer patient is, can this patient fits into our BCS algorithm? T1 and T3, upfront, if possible, no contraindication, should go for BCS. Contraindication to BCS, the first one can be poor cosmetic outcome, which is generally due to tumor size. There is nothing like stage wise. If the tumor is bigger than the breast size, it will cause some poor cosmetic outcome. If the tumor is involving more than one quadrant of the breast, if you find multiple areas of microcalcification and mammography, which will lead to a wide excision, again causing poor cosmetic outcome. You find diffusely positive pathologic margins on your biopsy. Recurrence is there after once a patient has undergone BCS and comes back to you with recurrence. Once a patient undergoes BCT, RT is generally mandatory. So whether the patient will be able to undergo RT or not, and patient preference for mastectomy. These are the contraindications which we think about while we see a patient. And for a T4B patient also, with a limited kind of disease, we can consider for BCS once the patient undergoes neoadjuvant therapy. So once the patient passes the criteria for contraindication, then he or she should definitely go for BCS. Otherwise, the only indication is once she does not qualify for BCS, she can go for mastectomy. These are the contraindications which we talked about. Poor cosmetic outcome, tumor size is relatively large to breast size. To bring it within the cosmetic parameter, we have an option of giving NSCT. Downstage the tumor may become reasonable good smaller in size as compared to breast size, and patient can undergo breast conservation therapy. The other problem is multicentric disease and diffuse suspicious microcal, which may not, even after NSCT, make it possible to do a small kind of excision. This can be solved by offering oncoplastic surgery to the patient. So the first 3 contraindications are bypassed now. They are no more a contraindication by the use of neoadjuvant chemotherapy and oncoplastic surgery. The only contraindication which we have to follow now is Once the patient is contraindicated for RT, we can't offer BCS to her. Pregnancy is not as such a contraindication for RT if you can plan the surgery in a way that patient will go for RT post delivery. Otherwise, it's a contraindication. Diffusely positive pathologic margins, you have to do mastectomy. And patient preference for mastectomy is a question which is can create a lots of further questions, because first of all, it depends how we counsel the patient, what is the social background of the patient, who is the decision maker, financial issues for the patient and other things. But keeping that in mind, diffusely positive pathologic margin and contraindication for RT are the only contraindication to BCS in a proper sense. The other has been bypassed using NSCT and oncoplastic surgery. So the question comes, everyone knows what is neoadjuvant chemotherapy. What exactly is oncoplastic surgery? As the name contains, it's a combination of oncologic as well as plastic surgery. We are trying to resect oncology with the proper oncological outcome, and we try to create a proper cosmetic outcome using plastic surgery. This is the surgeon. He's still living. He's a German surgeon. He coined this term, Professor Werner Odrich. The oncoplastic surgery was the term given by him, but the definition of oncoplastic surgery which we follow is given by American Society of Breast Surgeons, which is oncologic resection following the oncological principles, combined with reconstruction of the breast for a proper cosmetic outcome, and contralateral symmetrization procedure. The last thing is not so easy in our countries. Even the countries, surgeons who come from the outside, they are struggling to counsel the patient for this. In our country, many centers have not started doing this, and the centers who are doing this, they have felt lots of resistance, because obviously patients don't want to touch the breast which is not affected. Type of oncoplasty are generally three: level 1, level 2, level 3. Level 1, when we excise less than 20%. When we excise more than 20 to 50% is level 2. Less than 20% can be simply managed with local tissue arrangement, whereas more than 20 to 50% section of breast parenchyma needs some reconstruction by mobilizing of the tissue. Therefore, mobilization of the fatty tissue can get devascularized. Level 1 cannot be done in a breast which is mainly fatty. It is reserved for a dense breast with less than 20%. Whereas if a fatty breast needs reconstruction or a dense breast needs reconstruction for more than 20% loss, then we have to go with level 2 design. If you need to excise skin, then also it goes to the level 2 design. So why oncoplasty can be preferred over BCS? First of all, it extends the horizon of breast conservation therapy. The patients like multicentric disease, diffusely positive microcal, patients who are not responding to NSCT or partially responding can be taken up for this after multidisciplinary team meeting. It takes away the need for secondary correction, which can be there seen after BCT. BCT patients receive radiotherapy, and many times scarring and other things happen, which affect the cosmesis, and patient go for later reconstruction. Therefore, the upfront surgery is found to be better both in cosmetic, oncologic, as well as cost effective. And this is the paper by Krishna sir. This is read by most of the people who are doing oncoplasty. It's classified the oncoplastic procedure according to quadrant by quadrant. Many of the procedures have come, but still this paper holds true for most of the quadrant surgeries which people think of when they see a patient. In our department, in last 1 year, we have done around 50 procedures. The further data is supposed to come, like over the 1 year, we are just following up, they are undergoing radiotherapy and all. These are the immediate procedure images for those patients. This patient had an incision tumor over the 12 area. Since the breast volume was too much and we are not starting doing reduction procedures, we did the procedure by doing a simple incision over the breast tumor and removed it post NSCT. This is the patient. We have given a perianal incision and raised the plane and removed the breast tissue and approximated the breast fillers. This is the patient. For proper cosmesis, we have done a perianal dissection, and you can see the outcome is very good. And I can see the tears in the patient's eyes when she was discharged. Sometimes we have to resect the skin of the breast. So this is the crescent maxopexy. This is the hemi-bat wing for lateral extension, and this is the bat wing for bilateral extension. This is the S-shape incision because we try to avoid the giving incision over the breast parenchyma. We try to follow the hidden areas. Sometimes for central area tumors, we can do central cordectomy. In this patient, it came out well, but generally it may not come out well. So in that case, we can do something like Grisoti, and we can reconstruct the nipple area later over that. Lateral mammoplasty for the lateral tumors, the outer bulge is well maintained other than little deformity in the lower quadrant. This is another patient who was very happy after surgery. There was a tumor just at the 6 o'clock. You can see the dimpling. With the option of mastectomy, it would have been very bad for her. This is her post-op images. This is a post-op image, and this is the standing view. The breast contour is well maintained. And this is another patient. She had a long tumor microcal area along the whole lower outer quadrant, which would have required a wide local excision, which would have caused a lot of deformity or a mastectomy. We resected it and reconstructed with the local flap. And this is the post-op well-maintained contour for the other side breast. Is there a learning curve for BCS? This question, I could not find much studies on it. The only thing which can indirectly answer is this study. This was done where the surgeons have assisted their juniors resident, not the other way around. And they have classified surgeries based on different level who has done the surgery and assisted the main surgeon. And equivalent outcome has been seen by the main surgeon and the resident. So even if the residents are doing the oncological outcomes are not affected. So we can say that learning curve is not too steep for the breast conservation surgery. At the end, is there some point for us to ponder? Giving patient a choice of treatment indicate that two choices are equal. Increasing evidence indicates that BCT is a superior option for patients with early operable breast cancer, and that patients treated by BCT have better outcomes. So then should we say like we can offer the choice to a patient for mastectomy? This is not my statement. It's a statement by this review article by Dixon sir. And it's a nice article. You can read it. It simply says like when the options are not similar, then how can we say to the patient like you can go for one of the E? Thank you.
So it's a nice talk. So I have a couple of observations which I faced outside JIPMER. So the problem, I just want to ahead. So the problem of what we face with the choices of mastectomy and breast conservation is the mass mentality. So the problem with that, the people who have breast cancer, they go and have somehow get connections with the other breast cancer patients. Definitely, 9 out of 10 people who have definitely undergone the mastectomy, and we convince them, and they go back and come back with the result that they want mastectomy one. And second is that the variation, availability of variation is what those are the two practical challenges we face. I mean, that outside Japan, but that's my.
So like for us also that counseling is always an issue. Always 1 out of the 10 patients will say they don't want BCS. In that case, Kalamri ma'am will counsel them again. If that also they don't agree, then we generally have to go for mastectomy. And for radiation, I will say there is a saying Western people say that, or we say that number is our strength and number is our failure. So what I have observed is because of high number, our biopsy report comes late. And by the time the biopsy report comes and everything happens, the radiation date is generally given and radiation starts. So I will not say it will start within 1 month or 2 months, but within 3 months we are able to start. Sometimes we are able to start before that also, but at least for BCS we are able to start like within the reasonable time.
I'm doing this onchoplasty for the last 4 years. What I observe, people actually prefer onchoplastic than BCS. If we tell that BCS, there might be some cosmetic thing, but if we tell the onchoplasty, the cosmetic outcomes are better. people who are illegal breast conservation, they prefer orthostatic vote and that.
We also tend to do that, sir, but like one photo I showed, she was a bulky female. And since we can't do a reduction and if we have done an oncoplasty, lots of issue could have happened. So we gave an incident directly of that tumor and removed it. Otherwise, Kadamri ma'am's protocol is like we don't follow the giving tumor incident over that tumor.
It's like not my important.
How we used to do, of course, I just started to practice and I don't have patients who have years of follow-up, but what we used to do back in the training time is, I would tell the patients that when they are initially diagnosed with malignancy, they'll be in a shock. So for them, they think that if I get rid of this tumor or cancer, I'll be free. So at that time, they might decide to contact you. But when they start living more and more and they come to follow-up, say 3 years, 5 years, that is when they start looking at patients who undergone BCS, they regret it. So I tell this to patients when we are offering that you may think like this right now, but later you might regret it. So that is one thing I tell. Other thing that I tell the patients to come to them is if we have a ulcer or a tumor in the finger at the tip, you won't amputate the whole finger, right? This is an important organ. Every organ is important in the body, so that's how I tell couple points to come to them.
And actually, the issue is in our patients, the decision maker is only husband. So I once gave husband this example, like if tumor is on the penis, I will save half your penis. Will you want that or you want whole penis removal? But still, he told you remove whole best of my wife. I don't care for that. So that kind of mentality we still have to. And the decision maker is not the one man who is going to suffer. So that kind of thing is also there.
One question for you. You showed a lot of publications for the paper of PG here. Can you explain what is the hypothesis behind better survival outcomes because of radiation? You listed a few things, better radiation, I mean, the chemotherapy and adjuvant hormonal agents. So what do they hypothesize for this statement that there are better outcomes with BCS compared?
And like one hypothesis, like even if you do mastectomy, people have done the biopsy of the skin and they found like some amount of breast fat tissues still remaining. So mastectomy without radiotherapy is inferior with doing only mastectomy. With BCS, one benefit is we are doing radiotherapy for sure. So that takes care of the rest of the breast parenchyma. And second thing is de-escalation is happened, as ma'am is saying, because of the addition of adjuvant therapy. So lots of this Bernard Fisher has proposed. Initially, Halstead had told like breast is a local disease. Fisher proposed no, it's not a local disease, it's a systemic disease. So systemic treatment has to have take part, and that has we have advanced a lot, but I hope we'll advance further. But because of that advancement, that systemic disease being taken care. So basically, mainly because of combined effect of these like BCS outcome.
How do you what extent counseling and how do you counsel it?
It's my gray hair which makes a difference. Because they want a senior person who they believe has more experience and is able to convince them that the outcome is going to be equivalent. Because that is the beauty of our patients in our country. They think we are God. So the more experience you have, the more they. I don't do any further.
So like we have a 3 level of counseling. I am not a Tamilian, so I don't know Tamil. If I am able to convince, that is half job done. Then comes the resident who are somewhat proficient in Tamil. If they fail, then hardly post to Tamil. So like this 3 level of thing hardly fails. Like I said, only 1 out of 10. Only that also because maybe monetary or other things. Otherwise, only with this 3 tier kind of things we are following, it works.
What do you want to say? Mic is on. Oh, that's great.
Since we are talking about counseling, there are 2 myths as all of them have told. And we are telling patients about breast conservation surgery. One thing is that they feel that the breast, once you have completed your family, once you have breastfed the children, it is a very dispensable organ. Once the breast is diseased with cancer, most patients feel that the best way of getting rid of it is getting rid of the entire organ. That is one myth. The second myth, which is very, very, very common, throughout the country is that you remove the entire breast, the cancer will not come back at all. That is the major beliefs which they have. If they have, that is the major thought block which they have. So the way to deal with it is we have gray hair like man. That's the best way. The other way, where you have very gray hair like me, is to talk to them scientifically. Throughout southern India and western India, people, irrespective of where they go, whichever hospital they go, they are educated, at least up to the 10th. So you tell them scientifically, whatever surgery I am going to do, it is not going to affect your survival. It is not going to affect the chances of recurrence. I remove the breast. If it is written on your forehead that it will recur. If I preserve your breast, if it is written that it will not recur, it will not recur. So once you tell them that the scientific basis of your surgery is not preventing recurrence, but it is for staging and for prognostication, they understand and they will come. In spite of these two things, if they insist on mastectomy, don't force them. Don't ever force them to go in for a conservation. It's their choice, leave it. Patient is prime. And one more point. For the students, along with the breast, always axilla has to be staged. So whenever you are doing an upfront breast surgery, if it is a node negative axilla, the gold standard is sentinel from biopsy. If it is a node positive axilla, either upfront or post neoadjuvant therapy, the standard of care is level 1, level 2 axillary dissection. Level 2, if you find palpable lymph nodes, go ahead and do a level 3 dissection. That's it. Thank you. Yes, thank you.
Sir, I now request the chairpersons to felicitate Dr. Ankit Jain.
That is correct. Yes,
To felicitate the chairperson.
പുട്ടെല്ലാം എടുക്കല്ല obviously people will know their own people. No, I've seen her because she'll be fine with all these breast.
Thank you, sirs and ma'am. Now we shall have a short tea break. Tea is being served at yoga hall in the same floor. I request everyone to leave the
I don't can get whatever we want.
Whose thing is this? Father sir is presenting us. I wanted to like
Next up, what is the thing? Like, what does it say? JSU thyroid. JSU thyroid. You can give it in 11. This JSU thyroid is the next presentation. You'll load it. Copies it. You're not much. You'll copy and give it back. Right? Just go there. Loading. He gave in the pen. Have the group speed. I shall stop recording.
We have the program with you.
I have a soft copy. So
I'm giving a lecture. I forgot to talk. Instead of giving a lecture, I'm tired of it. Then I just back.
You're the only one. You're comfortable.
What?
Next 2 days presentation.
Oh, but I want to do for my laptop.
You can arrange. Do you have Zoom on your laptop, sir?
What?
Do you have Zoom, sir?
I think so.
அதை டவுன்லோட் பண்ணிருக்கீங்கன்னா உங்களுக்கு ஜாயின் பண்ணதுக்கு அப்புறம் ஸ்கிரீன் ஷேர் பண்ணலாம்ல
இல்ல நான் என் லேப்டாப்ல இருந்து பேசுறேன்.
ஆமா அது
இல்ல I always talk with my laptop.
So why who's watching on?
No, no.
they may not come here. அது ஸ்கிரீன் ஷேர் பண்ணியாதான் இங்க வரும் சார்.
Okay.
டெலிகாஸ்ட் ஆகணும்னா அது
எங்க
பாட்டுக்கு
டெலிகாஸ்ட் பண்றீங்க நீங்க?
யூடியூப்
No, we are recording for
everything is
data.
நம்ம டெக்னாலஜி எல்லாம் நம்மளுக்கு ரொம்ப லிமிட்டடா இருக்கு இப்போ.
Sir, you just open and give it to them. They
Your talk was good. Really good talk. இல்ல I always do for my laptop.
No problem. We'll get that done. It's go download பண்ணிட்டு
இல்ல இல்ல Zoom is here. I think I have Zoom somewhere because I give a lot of.
we just have to connect everything to that.
Yeah,
Sir,
Zoom
it wants to present from
No, I want to present for my laptop.
Okay, we just keep laptop. What you connect there? Zoom to why is it?
why?
He has it down. We simply need to replace the laptop.
That is fine.
No, but I would like to do it from my laptop.
You don't have to do anything. We'll just log in. So nothing else. No need to do anything. So your session is after tea break, sir.
Yeah.
Okay, ma'am. We'll done. He wants to present from his app, or just log in from there and we'll just connect. Just join.
Apna,
He has the Zoom down.
I think yes, I have the Zoom.
No, sir, it's safe. Join a meeting.
Join meeting.
English means
ID சொல்லுங்க.
here.
சொல்லுங்க அப்படியே.
939. 939.
Why you are putting in YouTube?
So because other people are there, you are not
Where?
able to come.
Oh, 939
3447.
3 Last year you didn't do this
No, sir, it's double
393.
thing. Oh, you have to slight.
Right. You have videos and all. Sir.
Huh?
You don't have videos. Videos and all.
I don't have video.
Guess Wi-Fi password. Guess Wi-Fi password.
We forgot, you know.
One. So you go.
No, I'm not going to go for you. I just now came. You only have to go. You did work, you have to.
This one.
Yeah. I am going
This is more complicated than the lecture. You have the tuber.
Anything is capital.
Hello, bro.
All small.
All small letter. JSU 2023 star. No, not guest Wi-Fi, sir. JIPMER surgery update, sir. Guest Wi-Fi. Sir, JSU 2023 star, sir.
Otherwise, take my lecture out of YouTube. I just present from here and go.
No, sir, it will work.
No, this is minimum.
Nine, three.
939. 3447. 3393.
No. Just 15.
You have to check those. You have to check.
Got it. Now, no, it's closing it. Maybe. Slide. Yes.
Share screen. Share enables,
Huh?
enable sounds. No, sound is not there. Okay.
But anyway, no,
Anyway,
no
enable
audio,
sound.
anyway, no. No.
Share sound. Share.
Yeah, where's the desktop?
Yeah.
Yeah,
You're on screen.
okay, but I, yeah. It's like,
Close this video panel.
huh?
Video panel, you can close the whole video panel from here itself. Come here. More, go more. Hide video panel. Yes.
But I think it's case discussion first, so let it get charged.
Okay. No.
Yeah, thank you.
We'll
Thank
keep
you.
it.
Yeah, enjoyed it.
Yeah, thyroid. You know. Copy it. Can you see it? Once again, this.
Somebody's on.
Check that. I want to check later. So you can directly connect the.
Yes. You just need to Wi-Fi you can connect. This Wi-Fi. I have seen.
Where is it saved? You can take.
It's not saved in the folder, it's saved in the main.
Yeah, we have to copy. Yes, I got one smart print 64 as a printer. Oh, you want something?
One more, just a quick fix. Can I give the lecture first and then the case presentation because it's loaded? It's easier. It's the same, because the same team is only going to be there.
Sure, okay.
Can be done.
So after lecture.
So it's just the thought which came in as. Because anyway, after the case, it's going to be the same team anyway.
Yes.
Don't mind, sir?
No, sir.
Ah. Anyway, I don't mind because I don't mind anything.
It's the next year.
And anyway, it's not related. Usually you keep the case presenting on lecture related.
Usually post lunch goes this is the case. So one case starts.
They'll like it. Now, this can be YouTube video.
I have to go via my. You can put my
and diet habits and no loss of appetite. There is no reported history of any allergies, and she consumes a mixed diet with no excessive cabbage or cassava intake. Cassava intake, I'm sorry. So moving on to the summary, 16.
Before that, are we allowed to? The first. In the history, can you just go back few slides, Mark? Sir, next one. Why did you ask for history of difficulty breathing, swallowing, alteration of hoarseness of voice, history of aspiration?
So for to elicit the pressure symptoms, so hoarseness.
Exactly. I would want you to say no history of pressure symptoms. See, when you give a negative history, you don't need to be elaborate of the negative history. You should ask the patient history. But when you say to the examiner, you will just say no history of pressure symptoms. Okay. Anyway, aspiration is not an example of pressure symptom, but all the others is the history of pressure symptoms. Next slide. Again. Once again, you said history of tremor, muscle weakness, double vision, palpitation. I would request you to say no history suggestive of toxic symptoms. Okay. And you don't need to say this is cardiovascular symptoms. This is so I would just request you to say no history of toxic symptoms. If I remember right, you also said that with regard to history regarding family and neighbors. I know what you are trying to say, endemicity, but that doesn't mean just asking the neighbors alone. So I think that I would just leave that aside. I'm sorry.
How do you ask for symptoms of difficulty in breathing? Like when you ask the patient, what questions do you ask?
While trying to elicit history of difficulty in breathing, we try to assess like what physical activity is she feeling difficulty in breathing. If there is any difficulty in breathing associated with difficulty in swallowing the mucus, that are something you can also prevent that difficulty in breathing.
Usually,
Yeah.
when we ask patient if there is breathlessness on lying down, but we.
Yeah. So what we are looking at is the goiter. Give this the trachea. So they have obstructive symptoms when the weight. Suppose you're sleeping supine, which may have difficulty in breathing. Sometimes in certain cases they may just keep having some kind of cough. So that is also a pressure on trachea. And even earlier, patients can feel air hunger in closed spaces or in closed cars. That is also one of, or recent onset snoring. So that could also be a pressure on the trachea.
What is the endemic goiter? What is the endemic goiter? If you have 4 or 5 person in the locality, do you call it as endemic? When do you call it as endemic goiter?
When the levels of the goiter are not when is the basal level of
It is more than 10% of the population. Yes, yes. And you asked about diet history that Brassica family. Why it causes goiter? Cabbage and all this. Yes, no?
Yes, sir.
Why it causes?
So it has certain chemicals like perchlorate levels and thiocyanate levels.
Thiocyanate, yes, yes. Yeah. Thiocyanate that acts like antithyroid. Okay. That's the reason, yeah.
You said the patient is a hypertensive and is on anti-hypertensive medications. But I think I remember seeing somewhere there is no history of cardiac illness or something. So I think they are contradictory. Just correct me if I'm wrong. Just go through the slides. Am I right?
Yes.
Yeah. So I think hypertension is a cardiac disorder, cardiovascular disorder. So when a patient is a hypertensive, you will not say that the patient doesn't have any cardiac. Okay. These are small things. We are allowed to make mistakes here. So don't feel shy. We all make mistakes.
So family history, in case of goiters, it need not necessarily be for goiters. But the most common thyroid disease is hypothyroidism. So in the same family, some of them may have goiters, some of them may have hypothyroidism, some of them really hyper also. But any thyroid related disease you can mention.
Why did you ask for no history of bone pain, fractures, and chest pain?
So since it's a long-standing goiter, there's a chance that there might be, and she lives from the hilly region, so there might be malignant transformation of the goiter into follicular thyroid carcinoma.
Yeah.
And that will have cultural bony metastasis to the family and might have pathological fracture.
Why do you have chest pain then?
The chest pain,
You mean fracture ribs then?
no, sir, chest pain, metastasis to the lungs in case of, in the case of papillary carcinoma.
I wouldn't go too extensively there like that, because then you have to start asking about everything in the world. I would just say for thyroid, history suggests of toxic symptoms, history suggests of pressure symptoms, then little bit about medication, what medication, little bit of family, any family history of thyroid problems. It can be just hypothyroidism, it could be goiter, or somebody in the family would have thyroidectomy. These are the relevant things which you have to tell the examiner. You might ask any number of things, but this is what pressure symptoms, toxic symptoms, medication history, family history of hypothyroidism or goiter or thyroidectomy or any malignancy for that matter. These are very important. Okay.
11% weight loss over 1 year. So do you think that is significant, and how do you think thyroid disease can affect weight? Ma'am, hyperthyroidism can lead to weight loss, and this is not a significant weight loss. For the weight loss to be significant, there has to be 10% in 6 months or 5% in 3 months. But since she does not have serial weight recordings, she only has weight recording of the last 1 year. So I felt it would, that's why I mentioned, how is appetite and weight related? I mean, in hyperthyroidism, what do we generally see? Because in other malignancies, we know that there will be loss of appetite or something like that. In thyroid, how is it different? In hyperthyroidism, especially.
Weight loss in the setting of increase in appetite.
Like, patient's appetite, increase appetite, but still they're having, despite that, weight loss.
When you are thinking in terms of increased appetite and weight loss, not only your toxicosis, you have to remember, you have to also think in terms of diabetes mellitus. These are two conditions where your appetite is increased, but you may end up losing weight. Okay? Carry on, please. Getting late for your exam.
So, my differential diagnosis will be benign thyroid swelling. On the basis of the history.
Moving on to the
Why do you say first benign thyroid swelling?
So benign or first of all, there is no there's a chronic
Malignancy of the thyroid may not present with hoarseness. Many malignancies of the thyroid can present without hoarseness. So that is not to say that it's benign. Long duration, number one. First of all, you will not say it is benign thyroid swelling. You will say it's a goiter and then start off with, first of all, it's not a, it's just, okay. You will not come to the conclusion with the history alone that this is a benign thyroid swelling. You will come to a conclusion at the end. See, you got me wrong already. Yeah. I'm also in a rush for you to go to the exam, I think. Carry on.
Moving on to the examination. Patient is alert, conscious, cooperative, and oriented time plus spaces. Examination was done after obtaining informed verbal consent and was examined in a well-lit room. Patient had mild pallor and did not have icterus, cyanosis, clubbing, lymphadenopathy, or edema. She was well-built and well-nourished. Her BMI was 29.8, which falls into obese 1 category of WHO Asian BMI classification. Patient had no characteristic species of hypothyroidism or hypothyroidism. Patient had no tremors in hand and tongue. The vitals, pulse rate was 69 beats per minute, regular rhythm, normal volume character, no vessel wall thickening, no radial delay. Blood pressure was 124/78 mm of Hg, right arm in setting position. Respiratory rate was 15 breaths per minute. Thoracic abdominal time, and temperature was 37 degrees Celsius. Eye examination, patient had no eye changes due to hyperthyroidism. No enophthalmos, meiosis or ptosis.
Can I just stop you there because I might forget? Once again, you don't need to say there was no ectophthalmos, there was no enophthalmos. I wouldn't say that. Okay, or if you really want to say there are no eye signs suggestive of thyrotoxicosis. Okay, because here you use two words, hyperthyroidism, thyrotoxicosis. Do the two words mean the same?
Hypothyroidism per se means a condition where if there's symptoms of hypothyroidism due to increased like functioning of the thyroid gland. Thyrotoxicosis is a condition where there's increased circulating thyroid hormone, which can also be due to factitious causes or.
Excellent. Hyperthyroidism means increased synthesis and secretion of thyroid hormone. That's all. Thyrotoxicosis means there is increased the tissues and the body is exposed to increased circulating levels of thyroid hormones, which can be due to increased synthesis or secretion or any variety of causes. Patient may take thyroid tablets, or in thyroiditis, there's a transient thyrotoxicosis because the follicular cells are destroyed and the cells, the hormone is released to the blood. So this is very important, So I will not say hyperthyroidism. Thyrotoxicosis is a common term. Hyperthyroidism is one subset of thyrotoxicosis. Okay.
Why did you ask about radiofemoral bleeding? The thyroid, do you get that?
I'm not aware about thyroid in thyrotoxicosis. We can get atrial fibrillation.
Radiofemoral as routinely said, so not specific to this patient.
Yes.
What is the importance of edema in thyroid disease?
Secondary thyrotoxicosis can lead to congestive cardiac failure, which can lead in edema. Also,
Let's start with the common ones first.
hypothyroidism can lead to mixed edema coma. Hypothyroidism, just edema, tissue edema, and Graves can have pretibial mixed edema.
Okay.
And also in toxic multinodal goiter, congestive cardiac failure symptoms.
That's yes, one of the reasons. Yeah, I think what are the characteristic phases that we talk about?
In hyperthyroid, patient will be agitated, irritated,
Angry looking.
angry.
So, what is it because of staring look? Yes. Very good. So staring look, is it seen only in Graves' disease? What are other causes as far as thyroid is concerned?
In any thyrotoxicosis case, we can see a staring look.
Yes. Because additionally, the Graves' eye disease can be there, but staring look can be present in any hyperthyroidism. That is because of
Mullerian muscle, autonomic component of sympathetic.
that's right. So
Why do they get ectophthalmos? One is physiological, then what else?
avoiders, assume the face. Yes, some of the signs, and side also concussion can also.
Local examination coming to inspection. Both lobes and the isthmus visible and asymmetrically enlarged. Diffuse enlargement of the thyroid gland with 3 prominent nodular swellings. Or swellings move with deglutition. A bossinated surface was observed with well-defined margins. Veins were prominent over the swelling, neck, and on the chest. No scars or pigmentations over the swelling. No visible pulsations over the swelling. Swelling became prominent on swallowing and less prominent on extension of neck and neck fixation tests. Tracheal position could not be visualized. Pemberton sign was positive. The first swelling, the swelling seen in the first picture, approximately 15 cross 15 centimeter, globular and hemispherical in shape on the right side of the neck, extends superiorly 1 centimeter below the angle of mandible, inferiorly extending up to the right clavicle, laterally to the posterior border of right sternocleidomastoid, and medially 4 centimeter lateral to the midline. All margins are seen. Next swelling, approximately 5 cross 5 centimeter, hemispherical swelling in the anterior apical midline. Extends superiorly 3 centimeter below the thyroid prominence. Inferior extent could not be visualized. 2 centimeter right towards the right, 2 centimeters from the midline, and 5 centimeters from the midline towards the left. All margins except the inferior margins were seen, and it could not be made out even on deglutition or cupping. A 10 cross 10 centimeters, the same globular hemispherical swelling on the anterior aspect of neck, more towards the left side. Extends superiorly 3 centimeter below the angle of mandible, laterally up to the posterior border of sternocleidomastoid, inferiorly extending up to right clavicle, and medially up to the midline. All margins the same.
Can I just interrupt you over there? Just come back. Now, I am assuming that these are all one swelling. Am I right? So when you have one swelling, basically you are trying to describe me each nodule. I don't think you need to describe each nodule. You have to take the entire swelling as a single unit and say it's got multiple nodules, postulated to it, rather than saying describe each nodule. I would welcome the opinion of my colleague panel members. I don't think you will describe each nodule.
By this time, we are sure it is thyroid swelling, right? So I think that makes sense to describe it like thyroid, each lobe and its side.
Unless you feel that this is the thyroid swelling and it's a separate cervical lymphadenopathy, I can agree with you. But if you're just going to describe a thyroid swelling with multiple nodules, with each nodule like that, I don't think it's necessary and probably far-fetched. What I would say, entire swelling dimension roughly, whether you can see the lower border, rather than each nodule. You don't need to describe each nodule like that. You will say which side is bigger, all those kind of things you can say. Okay? Carry on, please.
Coming to palpation, no warmth or tenderness, local tenderness. Neck circumference at the maximum extent of the swelling is 52 centimeters. Both lobes and the isthmus were palpable. All inspectory findings were confirmed. Inferior margin second swelling could not be palpated even on deglutition or cupping. A 3 cross 3 cystic swelling is palpated within the nodule on left side.
How can you palpate a cystic swelling within the nodule? You probably say it's a cystic swelling. How can you palpate a cystic swelling within a nodule? Yeah, either the solid or cystic. Only a ultrasound scan may say that it is a cystic swelling with a small solid component. But clinically, it is a solid swelling or a cystic swelling. That's all. Okay.
I would say this as both the lobes and isthmus are enlarged, multiple nodules are present, they are formed. It's moving up and down with deglutition, and the lower border is not palpable in the midline. That probably I would say.
You mentioned the Pemberton's test as positive inspection. What is Pemberton's test?
We asked the patient to raise both of her arms.
You are very cautious. You use the word we. You are including your colleague also. Okay.
And we asked the patient to keep her arms raised by the side of the ears for approximately 2 to 3 minutes. And we look for signs of facial condition, conjunctival condition, or venous prominence of the neck and face. This would help us give a clue about a retrocernal extension of the goiter due to compression of vascular structures of the thoracic.
We expose the patient to chest and neck and make her comfortably seated, explain her the procedure. May not continue it for 2 to 3 minutes if patient are developing symptoms. What are we going to look at? What signs? Okay.
Venous engorgement where? Okay, you say in the chest, the neck. What else can you see? What are the findings? Sorry? Sorry? Facial congestion. Okay, we don't have time. You'll have facial congestion. You may have some cyanosis. Why do you get that?
Due to compression of vascular structures.
What vascular structures? Abdominal aorta?
Mostly internal jugular vein.
Why should it get compressed?
The veins are more
I asked why should it get compressed?
thoracic inlet per se is a.
Yes, see, the goiter, when you raise your hand, narrows the thoracic inlet. That compresses on your veins, especially the interjugular vein. That compromises the venous drainage from the head and neck. That is why you get your facial plethora, your congestion, your sinus. Okay, this is the way you have to see. Okay.
What is trail sign?
Trail sign is a deviation of sternocleidomastoid, which helps us gives a clue about deviation of trachea.
Deviation?
Prominence of sternocleidomastoid on one side. Deviation of.
There is a nodule which is lifting up the circulation and it becomes prominent. That's the trail sign.
But is it seen only in metastatic button or any other condition? We have some big nodes in that area, in that from the carcinoma. Medullary carcinoma, yeah.
Any condition which narrows the thoracic inlet, that's all. This is one common example. Okay, and frankly, Pemberton sign is more easily seen in white skinned or fair skinned people. There you can make out actually, the facial congestion plethora. In dark skinned people, you will be able to make, but it's not very classical in nature. Okay, please carry on.
Nodular surface, firm consistency, no fixity, intrinsic mobility is not affected. Carotid pulse felt bilaterally, laterally and inferiorly displaced. No pulsations of thrill felt over the swelling or of the superior port. Tracheal position could not be felt. Laryngeal prominence was in midline. No palpable lymph nodes in the neck. No tenderness over the bone.
How is carotid position inferiorly displaced?
We also couldn't make up, but the normal anatomical location described is at the anterior border sternocleidomastoid and the line joining the thyroid prominence to the anterior border sternocleidomastoid.
What are the inferences of displacement of carotid artery position in case of goiter? What are we actually trying to do?
We are looking at if the Berry sign is positive, if carotid pulse is not felt, in case of any malignancy infiltrating the carotid sheath. Or if there's any goiter also, if it displaces the carotid, there's no bony prominence to feel the pulsation.
So it can be pushed posteriorly. That's what I think we mean laterally. Either it can be pushed or it cannot be felt because of infiltration of the sheath. And
Cushion dull note was dull Norton percussion over the manubrium. Auscultation, no bruit heard in superior portal thyroid. Systemic examination.
Why do you look at thyroid only superior? So how do you know where is superior pole of the thyroid?
The extent of thyroid starts from the thyroid prominence.
That's what you're saying. So why are you looking for thrills only in that area?
That is the location of superior thyroid artery. It is the most superficial of the arteries and it has the direct branch.
It's a direct continuous, direct branch.
And it has anterior and posterior division. The anterior branch of superior thyroid artery is more superficial and it's a Taucher's artery. Because of that, there will be, because of the pressure of the blood, there will be thrills. There is increased less than that.
Systemic examination, cardiovascular system examination, respiratory system, abdominal examination of normal. Summary, 65-year-old female, presented with swelling of anterior and lateral aspect of neck for 20 years, gradually progressive in size. No features suggestive of hypothyroidism or hypothyroidism. No pressure symptoms of pain. Lives in a hilly area with history of similar complaints in family who are also neighbors, and is also a known case of hypertension.
I think in summary, after the examination, you should not mention swelling of anterior and lateral. You should just call it a thyroid swelling now. When else are we going to call it? So you should summarize that it's a thyroid swelling.
On examination, diffuse swelling with multiple nodules seen in the front and side of neck. Lower border not seen or palpable in the midline, even in deglutition or cupping. Pemberton sign is positive.
Okay, what is your diagnosis?
Non-toxic multinodular goiter involving both lobes and isthmus with retrosternal extension.
First of all, why do you say it's a thyroid swelling?
It appears in the midline of neck and moves with deglutition.
Midline, sorry?
Moves with deglutition.
Why should a thyroid swelling move with deglutition?
Thyroid is enclosed by the pretracheal fascia, which condenses posteriorly in Mery's ligament, and it is attached to cricoid. The inferior constrictor muscles, thyropharyngeus and cricopharyngeus, are attached to from the pharynx. It connects to cricoid. So during deglutition, these muscles contract.
So thyropharyngeus is connected to the cricoid.
No, sir. Thyropharyngeus is connected to thyroid.
Thyropharyngeus is connected to thyroid cartilage.
Thyroid.
Okay.
Cricopharyngeus to cricoid cartilage.
Yes. So
Mery's ligament is also attached to cricoid cartilage. So on deglutition, the muscles contract and cricoid moves up. Along with it, due to connection and investment of
you are right. You have to be little more succinct. You are right when you say the thyroid is enclosed in the pretracheal fascia. Where is the pretracheal fascia? Attached to the cricoid cartilage and to the oblique line of the thyroid cartilage. So when you swallow, the cricoid and the thyroid move up. So the pretracheal fascia, which is attached to the cricoid and the thyroid, moves up as well. So all the contents of the pretracheal fascia moves up, number one. Number two, as you rightly point out, the posteromedial condensation of pretracheal fascia is called the Mery's ligament, which is attached to the cricoid cartilage. The other additional factor you can say is just some of the examiners may expect that the isthmus of the thyroid is closely related to the second, third, and fourth tracheal rings. So basically, the isthmus sits on the rings. When you swallow, the rings move up. So anything which is in contact with the rings will also move up. This is another contributory factor. So that is why the next question the examiner asks, what are the swellings which move up with deglutition? You will say, what are they? All the structures within the pretracheal fascia, like one thyroid, what else?
Pretracheal pharyngeal lymph nodes.
Okay.
Then subhyoid bursitis, laryngoscene, and thyroglossis.
What is the difference between thyroglossis and the thyroid swelling? Clinically, how do you make it out?
Movement with protrusion of tongue.
Why should it move with the protrusion of the tongue?
It's connected to the polar and sequence.
Which is connected?
Thyroglossus.
Why should it be connected to the foramen and cecum?
Because thyroglossus depends on the foramen sequence and it gives rise to the thyroid and the thyroid.
Carry on. You're doing well for undergraduate students.
Management, we'd like to go over the following investigations for diagnosis: thyroid profile, USG, and fine needle aspiration cytology. Thyroid profile, this is the patient's values. Free T3, free T4 were normal, and PSH mild 0.4. USG, these are the findings. Entire thyroid is replaced by a heterogeneous hyperechoic lesion with increased vascularity, wider and taller, multiple anechoic areas, multiple macro and microcalcifications. Thyroid score of TR4 was given.
So how do you call what is the interpretation of thyroid biochemical assay?
A patient is clinically used thyroid.
Biochemical assay. Right?
Yes, ma'am.
And it is mild. So what is the
Subclinical hyperthyroid.
hyperthyroidism? Yes. It's clinical hyperthyroidism.
Just remind me, in medical history, if I remember right, you said the patient is on Lugol-Cidin for 1 week. Why was she given Lugol-Cidin? Sorry? So, how did she have Lugol-Cidin even before you saw her? Did some other practitioner started it? Tell me, because you are seeing her and presenting. So, if she's on Lugol-Cidin for 1 week, somebody else would have diagnosed. Carry on. Okay.
The results in the HNAC were final impression is colloid goiter, right and left lobe of thyroid was aspirates from right and left lobe of thyroid taken. Bethesda system, according to Bethesda system for reporting thyroid cytopathology, category 2, benign colloid goiter.
Carry on.
Uh, uh, Along with that, we'd also like to do an X-ray cervical scan. In the patient, it showed dense soft tissue extending into the upper thoracic area and deviation of trachea in the right side. With CNMS, Gabat trachea is also seen. CT neck and thorax.
Why did you ask for a CT neck and thorax?
So the patient has clinically, we're suspecting retrosternal extension.
Yeah.
So.
Yes, cannot ultrasound pick up retrosternal extension? Yes or no? Yeah, you know the answer, say no. Yes, that's the answer, because ultrasound is a poor tool for picking up, so you'll have to ask for a CT scan.
On CT scan, massive thyromegaly with multiple hyperdense areas in calcific foci is seen. Retrosternal extension on the left side, compressing trachea and esophagus, and left internal jugular vein was not visualized for 2 centimeters.
When you mean not visualized, does it disappear? Either it has to be compressed or displaced. It cannot be disappearing into thin air. Okay. What was the lower extent of the tumor in the CT? Goiter, sorry.
So to the middle of mammary, not extending to body of sternum until middle of mammary.
That's all. Okay.
X-ray would be soft tissue neck, not cervical spine. You're trying to look at the soft tissue as well. Right, AP and lateral.
Apart from that,
Why did I ask you about the lower end of the goiter? Is it important in your treatment point of view?
So surgical incision depends upon the retrosternal extension. We might have to go through a sternal approach. There's a large retrosternal extension.
You mean cervical incision with a sternotomy? That's what you meant.
Yes, a sternotomy would have to be performed.
For want of time, I just want to tell you, 90% of your retrosternal goiters can be removed via the cervical region. Usually, if the lower end of the goiter is above the arch of aorta, it can come out from the neck. That's the general rule of thumb. That is why it is very important for us to know the lower limit of the goiter.
So there is a grading of retrosternal goiter. Above the aortic arch, at the level of aortic arch, below the. As I said, above the aortic arch, easily you can remove by pulling it.
So we perform something called a Stowbagan's maneuver, where we place our finger and deliver the thyroid. It is not possible to deliver thyroid. There is dotty neck at the trachea, and the bulging part is wider. That is also given information given by the PT scan.
Another thing is there is primary retrosternal goiter is there, and secondary. Secondary is from the. I think there is a connection, and also in CT you have to see any vascular supplies from the thoracic vessels are there. Because when you pull it, by mistake will rupture it. Catastrophic.
Surgical fitness, complete blood count, blood sugar, HIV, HbA1c, cardiac fitness. And for documentation, we would like to do an indirect laryngoscopy to rule out any occult recurrent laryngeal injuries that pre-existed before. So
We can't call it staging because it's not a management.
Any goiter for diagnosis, not for staging. Okay.
Treatment plan, surgical plan, we would like to go forward with total thyroidectomy, given that it's a high volume center and experienced surgeon, and preoperative leukocytomy. And
There are 2 more minutes.
levothyroxine TH6 suppression therapy is not very effective in patients with such diffuse goiters, and that is why we did not feel it was needed. And perioperative specimen should be collected for histopathological examination, and post-operative thyroxine replacement due to thyroidectomy, as well as to prevent any fluctuating TSH levels.
My only question is, this patient got a huge goiter. Let's imagine that the thyroid hormones are normal. There's no subclinical hyperthyroidism. Patient is asymptomatic. Will you still operate? Will you still offer a surgery? FNAC is benign. will you still offer a surgery? If so,
I would still offer a.
that is the right answer. Why would you offer a surgery?
So, would be, the risk of malignancy considering the age. It would be.
The risk of malignancy. Even a cervical goiter can be malignant.
Pressure can manifest later, right? In this case.
In this patient, why would, in a patient with retrosternal goiter, who's clinically euthyroid, whose FNAC of the cervical component of the goiter is benign, will you offer thyroidectomy? The answer is yes. I will offer. Lack of time. Number one, even though you do FNAC of the cervical component, we don't do FNAC of the, we can't do FNAC of the retrosternal component. So we do not know whether it harbors any malignancy, number one. Number two, it may not have compressive features now, but already there's a tracheostomy, number two. Number three, it is not feasible for any other alternative methods of management. You can't give radio IAD or you can't give suppressive therapy. And number four, rarely, if the nodules inside, it's a big goiter, will suddenly bleed, then you can have acute airway compromise, which may be very difficult to treat. So that is the reason for most cases of retrosternal goiter, even if the patient is euthyroid, even if the patient does not have compressive features, you would offer the patient
In
surgery.
this case, she's also at the verge of turning into a soft multinodular goiter. So she start developing the symptoms.
Very good presentation by both of you. Both did well. I think they deserve a big hand for understanding.
Thank you. Thank you, Naveen and Raveen. I now request the examiners to award certificate of presentation to Mr. Naveen Vincent. Ms. Raveen for. And Professor Dr. Vishnu Prasad to felicitate the examiners.
Hello? You check that?
Dr. Sai Krishna Vittal.
Oh, this is yesterday's people already. Yes, which is the you like? He speaks very well. Yeah, I like Tamil so much. I like this too. It's where he was confident. They speak well. Another thing.
Thank you, sir. I now request Dr. Ramya V and Dr. Srivastav sir to kindly be seated for the next session. We next have a guest lecture by Dr. Srivastav Vittal on parathyroid surgery, why, when, and how. I request sir to kindly guide us.
You have to be lenient with the time for me, man. Good morning, everybody. It's once again indeed a great pleasure to attend this JIPMER update, surgical update, and to be amidst you once again. And I need to thank the entire organizing committee, especially my good friend Professor Vikram Kate over here, and Professor Vishnu Prasad, and the entire team. It's been a yearly pilgrimage for me coming the first week of April to attend this surgical update. Before I go any further, I'd like to express my gratitude to Professor Vittal, who is not only the father of endocrine surgery in India, but my own father, teacher, mentor, and guide. I'm not tired of saying this. I am what I am because of him. So in the next 15 or 20 minutes, I'm just going to say a few points about parathyroid surgery, focusing on why, when, and how. Generally, parathyroid surgery revolves around the surgical management for primary hyperparathyroidism. And so my scope of my talk will be revolve around the management of primary hyperparathyroidism. So parathyroidectomy is the only curative treatment for primary hyperparathyroidism. It is not only the curative treatment, it is the most effective management for primary hyperparathyroidism. I'm going to use the acronym PHPT just to save some time. So few minutes or about PHPT. What is primary hyperparathyroidism? It is an inappropriate elevation of PTH in the presence of hypercalcemia. Normally, when the calcium level goes up, it causes the inhibition of PTH. This is a normal feedback mechanism. But in PHPT, in spite of the high calcium levels, there is an inappropriate synthesis or inappropriate and secretion, and therefore inappropriate elevation. And that is primary hyperparathyroidism. Before coming to a diagnosis of PHPT, you will have to rule out hypocalciuria. Why? Because there's a condition called familial hypocalciuric hypercalcemia, otherwise called FHH. Familial because it is inherited in an autosomal dominant mode. Of course, you'll have hypercalcemia like your primary hyperparathyroidism, but here, unlike PHPT, you will have hypocalciuria. Now, why is it important to differentiate this from PHPT? Because your FHH does not need treatment. So that is why you need to differentiate between your primary hyperparathyroidism and familial hypocalciuric hypercalcemia. So how will you diagnose familial hypocalciuric hypercalcemia? One, you can do a 24-hour urinary calcium test, where a 24 hours urinary will be low, usually less than 150 milligram per 24 hours, many cases less than 100. But the more important or the more accurate way is to measure your urinary calcium creatinine ratio. If the urinary calcium creatinine ratio is less than 0.01, then we are perhaps dealing with FHH. Next, coming to the pathology of primary hyperparathyroidism, in 85%, it is an adenoma. When you talk about adenoma, 2 to 10%, you may have more than one adenomas when it's called double adenomas. In around 10 to 15%, it may be due to a diffuse hyperplasia, which may be either either normal, that is non-inherited variety, or rarely you may get the familial variety where the multiple endocrine neoplasia is included. Rarely 1% of PHPT may be due to parathyroid carcinoma. Coming to the pathophysiology of primary hyperparathyroidism, the PTH, please understand, these are all very interesting concepts. Once you understand, you don't need to memorize, you will never forget. The PTH acts on 3 target organs. Number 1, the bone. Number 2, the kidney. Number 3, the intestine. What does it do to the bone? It causes resorption from the bone. 2, in kidneys, it does 2 actions. 1, it promotes the calcium reabsorption in the kidneys, especially in the distal convoluted tubule. So it promotes the renal tubular absorption of calcium in the kidney. 2, it activates the vitamin D. the 25 hydroxy vitamin D is activated to 125 dihydroxy vitamin D. And what does this 125 dihydroxy vitamin D do? It promotes your calcium absorption from the intestine. Because of all these actions, your calcium level increases in the blood. So you will get hypercalcemia in primary hyperparathyroidism. The high calcium is the calcium levels in the blood are so high that the excess calcium leaks into the urine. So you get hypercalciuria. Please note, in primary hyperparathyroidism, you get hypercalciuria. Whereas in familial hypocalciuric hypercalcemia, the urinary calcium levels are less. So this is about calcium. What else does the PTH do? It does the exact opposite effect with regard to the phosphorus. It inhibits the phosphate reabsorption in the renal tubules. So because of that, phosphorus leaks into the urine. You get phosphaturia. Because the phosphorus leaks into the urine, the blood levels of phosphate become less. So you have hypophosphatemia. What else does the PTH do? It inhibits the bicarbonate absorption in the kidneys. So what does loss of bicarbonate lead to? Acidosis. And what is bicarbonate? It is a negatively charged ion. To maintain electrical neutrality, the kidney absorbs chloride, another negative ion. So what do you get? You get hyperchloremic acidosis. This in a nutshell are the biochemical abnormalities of primary hyperparathyroidism. You don't need to memorize. Once you understand, you will remember for lifetime. You may not see all these biochemical abnormalities always, but this is the full picture of biochemical abnormalities. Some of them say the chloride to phosphate ratio is generally more than 33. These are all some non-specific biochemical indicators of PHPT. I will not go into the detail about clinical presentation. I know you know about the bone disease where they can present with bone pain or fractures, kidney disease in the form of nephrolithiasis or nephrocalcinosis, abdominal symptoms may be due to pancreatitis or the high calcium level can also cause peptic ulcer. Many of them have neuropsychiatric symptoms. This is something which we conveniently either we forget or we are not aware. Many of them are depressed, confused, vague symptoms they have. Some of them just have severe fatigue. Rarely, some patients may have hypertension and pseudo gout. You may be aware of the popular adage which you have read in Bailey and Love: bones, stones, abdominal groans, psychic moans. I will also add fatigue overtones. One of my teachers used to say, the presentation of primary hyperparathyroidism is so vague. The patient goes from doctor to doctor in search of a diagnosis, spends more money and ends up taking loans as well. Don't tell this in the exam. This is just in jest I'm telling to complete the adage. So when will you suspect PHPT? When the classical clinical presentation which I enumerated now, or the patient can be asymptomatic. When you do routine biochemical screening, you detect patients with asymptomatic primary hyperparathyroidism. In the Western world, most cases of PHPT are diagnosed in the asymptomatic stage because they do a lot of screening measures biochemically. In India, we still see the classical clinical presentation. Having said that, more and more cases are picked up in the asymptomatic stage nowadays. So what are the investigations which will aid the diagnosis of PHPT? One, PTH, two, serum calcium. A high PTH and a high serum calcium are the biochemical cornerstone in the diagnosis of primary hyperparathyroidism. The serum phosphate can either be normal or can be low. These are the steps which you will do to diagnose. PHPT. What are the other tests you will do? You will do a 24 hours urinary calcium and a calcium creatinine clearance ratio to exclude familial hypocalciuric hypercalcemia. When you're suspecting bone disease, you will do a serum alkaline phosphatase. In the olden days, they used to do a skeletal survey, but nowadays we do a DEXA scan to give an idea about the density of the bone, whether the patient is osteopenic, osteoporosis, or the chances of fracture. These are some typical bony lesions which used to be seen in primary hyperparathyroidism. So what is the effect on the bone? The PTH causes subperiosteal bone resorption. So what happens because of the subperiosteal bone resorption? There is inflammation of the bone. The inflammation is followed by fibrosis, and the subperiosteal bone resorption causes cystic spaces, and that is why you get the terminology osteitis fibrosa cystica. Osteitis means inflammation. Fibrosa means fibrous tissue deposition after inflammation in the cystic spaces. So most of them you don't need to memorize. This is otherwise called von Recklinghausen diseases of the bone. Sometimes hemosiderin pigments may be interspersed, and that leads to the terminology Brown's tumor. This is more pictures of similar kind of lesions. This is a patient who actually went to the orthopedician and had a left hemipelvectomy. The patient, they thought it was a giant cell tumor because this gives a similar picture in your X-rays, and the patient had left hemipelvectomy and later on was diagnosed to have a primary hyperparathyroidism and came to us. A simple serum calcium and a PTH would have actually diagnosed it before the operation. So we next go to the when component of parathyroid surgery. We initially heard the Y component. When will you do parathyroid surgery? All symptomatic patients must be offered parathyroid surgery unless there's a medical contraindication. Coming to the asymptomatic patient, if you ask me, I will offer surgery even for asymptomatic patients because they at some stage will become symptomatic. So if the patient and the physician agrees, you can also offer surgery for asymptomatic patients. Having said that, with regard to asymptomatic patients, there have been some guidelines which have been initiated. I will not go into the details. You can read up from the book. There was the first international workshop in 1990, then in 2002, third one in 2008, fourth in 2013. Lastly, the fifth international workshop took place in 2022, where they gave specific guidelines. If one of these guidelines are positive, definitely you can offer surgery even in a patient with asymptomatic primary hyperparathyroidism. You can go up and read up from your textbooks. So what is the management of PHPT? As I told you, this is the surgical treatment is the choice, and you will do parathyroidectomy because that is the only curative management. Next, coming to the how component. So you have decided to operate. How will you go about it? The first thing you will do is localization. To quote John Dorfman, a famous American radiologist, this is what he said in 1986. The only localizing test that a patient with primary hyperparathyroidism needs is the localization of an experienced surgeon. This is what he said in 1986. Having said that, much water has flown down the bridge. We routinely do localizing tests. Why? Because you want to have a pre-operative roadmap. Two, you do not want to waste much time intraoperatively. Three, 10 to 15% they have ectopic parathyroid. The parathyroid may be present in ectopic site, and you don't want to have egg on your face. So nowadays, localizing tests are the rules rather than exceptions. Just few words about the different localizing tests. The easiest and the first one is an ultrasound scan, which is 70 to 85% sensitive in picking up parathyroid adenomas, usually seen as a homogeneous hypoechoic lesion, can pick up thyroid abnormalities as well, but cannot differentiate between parathyroid and lymph nodes. Obviously, it is operator dependent. The next test you will do is a sestamibi scan. What is sestamibi? It is nothing but a cationic lipophilic isonitrile derivative. This is usually tagged with technetium. When you give, are usually around 20 millicuries are given IV. When you give sestamibi, what happens? Initially, both the thyroid and parathyroid take the sestamibi, but later on, it is washed from the parathyroid, washed from the thyroid, and only the abnormal parathyroid gets visualized. You can see here, this is the early stage where both the thyroid and parathyroid are visualized. Here, right lower parathyroid adenoma, where the thyroid, the sestamibi is washed out from the thyroid and accumulated in the abnormal parathyroid. Sestamibi is a functional scan. You can improve the sensitivity and the anatomical details by adding a SPECT CT, and sestamibi SPECT CT is a good tool. Nowadays, we also do what is called a 4D CT, when an ultrasound and a sestamibi does not give us useful information. Sestamibi is a good tool for a single gland disease. The sensitivity is between 85 to 90%. However, in multiglandular disease, the sensitivity drops. So when you do not get enough information with an ultrasound or a sestamibi, we now have another tool called 4D CT. It is nothing but a CT scan with a fourth dimension being time. Basically, you take CT images before contrast and after injection of the contrast. In parathyroid adenomas, they take in the arterial phase, they really flare up and get washed away in the venous phase. Based on this, they are able to localize and pick up parathyroid lesions. They have a higher sensitivity. 4DCT has a higher sensitivity than sestamibi in single gland disease. This is a patient which was negative with ultrasound scan. Sestamibi was doubtful. We did it 6 months ago. I think you can see here 4DCT. You can see the parathyroid adenoma, it flares up with the arterial phase and rapid washout to the venous phase. This is an ectopic parathyroid situated near the left clavicle, just beside the left clavicle, not picked out in the ultrasound, obviously. Very vague sestamibi. So I did a 4DCT. It is quite handy nowadays. The other localizing tests or MRI can be used. A new tool which is increasingly used is a colon PET scan, PET CT, which is considered even better than a 4D CT, but limited availability and the cost is probably a negative factor when you talk about colon PET. Okay. You have decided to operate your localized tumor. Do I need intraoperative adjuncts? What are the intraoperative adjuncts available? Frozen section, intraoperative PTH, intraoperative ultrasound, gamma probe, and the new kid on the block, NIRAP, and I mean NIRAP, it's near infrared autofluorescence of the parathyroid and indocyanine green angiography. I will not go into the details, but these are the common adjunct. I personally do a frozen section for all my cases. It's not indicated, but the reason is frozen section will not give you a diagnosis, but at least it will tell you whether you removed a parathyroid tissue, because 1 week you don't want to have a histopathology report saying that you have removed fat. Okay. I will not go in detail about other intraoperative PTH, other adjuncts. Few words about intraoperative PTH. Very useful adjunct. What is the basic principle? The half-life of PTH is around 5 minutes. So if you remove the hyperfunctioning parathyroid lesion, your PTH level should drop by 50% in 5 to 10 minutes. If it doesn't drop, either you have not removed the parathyroid lesion or you are dealing with more than one hyperfunctioning lesion. Otherwise, you are dealing with multi-glandular involvement. There are various criteria which are used, but I don't think at your stage you need to know all that. To quote Edward Churchill, a famous American surgeon of the 1930s who did a lot of parathyroidectomies, what did he say? The success of parathyroid surgery must lie in the ability of the surgeon to know a parathyroid gland when he saw it, to know the distribution of the gland, where they hide, and also be delicate enough in technique to be able to use the knowledge. Allow me to repeat, the success of parathyroid surgery must lie in the ability of the surgeon to know a parathyroid gland when he saw it, which means the surgeon must be experienced. To know the distribution of the gland, which means he should know the normal sites where the parathyroid gland is present. Where they hide, he should know the ectopic sites and be delicate enough in technique to be able to use his knowledge. This is a quote 100 years ago. His statement still holds the test of time. So rapidly, you have got two superior parathyroids which arise from the fourth pharyngeal pouch, two inferior parathyroid which arise from the third pharyngeal pouch along with the thymus. If you look here, the inferior parathyroid along with the thymus which arise from the third pouch traverse a longer distance. What is the significance? The inferior parathyroid can be more prone to be ectopic. 5 to 10% of the cases you may have supernumeric parathyroid. As I said, superior parathyroid more constant in position. Usually, if you take in relation of the recurrent laryngeal, the superior parathyroid are generally posterior. Why is it important? When you're searching for a superior parathyroid, you look for it in a posterior plane. And even when you're looking for an ectopic parathyroid, superior parathyroid, you look for a posterior plane, either in the tracheoesophageal groove, behind the esophagus, or posterior superior mediastinum. Inferior parathyroids, I mentioned, are variable in position. Usually, the inferior parathyroids are anterior or ventral to the nerve. So, when you're searching for the inferior parathyroid, you look in the anterior plane. Thymus, thymothymic ligament, anterior mediastinum, and so on. This is a patient who had a ectopic right inferior parathyroid adenoma with the adenoma in the, you can see it here, it was present in the anterior mediastinum over the ascending aorta. Last bit of my lecture coming to what are the surgical options. The best approach is something which gives the highest cure rate with the lowest complicated rate and has to be cost effective. Are we living in utopia over here? So what are the two options? One is the bilateral neck exploration or the standard 4-gland exploration, where you have a look at all the 4 parathyroids and remove the macroscopically enlarged glands. This is the left lower parathyroid adenoma. This is the right lower parathyroid adenoma in a bilateral neck exploration. Always gives excellent results. Is always an option. You don't need any intraoperative adjuncts. When localizing tests are negative, this is the method which you should adopt. Next comes focused parathyroidectomy, otherwise called targeted parathyroidectomy or minimally invasive parathyroidectomy. You now know that 85% is due to a single adenoma, and we can diagnose it in most of the cases pre-operatively. So why explore all 4 parathyroids and maybe risk the chance of hypocalcemia? That's why focused parathyroidectomy came into vogue. When you do a focused parathyroidectomy, you want to do at least 2 imaging tests, either an ultrasound scan and a cystometry scan, and you want to make sure both of them agree on the position. When there is a discrepancy between the 2 localizing tests, then you will do a bilateral neck exploration. If you are still adamant, then you will do a focus with intraoperative PTH measurements. What are the contraindications for a focused approach? Whenever there's a multi-glandular involvement, like hereditary hyperparathyroidism, lithium-associated hyperparathyroidism, chronic renal failure, multi-glandular involvement may be present, you will only do bilateral neck. When a coexistence of goiter, including which requires thyroidectomy, there is no point doing a focus. When the adenoma is big, you are going to put a bigger incision. There's no point in doing a focus. When you suspect parathyroid carcinoma, you should not do a focus. Obviously, when the negative image, when localizing tests are negative, then you will not do a focus. What does the evidence say? You can either do focus or bilateral neck. Both give equal results. One is not superior. Only thing the focus approach maybe the cost message. Sometimes the hospital stay is less, so sometimes it may be cost effective. You use the term minimally invasive when the incision is 3 centimeter or less. It can be open minimally invasive, endoscopic variety, video assisted, or radio guided. There are two novel surgical techniques. I will not go into detail. One is called transoral endoscopic vestibular approach. Other is called robotic parathyroidectomy. Personally, I think they are overkill especially if you want to use them for parathyroid surgery. To quote Mark Twain, to a man with a hammer, everything looks like a nail. I think it's very important to realize what we should do, what the patient needs to have his condition treated rather than what the surgeon wants to do for the problem. So conclude, ladies and gentlemen, parathyroidectomy is the only curative treatment for primary hyperparathyroidism. Adequate knowledge of anatomy and embryology of parathyroid is imperative. Pre-operative localization is ideal. In the modern world, I think I will not embark on parathyroid surgery without some sort of a pre-operative localizing procedure. Intraoperative PTH measurement is a useful adjunct. Not necessary in all cases, but definitely I will use it if I'm doing focus, if I'm doing recurrent, or if I'm suspecting multiglandular involvement. Personally, I would do an intraoperative PTH. What are your surgical options? You can either do a bilateral neck exploration, otherwise called a standard four-gland exploration, or you can use a focus approach. Even in the modern era, 30 to 40% will require bilateral neck exploration. Currently, the minimally invasive parathyroid surgery means incision less than 3 centimeter. Before you embark upon them, you need to see how feasible they are in a country like us, how cost effective, whether you can apply them in every case of yours. To quote a famous American surgeon, whatever happens, the cervical incision for parathyroidectomy is here to stay. That's what Dr. Kwan Yang Du, who does a lot of parathyroid surgery in San Francisco, says. Thank you, ladies and gentlemen, for your patient hearing. Sorry if I overshot the time.
Comprehensive presentation in highlighting how parathyroid surgery is more of an embryological surgery than a topical one, and how the surgeon operating on these patients should have comprehensive biochemical knowledge, the clinical symptoms, and how to differentiate this from familial hypocalcemia. So, how do you prepare these patients in terms of vitamin D, and do you use any bisphosphonates or denosumab to decrease the calcium before surgery?
It all depends upon the calcium level. If the calcium levels are less than 12, I don't think we don't need to do anything. But if the calcium levels are very high, so if you are planning to operate immediately, the calcium levels are very high, more than 14, 15, salmon calcitonin, because that brings the calcium levels down immediately within 2 hours. Otherwise, nothing wrong in giving IV zoledronic acid, which will bring down in a couple of days. It all depends upon the calcium levels. I don't routinely use agents to bring down calcium levels if the calcium is level less than 12. If it's more than 12, depending upon the calcium levels, I might use calcitonin or zoledronic acid. Denosumab takes time, so that is not something which you'll use in the acute stage.
Most of the patients with IL-30 have low vitamin D levels. So do you think correction of vitamin D before surgery will decrease the incidence of or duration of hypocalcemia post surgery?
Once again, post-operative hypocalcemia depends upon your pre-operative hypercalcemia. If the hypercalcemia is very high, then your post-operative hypocalcemia, the chances are also high. There is nothing wrong in correcting pre-operative vitamin D, but make sure when you're correcting pre-operative vitamin D, the calcium level does not go high. But it's a good principle, maybe start a week or two. I will not do a long-term correction of vitamin D. Generally, patients with primary hyperparathyroidism and vitamin D deficiency, the symptoms are more aggressive.
Also, the DEXA and ALP can give us an indirect.
That's what I said. Whenever you suspect, you will always do alkaline phosphatase. But the thing which will help me determine whether I am going to give agents like bisphosphonates or agents like calcitonin is your calcium level. That will determine what you are going to do. In fact, there was one patient which came from Pondicherry last week with a calcium level of nearly 14. And he was coming back to Pondicherry, so I rang him and said, go to your local physician, get your calcium level decrease immediately and then come back to me. So it all depends upon the calcium level. But by the rule of thumb, more than 12, be careful and cautious.
As I said, localization is negative in 30% of it. So, region side of on table, what are the tips for identification of parathyroid gland, hypertension, adeno? What are the tips?
First of all, whenever you have negative localization, first of all, you localization test is done only when you opt for surgery. Your localizing tests are not for diagnosis. Primary hyperparathyroidism is a biochemical diagnosis. You will do localizing test only when you opt for surgery. When you opt for surgery, when you do a localizing test and it's negative, then you will only do bilateral neck exploration. When you are doing bilateral neck exploration, you should know where the parathyroid glands are normally situated. That is the most important thing. That's why I said adequate knowledge of anatomy and embryology is important. If you are looking for the superior parathyroid, look in a more posterior plane, in the tracheoesophageal groove. That is, you look in first, the normal anatomical side. The superior parathyroid is generally seen at the junction of the recurrent laryngeal nerve to the superior thyroid artery within 1 centimeter. That is the normal side. If you cannot find it there, you will look for it in the tracheoesophageal groove, behind the esophagus, or beside the esophagus, carotid sheath, or posterior superior medius venom. Inferior parathyroid, it is usually present below the junction of the recurrent nerve and the inferior thyroid artery. If you cannot find it there, you will look for it in the thymothymic tract, sometimes in the carotid sheath, sometimes it can be even higher. This is with regard to anatomy and embryology. Next, how will you differentiate between fat and parathyroid? This comes with experience. They say fat is bright yellow, parathyroid is tan. It's all easy saying it theoretically, but usually they say it's a tan. Sometimes parathyroid, when you touch it, there may be some sort of a ooze or discoloration may be there. So whereas fat, it doesn't occur. And usually parathyroid may have a little bit of a sort of a slimy fat which gives a gliding motion, whereas in fat, the entire fat moves. So these are subtle tips. But that is why I say, whenever I do parathyroid surgery, I always get a bit anxious. Thyroid surgery, identifying the thyroid is not difficult. Removing the thyroid is difficult. Parathyroid surgery, removing the parathyroid is not difficult. Identifying the parathyroid is difficult.
Any questions from the audience? We can take one. Yes, there's a hand raised. Yes,
Yes, please. Yeah, I know you're very specific. You want to look at the watch and then say good morning or good afternoon.
Good afternoon, sir. My question is related to a scenario in which we have to remove all the 4 parathyroids. Do you prefer 3.5 or a 4 with implantation? What has been your experience?
I would normally remove 3.5 because recurrent hyperparathyroidism is better to easier to treat than a permanent hypoparathyroidism. So 3.5 would be better than removing all 4. Number 1. Because when you remove all 4, see, we don't have facilities for cryo. If you remove all 4, you have to auto transplant. Even if you auto transplant, the chance of permanent hypoparathyroidism is there. So first option would be a 3.5 parathyroidectomy. When you remove 3.5, make sure the half which you leave back has an intact vascular supply. And it should be roughly at least 50 milligrams, because only then it could produce the appropriate amount of PTH which is required for a normal day-to-day activities. So my personal preference first time would be to do a 3.5, leave behind at least 50 milligrams of parathyroid, the most normal looking parathyroid with an intact vascular pedicle. I hope I answered your question.
Any other questions?
Yes, please. Louder, please. I did mention that in intraoperative urgence, that was the last one. Nowadays, people have started using NIRAM, that is near infrared autofluorescence. Parathyroid, like many other organs, exhibit autofluorescence in near infrared spectrum. You can use that. It's not only used for parathyroid surgery, they have started using for identification of parathyroids in thyroidectomies. That is number 1. But when you use this technique, you can only identify parathyroid. You cannot comment about the vascularity. That is why your indocyanine green, like in hepatobiliary surgery, like in colorectal surgery, they also started using for parathyroid surgery. Indocyanine green angiography have been used to not only to identify parathyroid, you can also say whether the parathyroid is vascular or not. But you need to have all these equipment to use it. I have not personally used it. Normally I use frozen section. Many important cases I use intraoperative PTH because it's when you use intraoperative PTH, not only the cost, each PTH level, your turnaround time is 15 to 18 minutes. If you use 3 or 4 times, you have to wait. There's no point asking for a PTH and not waiting for it, So turnaround time. So, but I use intraoperative PTH. Some cases I will use a gamma probe. I use in recurrent cases, couple of VIPs, they use gamma probe, where you inject just maybe 20 minutes before the procedure. The gamma probe is used 2 hours later. It can tell you where roughly it is. When you remove a suspected parathyroid adenoma and you put a gamma probe over it, I have got pictures, I didn't want to put it for the lack of time. If you put a probe over it, the radioactivity over the lesion, which is 20% more than the background radioactivity, that means what you have removed is the parathyroid. Okay, because the system is there in the parathyroid and your gamma probe identifies that. Okay.
Thank you. We will have time to meet sir over lunch and ask more questions. Thank you very much for an excellent talk, sir. Thank you very much.
Thank you, sir. I thank Dr. Ramkila, Dr. Sri Venkateshwari, and Dr. Nandakishore Manju for chairing the session. I now request Professor Dr. Daspesh kindly come to rise to felicitate the chairperson, Dr. Nandakishore.
We have to see this.
What is
We now have a case presentation on lateral neck swelling by Dr. Sriram and Dr. Varun. I kindly request the examiners for the presentation, Dr. Uday, Dr. Natarajan, Dr. Sessan, and Dr. Balamurugan to come to the dais.
No, yeah, I'm here, but there's a couple of things that we are. That's the thing. What is Oh, okay, I mean, yes, and okay, then I can keep on track and academic center. Yeah, academic building, academic. Sure. Yeah, sure. I was for many years. Academic building. Yeah, but what's the part? Okay.
Let's start. Good afternoon, my dear colleagues. Good afternoon. Myself, Dr. Sriram, and with me, Dr. Varun, will be presenting case on Latin actually. Our patient is a 54-year-old farmer with of lower middle class socioeconomic status, hailing from Erode, Tamil Nadu. He definitely chief complaints of a swelling in the right side of neck for 4 years and pain over the swelling for 5 months. He was apparently asymptomatic 4 years back when he developed swelling over the right side of neck, which is of insidious onset, noticed by the patient incidentally, which was initially around 3 close 3 centimeters in size, gradually increasing in size to the present size of around 8 close 10 centimeters. He had no history of sudden increase in size of the swelling, and it was associated with pain of the swelling for 5 months, which was mild in nature, continuous dull aching type, with no specific aggravating or relieving factors, and radiating to the lower neck and right shoulder. He had no complaints of fever or night sweats. He had no complaints of loss of appetite or loss of weight. He had no history of trauma. He had no history of throat pain or ulcer in the mouth, or difficulty in opening mouth. He had no complaints of difficulty in breathing, cough, or bloody sputum. He had no complaints of any swelling or ulcer of the scalp or face. He had no swellings in the armpits or groin. He had no complaints of abdominal pain, fullness, or mass, or any altered bowel habits. He had no history of any difficulty in moving the neck. It was not associated. The swelling was not associated with any ulceration, skin changes, or discharge, and there was no complaints of difficulty in swallowing, difficulty in breathing, or any change in voice. Past history: he had no history of any similar swellings in the past. He had no history of tuberculosis or exposure to contact with tuberculosis. He had no history of any malignancies or previous irradiation to the neck. He was not a known case of diabetes mellitus, hypertension, asthma, or epilepsy. Previous treatment history: for the same complaints, he had visited a private hospital in Erode 3 years back, where he had underwent a biopsy, but the swelling was not removed completely, of which records are not available in the patient, and he has no history of any treatment received following the biopsy. He had no significant family history of any malignancies or tuberculosis. Personal history was diet and appetite was normal. He was a chronic smoker for the last 15 years with 7.5 back years. He was a chronic consumer of alcohol with no history of use of any other forms of tobacco, pan, or recreational drug use. His bowel and bladder habits were normal, and sleep pattern was also normal. Summarizing the history: he is a 54-year-old farmer, a chronic smoker, and alcohol consumer who presented the gradually enlarging swelling over the right side of the neck for the last 4 years, associated with mild pain with no history of swelling elsewhere in the body. My provisional diagnosis based on history will be TB lymphadenitis, and also I would keep in mind lymph node secondaries, ocular lymphoma, carotid body tumor, or optic sarcoma.
Patient is having history since last 4 years, and the swelling gradually increasing almost double the size of the initial swelling over 4 years time. So, what is the interpretation you told the directed to history? So, what is the interpretation of the coming for the tuberculosis? Why you think lymph node is swelling only?
Firstly, in this age group, presenting with the neck swelling,
My most common presentation would be a as a nodal mass, most probably TB or a lymphosecondary as per the age of the patient. Then other things that suggested was the patient's low socioeconomic status and occupation gives him a high risk of exposure to tuberculosis. Although there is no other history suggestive of TB as such. Then the location of the swelling. Location of the swelling, according to the patient, is on the right side of the neck, which is looking at the lateral neck swelling. In this provided elderly population, I would like to go with an nodal mass assessment.
From the history itself, TB has rapid progression to certain health changes that might happen. If the analyst would say, I will really go out and you would suspect another, swelling. We see one we have just during the history. TB with a very large size to remain without secondary skin. One thing in the history shown that there was a similar swelling which was operated
Like in the you just want.
Is it at the same side or is that
Actually, it's a same swelling. They have taken, according to the patient, they have taken small part of the swelling for testing, but the swelling aspect was not removed.
So that is after how many years back that was done?
That is 3 years back.
Okay, so they didn't have the biopsy.
After that, there was no follow-up.
So once if the swelling is not completely removed, at least the doctor will explain. So what was the case?
After that, there was no follow-up. The patient has not followed up.
Regarding pain, you have not mentioned too much, but you told that pain is there in the lower neck as well as in the shoulder.
Yes.
What is the significance of it?
So one possibility is that very large swelling causing stretching of the tissue will be causing pain, radiating, and stretching of the overlying muscles could be causing pain. Next possibility is any like engaging or infiltration of the nerve fibers can also cause pain, radiating.
Which nerve fibers?
Even the location of the swelling, spinal accessory might be involved.
That's a motor nerve. So
And
I just
the
suspect
cutaneous nerves of the neck.
any branch of the cervical plexus, maybe the transverse cervical or supraclavicular, any of those can go. Another thing is, does this patient complain of pain radiating to the hand, to the arm?
No, sir. Pain is mostly localized to the over the swelling and the shoulder.
So if it was to the upper limb, then what would that indicate?
Possibility of involvement of the pain.
Yeah, so that's what it would be. So again, depending on where's the location, like is it in the the brachial plexus is more lower down the neck. We don't have that idea yet. But these are the possibilities of that can cause pain. When you have a swelling that's slowly increasing in size, it's very unlikely that it's causing capsular, a stretching or those kind of stretching related pain. It must be directly pressing on some nerves. A rapidly increasing swelling, you can explain by capsular stretch.
Another thing I would like to mention here that your differential among differential tuberculosis at the first include cervical tubercular lymphadenopathy. So you should justify in that because we are in a developing country. And second thing, even the duration it is for 4 years. So as sir told, it is usually they should present with the constitutional symptoms. Second thing, there should be secondary changes. But in certain conditions, like when there is a hematogenous spread, it is a lymphatic spread usually will produce the secondary changes like matting or causation and necrosis. But if it is hematogenous, like biliary tuberculosis, it may present a swelling, particularly not at this age, but in a pediatric age. Usually, swelling for a prolonged period. So you can justify in that way, not only that way. That is the commonest. And the lymph nodal swelling, why? Because that is the commonest swelling which we see in the neck. That's why at the end of this tree, you can justify your diagnosis to be it is arising from the lymph node.
Examination. With consent of the patient,
Patient was examined in sitting position with exposure to the clavicle. Patient was conscious, oriented to time, place, and person, moderately built, moderately nourished, the BMI of 20.25 and the ECOG status 1. I was afebrile and general physical examination, no pallor, no stress, and cyanosis, no clubbing, no generalized lymphedema, and no pedal edema. So pulse rate of 76 beats per minute, good volume, regular rhythm, measured in right radial artery, and BP of 110/80 millimeter of mercury, measured in left arm in sitting position, and respiratory rate of 14 per minute, abdominal pressure type. On local examination, inspection, solitary vertically oval swelling of 10 cross 8 centimeter, present in the right side of the neck, extending vertically from 2 centimeter below the mastoid to 3 centimeter above the clavicle, and anteriorly around 4 centimeter from the midline from the spine, and 5 centimeter lateral to the 4 centimeter to the midline to 5 centimeter lateral to the cervical spine. Surface appears smooth with well-defined margin, and it's a non-pulsatile swelling. Skin of the swelling is normal with no scars, erythema, sinus, dilated veins, or ulcers. Trachea appears to be central. Earlobe is not lifted by the swelling. No other visible swellings in the neck. On palpation, no local rise of temperature, a non-tender swelling of right across 6 centimeter present in the right side of the neck, extending vertically from 2 centimeter below mastoid and to 2 centimeter above the clavicle, and anteriorly around 4 centimeter in the midline to 6 centimeter lateral to the cervical spine. Nodular surface, forming consistency, well-defined margin, freely mobile horizontally and vertically. Skin is pinchable over the swelling, and on sternocleidomastoid contraction, there is no change in size of the swelling, and no palpable pulsation of the swelling is noted. And trachea is central, and two lymph nodes of size 1 centimeter is noted in the right upper part of the neck, above the level of the cricoid cartilage, that is at level 3. That was non-tender, and it was matted with foaming consistency, and it was freely mobile. And bilateral carotid examination, carotid is palpable in normal position. And on auscultation, no bruit over the swelling. So oral cavity examination, nicotine staining of the teeth was noted, and oropharyngeal examination, nasal cavity examination, thyroid examination was normal. Axilla and inguinal region, there is no lymph nodes palpable, and on scalp examination, it was normal. The systemic examination, C has no focal neurological deficit noted, and CVS S1S2 heard and no murmurs, and the respiratory system was normal. And per abdomen, it was soft, non-tender, no organomegaly, and no fluid, and was noted. So this is the swelling. So based on this, my summary: 54-year-old farmer, chronic alcoholic and smoker, with a swelling history in the right side of the neck for 4 years, which is gradually increasing size, nodular surface, and firm inconsistency of breathing over, with other lymph nodes palpable in the neck, and my primary diagnosis, provisional diagnosis will be TB, followed by lymph node secondary unknown.
Local examination, the extent of the swelling, what you have mentioned, both in inspection and palpation, you have taken it from the midline. Why? There is one very good anatomical structure which is present in the neck, and which is on inspection as well as palpation. There is no issue. But on inspection, it's quite obvious. You can show that image.
So usually we thought of like from the sternocleidomastoid, the extent, anterior extent, but the mid part of the sternocleidomastoid was not so obvious to palpate or in inspection. On the lower part is so even on the sternocleidomastoid contact test, contraction test, we are not able to differentiate the decrease or increase in the size of the test because only the lower part was visible. The above part was not visible or palpable.
No, but where is the major part of the swelling is located?
The level 5 below the above we are taken from the mastoid, below from the clavicle. Anteriorly, we went with
No,
the.
basically, we should know whether this lymph or this swelling is present in the anterior triangle or the posterior triangle, which is very obvious that it is present in the posterior triangle. Am I right? Okay. So levels, we should not go to the levels in a clinical examination, what I feel. We can, haphazardly, we can tell the level, but here it is mainly the posterior triangle and your differentials are first is the tuberculosis, second is the secondaries. So the position in relation to the sternocleidomastoid is very, very important, particularly to find out if you are thinking secondaries, find out where is the primary located. So that's what I feel that is very important. You should tell the exact anatomical location and the obvious landmarks in the image that you should use while presenting the case.
You said surgery has been done and part of the thing was excised. But the scar was there. Where was the scar? You are not mentioned in the.
In the lower part in the anterior, just below the, lateral to the sternocleidomastoid, small curve.
But they are not mentioned. And if it is a tuberculosis and it has been operated before and a biopsy has been done, do you think the wound will get healed like this? So that's unlikely. So firstly, or diagnosed tuberculosis. And again, 4 years duration, secondaries, 4 years duration. We have secondaries by this time, patient will have other notes and probably not be. That's also again. Any other possibility apart from these two possibilities?
Initially, we thought of carotid body tumor based on history. Examination of
Normally, posterior triangle, right? Such a large swelling, carotid body tumor will report up to such a huge size without consistency.
Is it the site for the carotid body tumor?
No, sir, it will be in the anterior triangle.
What about any other possibility, any other lymph nodes which can present like this, secondary which can present like this, a prolonged duration?
And the lymphoma.
Any other possibilities? Can it be from thyroid? Second is from thyroid.
Second is from the thyroid with unknown primary, but thyroid examination is normal.
Can it present like this? What is lateral aberrant thyroid? It is in stomach. Have you heard the term? Is that?
The primary thyroid per se is not apparent, but the lateral part of the neck will have a swelling, which is a link of the primary per se thyroid is not apparent.
Clinically, they are not pathological, but radiologically, there may be some nodule, but they may have present as a primary lymph node swelling.
Which group of lymph nodes will be involved in the thyroid malignancy, which is the commonest group of lymph node?
So it will be the anterior group of lymph nodes in the midline level 6 nodes.
Which are the lateral? We are thinking about the lateral central group of lymph node, which will not present as a palpable mass index. No. So, which lateral group of lymph nodes are commonly involved in the thyroid malignancy?
3, 3, 4.
Level 3. If you think this is the level 3 group of lymph node,
Higher of the question. It's higher of the question.
now I feel it should be a level 5 group of, if it is a lymph nodal region, it should be a level 5. It is classical if more mass is there in the posterior triangle. That's why repeatedly I am telling that it is in the posterior triangle. So we should think of the drainage area of that area.
Can it be a soft tissue tumor there, not a lymph node?
Yeah, it can be very.
That's okay, but the thing is that other different diagnosis.
Examination findings of the nodular swelling is not very clear. Lymph node mass, other uncompleted lymph node mass rather than it will be swelling.
What means, what is the size of the nodules when they are on the surface?
Examine other lymph nodes, there are 2 lymph nodes purple that are, I mean, even the over the surface of the matted filling of the.
So you think this big swelling is a matter?
Yes.
Can soft tissue tumor like something can have irregular surface or like usually lymph node mass such a big thing with matting, some kind of necrosis would have happened. Patients some things of changes, secondary changes would have happened. Which is so obviously this has in this case. Okay, that's a question. And also I feel that you should consider the soft tissue tumor as well as your one of your differentials.
Can it be a parotid study?
So based on the location, so the earlobe was not
It should not be always raised. The tumor arising from the lower port will not be the classical picture of parotid study.
the retromandibular groove was.
It is obliterated. I am able to see retromandibular groove here. It is in the region of that.
Please let's play with the.
And it is the long duration swelling. Also, it's moving in favor of that case.
Relation that is arising from the Taylor parotid is more likely to go upwards rather than downwards. Going to positive random pass. So that would have been palpable above the lower.
There is one possibility because of the encasement of the parotid. It is encased in the parotid patient. That is one possibility. Okay.
And patient might be involved. Yes. With the parotid alignment.
Need not be always.
This is deep to the sternum.
Yes, sir.
It looks like the sternum is stretched over. That's the one thing that goes out, I mean, against the superficial lobe tumor. You can have deep lobe parapharyngeal tumors that can extend to the neck, but usually they don't extend into the posterior trabecle like this. So, I mean, apart from the differentials that you consider, like the Pandis around mentioned, I think a soft tissue tumor, especially like a nerve sheath tumors, they're quite common to go for, years together and be difficult to remove. Some people might attempt shall we go forward? How would you approach next the patient? What would you do next?
Yes, I'll go with the radiological investigation. With ultrasound neck, showing multiple enlarged conglomerated lymph nodes with compressed fatty acid noted in the right 1B, 2, 3, 4, and 5 group of lymph nodes, largest SAD of 3.2 centimeter level 5, and few subcentimeter lymph nodes in the left level 1B and 2, largest SAD of 7 mm. Thyroid is normal size, equidistal vascularity. Bilateral great vessels appears normal, and bilateral salivary glands are normal with equitexture and vascularity. Then further, I would like to take FNAC from the largest lesion. Sorry.
I think this kind of you've kind of given away the. I mean, you've driven your diagnosis towards this finding where it's going to probably look like a tuberculosis. What if this was one single big lump? Say you ultrasound is not able to characterize it, and you just got one big lump. I just want to know what would be your approach. I want to understand what are the things that you will take into consideration before you go back. Before you look at what will you look in the imaging. So here it's very clearly, probably a mattered group of lymph nodes. Are there, suppose there's a tumor, then what would be the things that you are looking for? And how would you approach a biopsy? Now, this could be an FNA. Let's say with this situation, you have an FNA, what do you look for?
With this finding,
Yeah, in this finding.
and it will be like tuberculosis.
Yeah, so you should have necrotizing granulomas or granulomas. Or sometimes you just see lymphocytes in the body of the report of the FNA. That's all that they might tell you. Suppose you're just seeing lymphocytes and they are not able to characterize further. Then what? In the same case.
Just lymphocytes, I will consider lymphoma. So I look for other types of cells for lymphoma.
No, you just did an FNA. That's what I was saying. You did an FNA. And the FNA is not able to characterize further. They're not able to see any granulomas. They're not. And they just say some lymphocytes. So there are many options. What would be this? One could be an incision. Is there any other way of getting it? Other than doing an incision, that was done once. And so many of these areas have necrotic areas. Can you do something else? You can do a guided biopsy with a core needle biopsy. And just go core needle biopsy. Often that is good enough for lymphomas as well as other tumors also. So we may do that. Okay, but what is important is for a lymphoma for further characterization, you do need a biopsy. So that's right. So you may do a guided biopsy or, as you said, an incision. You often avoid an incision because you're worried that there's some necrosis, then that thing does not heal until the treatment can be. So either your TB drugs or your chemotherapy will have to be given before you can have some resolutions.
With this UHG, what is your interpretation of it, and what is your diagnosis?
It's more suggestive of tuberculosis.
Why you are
But
thinking it is the tuberculosis?
multiple lymph nodes in that with conglomerate lymph.
Yes, that will be seen in some other conditions as well. It will be seen particularly in case of the lymphoma, it will be seen in case of sickle cell as well.
That item is the maintained, the patient comes in maintained, so that's likely to be an anything. Not likely to be.
Okay.
How do you want to proceed?
I'll go for FNAC from the region. Guided FNAC from the right cervical lymph node. Sydney category 2 benign necrotizing granulomatosis lymphadenopathy suggestion of tuberculosis.
So what else? How do you proceed?
Just I rule out the other lymph nodes from the mediastinum. So just got the CT sputum examination. The CT sputum examination from AFP smear is negative. Gene expert for the MTV. The result was negative, not detected. And this is the chest X-ray. Rule out pulmonary TB. No significant findings are noted. No lymph node environment. Mediastinal lymph node. And
my question is, this is the extrapulmonary tuberculosis. Now, why you wanted to do the sputum as well as chest X-ray in these patients?
Just to rule out the pulmonary TB.
Most level, you should answer me how much percent of extrapulmonary will have a pulmonary component, how many pulmonary will have extrapulmonary component.
Usually, it's a 30% patient, 30% of the extrapulmonary TBs have pulmonary component.
Symptomatic, symptomatic. Symptomatic, usually. Okay.
Suppose FNAC shows lymphocytes, and if you have core in the leukocytic core, it shows lymphoma. How will you proceed?
We'd like to proceed with the ECT of the vaccine happened to before radiation or endoplasmic abdominal lymphadenopathy, and also to explore metastatic disease as well, and also to see the MRI.
Stage the lymphoma, right? Okay. I also like to look at your core in the
Typing. Things on histological something.
in TB, if you have treated it, and say after 6 months, the patient again comes back with lungs and discharging or huge lungs. Is there another possibility? What are the possibilities that you think of? This patient, he had surgery, but we are thinking that it was not, it was not removed fully, but what if it was a rectal that it's not now? What are you thinking in terms of TB with all these?
One possibility is a drug resistant strain of TB, the MDR. So in that case, I would like to check for drug sensitivity based on biopsy from the lesion for CBNAT, which can give me information regarding the drug sensitivity panel. Based on that.
Sure. Are there any other possibilities that can happen in TB? So there's something called as an immune reconstitutive syndrome. Basically, when the patient's immune system gets better with treatment, Some of these lymph nodes paradoxically flare up, and we've seen a number of patients where it becomes big, and sometimes they start to discharge also. It's not that they have active disease, and they may need a surgery just to clear off the disease. They are treated from TB, but might need just that. So immune reconstitution is a possibility, or early drug resistance as well.
You say no, that is a tubercular lymphadenitis, and you showed some investigations to be that biopsy, and you wanted to get that seminary. How usually you send this sample to which departments will you send, and how you are sending these samples?
We sent to the microbiology department, the sputum, with the saline. The sputum, early morning, the sample will take. With the sputum, we'll send with the saline. For the
And what is the name of that tube which we send it? Barker tube, which should be okay. So see why it is very important to know regarding tuberculosis, because we are going to eliminate it by India is going to eliminate tuberculosis by which year?
that is the
No, it's 2020. Globally by
Switch the light.
2035. We wanted to eliminate 10 years earlier. So that is very important because tuberculosis is very common and we must know regarding the management. As the sir told, no, one that is the immune response and this. So when once you I will go to the treatment and then we discuss.
I don't have a slice for the treatment. So for extra pulmonary TB, we give intensive phase 2 months of exergenic therapy and 4 months of continuation therapy. Isoniazid, rifampicin, and pyrazinamide and ethambutol. For that's 2 months of intensive phase and 4 months of continuation phase. So then I'll follow up with the patient after 2 months of intensive therapy to look for any progression of the study, or whether he's improving with the ADT. So if it is not improving, then I'll go with the biopsy.
This will include the mass which is a tubercular who started the intensive phase of treatment. And how will you know that patient is responding or patient is not responding?
Based on clinical and radiological investigations.
Since how clinically will you know whether patient is responding or not responding?
Based on the size per se, and
So you think this isn't a large swelling? No. Will you think with anti-tubercular treatment, the size will sink or the swelling will disappear completely? So how will you know that whether he is responding or not? That's the question. Usually in the patients who are having the constitutional symptoms, usually patients' constitutional symptoms will resolve. That is the first thing. Second thing, there will be increase in appetite, there will be increase in weight gain. That are the two most important things which apply for not only for pulmonary tuberculosis or extrapulmonary tuberculosis as well. And suppose this swelling as told that it is going to increase in between with the treatment, and usually this response is seen within 6 weeks of treatment. So that is again very important part we should come to this patient. And if it's responding and even with the continuation phase, the swelling doesn't completely resolve, then again the role of surgeon comes. So these phases you must know all patients with tubercular or any other nature.
Okay, thank you. It was a good presentation. So we covered many aspects. So you need to keep your open mind, because I think your differential diagnosis is a bit more based on the investigation. Already you know the investigation. So your clinical diagnosis, no, the put as clinical as person. Though it that sometimes was there after your ultrasound and your diagnosis. But if post your history and the examination, I think your diagnosis should not be limited to tuberculosis diagnosis. Okay, which was a good presentation. Yeah. Yes.
Thank you, sir. Kindly reactors to award certificate of presentation to Dr. Sriram. Dr. Varun. I request Professor Dr. Sai Krishna Vittal to felicitate the examiner, Dr. Uday Chandra Kumar, Dr. Balakumar. Thank you, sir. Upcoming is the very illustrative video lecture session on the strategies to increase the residual liver volume before major liver resection by Dr. Sarthi Datta. I request the chairpersons, Dr. Shanmugh, Dr. Ranjit Hari, Dr. Jayapala Reddy, and Dr. Devashish Naik to kindly come to the dais.
Oh my God.
Good afternoon, everyone. Dr. Saurabh Satta, he did his MS from JIPMER. He is the senior resident in division of HPV surgery in JIPMER. He is the winner of Samuel Endowment Medal in JIPMER in 2021. He has over 37 publications in various international journals. And he is interested in HPV oncology and portal hypertension. He is going to give a talk on FLR management, how to get good FLR in the liver resection. Good morning, respected chairpersons, faculties, and my dear juniors. I am Shoradeep, third year senior resident under Professor Vishnu Prasad, and I will be presenting on the strategies of increasing the residual liver volume before a major liver resection and a short experience of a review. A major liver resection means removing 3 or more contiguous liver segments. It is a major surgery not without complications. Over the years, various groups around the world have reported morbidities ranging from around 25 to 50%, with mortality between 5 to 8%. The complications can be due to technical factors like a bile leak or an abscess formation, but the most graded complication remains post-hepatectomy liver failure, which reveals in the form of cholestasis, hypoalbuminemia, and deranged INR, which starts around like 3 to 5 days after surgery. It has been well documented now over the years that if the FLR is more, the complications decrease. Igitler et al. Showed that there was almost 50% decrease in the overall morbidity if the FLR increased from 30 to 60%. Now, why does the post-hepatectomy liver failure happen? It is due to the excessive increase in the portal pressure and the blood flow per gram of remnant liver, leading to an increased turbulent mesenteric blood flow. This leads to the endothelial, sinusoidal endothelial and corpus cell injury, and in turn, it releases the inflammatory cytokines. So what is considered as a safe liver resection? Various consensus guidelines recommend that a normal liver requires a 20% remnant volume, whereas an injured liver requires 30% and the diseased liver requires 40%. If the preoperative planning shows a low remnant volume, we need to increase it. The technique we use is depriving portal blood flow to the liver part which is being resected. There will be lower function shifts to the non-embolized liver, and the bile flow also shifts, and then atrophy hypertrophy complex sets in. There are two types of strategies to induce FLR hypertrophy. It can be surgical or IR techniques. The surgical techniques include a portal vein ligation with a two-stage hepatectomy, and the second one is associating a liver partition in the first stage. IR techniques include the main portal vein embolization with its adjuncts like combining it with case or hepatic venous embolization. A new technique called as radiation lobectomy is also gaining popularity now. Coming to the surgical options, the first is doing a portal vein ligation while doing a two-stage hepatectomy. It is done with when there is a bilobar disease. For example, if there is a large right lobe colorectal head with two smaller lesions in the left lobe, in the first surgery, the smaller lesions in the left lobe are removed along with the right portal vein ligation. And after 6 to 8 weeks, when the FLR grows in size, a second stage surgery is done. The next option is basically doing a liver partition to the first stage surgery. It was accidentally discovered during a surgery in Germany in 2012 and thereafter tried by various groups with some modifications. But the procedure has a significant morbidity with mortality ranging from 12 to 15%. So portal vein embolization remains the most commonly used and well-proven technique. It was first described from the Japanese centers in 1980s. The access to the portal vein can be obtained surgically, which is called a trans-ileocolic approach. It involves a mini laparotomy and placing a catheter into the portal system via an ileocolic vein and embolizing one side of the liver using C-arm in the operating room itself. The other newer technique is a percutaneous transhepatic approach, which has to be done in an IRC by the interventional radiologist. As the name suggests, there are two types of percutaneous techniques. As the name suggests, ipsilateral refers to the approaching the portal vein to the liver part which has to be resected. Contralateral refers to approaching the portal vein via the FLR. There can be various pros and cons to both the techniques. A contralateral approach is easier to do, due to lack of acute angulation, and there is no associated tumor seeding. But the dreaded risk remains is the injury to the FLR, which would make the entire effort waste. Ipsilateral technique might be difficult to do for the beginners, but if we need a segment 4 embolization, it is an easy way to do it. And there is no risk of injury to the FLR. Then comes some adjunct techniques like a sequential case with a portal vein embolization, which can be done for a hepatocellular carcinoma. And adding a hepatic venous ligation along with portal vein ligation, this increases the rate of liver hypertrophy. So we come to a case scenario like a case which happened in our unit. 45-year-old lady who came to us with dull aching upper abdominal pain for 5 months, and she self-referred to us with an ultrasound report which showed large liver swells. Physical examination was not remarkable, other than liver being palpable 3 centimeters below the costal margin. We did a CT. It showed 2 lesions resembling intrahepatic cholangiocarcinoma in the segment 7 and segments 4B, 5, and 8. We did a CT volumetry which showed around 32% FLR. As there were some large cysts in the FLR and we needed to also take the segment 4B along with the right lobe, we thought a portal vein embolization would be a safe approach. There are some snaps from our cath lab. The left portal vein is being localized using the ultrasound. And after that, a catheter is manipulated to the left portal vein into the right side the dye is injected to get a right portal venogram. And then the PVA particles are injected. We see a CT which shows no right portal vein. And CT volumetry shows almost 9% increase in the FLR after 6 weeks. I show a small video of the hepatectomy done after that. So first, dividing the falciform on the right coronary ligament, we start mobilizing the right lobe of the liver. Then we see the retrohepatic dissection, lifting the liver from the IVC. After that, the Marcucci's ligament, the hepatocaval ligament will be divided. Sometimes it is a vascularized structure also. So we are dividing between the glands. The Marcucci ligament. We suture like it. Coming to the hilar dissection, here we dissect out the structures, the bile duct, the hepatic artery, and the portal vein. We place umbilical tape also around for a Pringles maneuver. And further dissect the structures above the hilum to get access to the right-sided inflow. So right side of the portal vein has been dissected now. So we'll put clamps on the right portal vein and the right hepatic artery to get a demarcation line next. So here we'll be able to see the demarcation line. And we mark the plane of resection. In this place, we have increased the line of resection as we used infrared ultrasound to see that the tumor was infiltrating the right, the segment 4B also from inside. Then we start a parenchymal transection. As of now, we have been doing it with the combination of monopolar, bipolar, and the thunderbig sealers. We are supposed to get a closer soon. The vibrating arm of the thunderbit is used to dissolve the liver parenchymal structures, just like a tweezer. As we open the liver from inside, it becomes easier to ligate and divide the right-sided inflow. The right portal vein, right hepatic artery, and the right bile duct will be clamped and divided. We can see the bile duct, right sided bile duct being divided now. We continue doing the transaction. This is probably a segment 5 vein, which is being planned and it is being divided right now. Then we continue the transaction and we would end by finally putting a vascular stapler with the right hepatic vein. So we had 800 ml blood loss during the procedure. 1 PRBC transfusion was done, and the surgery took 6 hours. The patient was discharged on post-op day 8 with no complications. I would like to end my talk here to add I'm very emotional today. This is going to be the last JIPMER surgery update. I would like to thank my unit chief, Professor Vishnu Prasad sir, for everything. I have been under his mentorship for almost 6 years now. And at last, I would like to thank my wife, my son, for being the pillars of my constant motivation and support. Thank you.
Thank you for a wonderful presentation. I am very happy to see that my alma mater, that is the department from which I trained, is doing such quality work. Any questions from the floor?
I would like to know what will be the optimal time for doing this procedure before. I would like to know what is the optimal timing for the procedure before going for a list.
Usually 4 to 6 weeks, we do CT scans to evaluate for the epithelial increase.
How much you are expecting it to increase till go for surgery?
So that is basically like what I said before. For a normal liver, it is usually 20%. If they tell, but sometimes we keep a margin, and most of the times we can have some intra issues also. We don't have a QSA. We use monopolar, Cautery, and Thunder bits. So we tend to take a safe margin. Probably 35 to 40% should be okay.
That will be achieving within 4 to 6 weeks after the procedure.
Yeah, most.
It is not the same for all patients. It depends on various patient factors. How is the liver? If the liver is steatotic or it has some cirrhosis, it will take a much longer time.
Firstly, again, same person transit, the rest we should be allowing thanks to this thing. When during the MS, they're getting into this kind of exposure. A few important points. The decision sector is a very good point. So the portfolio embolization, in addition to actually increasing the volume, it's a diagnostic test to see how good your liver is, what is regenerative capacity. So traditionally, the criteria we look for is 2% per week. There's no point waiting beyond 3 weeks. So it's if you are after your portfolio embolization, it shows 6% increase in volume, that's good enough. That means your liver is going to take this. You think 6% is not enough. So what higher cancer showed, the actual volume increase is not much, but the functional the takeover of the revenue segment is much. So that's the sort of criteria. 2%, and it's a very good useful test to assess how safe your research is. So you can let us know, you can abandon research. And about you both techniques, portfolio embolization and ALPS there. What to use where? That's like for right appendectomy, especially portfolio embolization is very good. But when you do go for right trisectionectomies, many times the interventional radiologists find it difficult to embolize the segment 4, and they will actually embolize the left lateral segment. So in that situation, ALPS is good. And ALPS was initially very popular, less popular. Important teaching points about ALPS is now ALPS in obstetric jaundice is now considered a contraindication. The morbidity is so high that in obstetric jaundice patients we don't do it anymore. That's one problem. The other problem with ALPS is big disadvantage is a very major surgery. And when once you do ALPS, you go in within 7 to 10 days. You have to go in within 7 to 10 days because the hypertrophic development curve is very fast. If for some reason you are delayed, so we've had this problem because the patient has pneumonia or some problem, we've had to go in at 3 weeks. It's a mess. So once you cut the liver and you like it for within 2 to 3 weeks, new collaterals form. Portal hypertension develops, the portal vein recanals by other ways. Like when you have in thrombosis, 3 weeks collaterals form, right? So your surgery becomes very messy, bleeding, packing. So that is why ALPS came up in a big way. The extent of hypertrophy you have in ALPS is much faster than embolization because you're transecting and there's no chance for collaterals. But with all these disadvantages, it's actually slowly becoming less forward. Thank you so much.
Just I want to add one point for the sake of posterior TX. So before we are optimizing FLR, suppose the bilirubin is high, patients have obstructive jaundice, you have to relieve the jaundice. Then only you should try for this embolization or ALPS or whatever. So if the patient is bilirubin is high and the patient is obstructive jaundice, we have to do stenting or PTPD, whatever. Let the bilirubin settle down, let the LFT settle down. Then we have to go for the embolization or ALPS or whatever is needed. Then suppose after doing the portal embolization, suppose the means the hypertrophy is not adequate. There is one term called risk ALPS. You can try again ALPS during the means while you are operating. You feel that left lobe is not very much big and the hypertrophy is not enough. Then again you can transect the parenchyma, leave it like that, and again going after 2 weeks. So that is called risk ALPS, and there are multiple modifications of ALPS, like tourniquet ALPS or partial ALPS and risk ALPS, different means partial parenchymal transection or full parenchymal transection. All those modifications are to reduce the complications. So recently the ALPS actually, not the classic ALPS, the modified ALPS are gaining popularity. In other, not like in hilar pharyngeal studies are told, not in hilar pharyngeal carcinoma, but in colorectal liver mets and SCC. And there is a ALPS.net one website is there. You can go through it. There is an international community who reports all their ALPS cases there. It's a German-based website. You can get all the thing. And one more important point is before deciding on the portal vein embolization or ALPS, you should have clear-cut idea on the anatomy, like what they did. So you should have a good CT scan. So where you can see the portal vein anatomy, whether the type 1, type 2, or type 3, whether is there any portal vein excess one. Sometimes it can, which is supplying the right lobe, it can come from the left portal vein sometimes. So you have to see the anatomy properly. Then you can decide either to go for portal vein embolization or to go directly to ALPS. So based on that, your thing will change. Not like portal vein embolization is superior or inferior, not like that. You should know about all the techniques to improve the FLR. So you should know where to use which technique in which way, means whatever way sequential, which is good for the patient. Yeah, very excellent talk. I'm very happy that the liver restrictions are happening in general surgery department in JIPMER. It's like a proud thing to all of us. Thank you. Thank you very much. Thanks.
And Sauradeep, it's an emotional moment for you, and we wish you all the best and a wonderful future and an excellent career ahead. All the best to you. Thank you.
Thank you, sir. I request the chairpersons to felicitate Dr. Saradeep Datta. I request Professor Dr. Krishnamurthy to kindly come to the stage to felicitate the chairpersons. Dr. Shanmugam. Dr. Jayabala Reddy. And Dr. Devashish Naik. Thank you, sirs. Thank you, sirs. We shall be breaking for lunch now. The lunch is served in third floor, exam hall 1. We request all of you to reconvene in 45 minutes for the afternoon session. Thank you.
Krishna. He is the director of the Face Hospitals, Hyderabad. He has done MS from JIPMER, MCH from SCPJ. He has also done MRCS, fellowship in hepatic oncology from Kurume University, Japan, and liver transplant fellowship from Leeds. So Dr. Pani is a well-known surgical gastroenterologist at Hyderabad. So he does varieties of surgery, but I think what is close to him is laparoscopic surgery and liver transplantation. Over to you, Dr. Pani.
Firstly, I'd like to thank the organizers led by Dr. Vishnu Prasad for this opportunity. I'm really glad, I'm giving this talk today because I see all the young surgeons here and the concepts which we discussed today of AWR. I mean, this is a field that has had an explosion of growth in the past decade or so. And these concepts, if you already don't know them, these are going to be the mainstay of your work in complex hernias for the next couple of decades. So AWR, it's become a mad rush. There are around 30-40 new acronym surgeries which have come in the past decade only. To cover all that would be impossible. I'll talk about two main surgeries which have become major game changers in our understanding of hernia surgery and the way we do it, the kind of results we give to the patients. I'll just focus on these two only because they are like really important step ups. So, okay, first, why do we need this kind of component separation techniques or abdominal reconstructions over and beyond our traditional, open and laparoscopic hernia surgeries? We know that primary closure of a defect is extremely important in any hernia. Because post-op seromas, if the big bulge meshes bulging into the sac over a period, pseudo recurrence can occur in the early post-op, which can actually become a true recurrence later on. And also we know that for large defects, all our abdominal wall muscles are coupled together in the center. So if you have a wide breach in that and they're uncoupled, over a period of time, they're going to actually retract, atrophy, and that not just leads to progressively your hernia becoming bigger and bigger, not just the hernia problems, but respiratory and back problems. So this is one very good Spanish study, which will improve our understanding of hernia. So across the board for the past, let's say 25 years, we've all been doing lap IPOMs. Then we understood that we have to close the defect. We started doing IPOM plus. What we should understand is when you do the IPOM here, this is just a peritonealized defect. You're just closing with your sutures, with your Prolene sutures. You're sort of dragging and bringing them together and setting them together somewhere. At that point, it looks okay. But you see, there is no raw area being created here. These two edges are being just held together by the strength of your Prolene, which is going to last for what, 9 months, 1 year. It's going to weaken. So these guys, they did for 3 centimeters, 5 centimeters defects, protocol CTs for almost 5 years after the surgery. Every year they did a protocol CT, and they said that all defects which are more than 5 centimeters, and after 3 years post surgery, they reach the initial size. So what you're doing in IPOM plus is actually becoming a IPOM only. And the other problem is what we don't realize, especially in women. All women after delivery, majority of them have a divarication of recti, a thinned out papery rectus sheath. We think we are going in and putting a mesh and reinforcing the rectus, but we are actually reinforcing paper. So what is happening over a period of time is they retract, the defect becomes wider and wider, and then initial results are okay, but after 5 years, we get a more complex rectus. So the two surgeries, basically they are posterior space. So the ETAP is a surgery in which we actually join the two rectus spaces, the Reeve Stopa repair, which above from the costal border till below the prevesical area we go, and the ETAP TAR is for the bigger defects. So with the ETAP, you can get a 7 to 8 centimeter advancement on the rectus muscles in a tension-free fashion. And then the ETAP TAR is when for wider defects up to 15 centimeters defects, 15 to even 20 centimeters we've handled with that. You can go beyond the linea semiluraris and separate the transversalis marginal. So here we enter the gap between the posterior rectus sheath, the linea semiluraris is divided, and then we create a wide space in which we can place very large meshes and get a very good advancement in the midline. So why PCSD? Why these two are posterior component separation techniques? So one is they restore the abdominal integrity. The muscles are closed in a tension-free fashion. They regain their tone and the flexion strength improves and the abdominal compliance improves. So you're doing it in tension-free fashion. And all these patients, because of the, especially in the, both in the TAR, ETEP and the TAR, we're able to place very large meshes. For example, the TAR, what we use is a 60 by 40 mesh. We cut it many times to around 45 by 35, but a very large mesh is being placed with the mesh incorporation. When you place it on lay, it's in contact with fat and tendinous structures. So the reaction is not much. But here, it's in contact with the vascularized muscle, anteriorly with the rectus, laterally with the transverse abdominis. So when you have that kind of a muscle, the incorporation of the mesh is very good because it's a very well vascularized area. Infections are very less. There is no fixation in all these because it's in between spaces. So there's no fixation. So and the mesh doesn't migrate. So when you do no fixation, all the immediate post-op problems of pain and long-standing neuropathies are avoided. And so those are all there. In some infected situations also, it's the ideal. When you, let's say you have to do a bowel resection or something, an on-lay would not be an ideal situation because subcutaneous and the tendinous, that's a poorly vascularized area. Infection that is going to come is going to become resistant. While in this area, you can still get away. And the traditional, I'm sure a lot of surgeons would have been doing the anterior component separation issues, but that has its own issues that you raise large flaps, seromas, a lot of mobility. All those are avoided in this. And it's cost effective because we are using, let's say you have to use a 30 by 30 mesh, a composite mesh, the costs are huge. The cost of tackers is huge. You're avoiding it by putting in a straightforward regular Prolene mesh. You usually use a heavy Prolene mesh. The most important thing about these surgeries is they're very versatile. See, anterior component separation you can use only for large midline defects. TAR, one single technique, if you master it, you can use for in anterior compression. The advancement in the midline is good, but in the epigastrium region, pelvic region, the advancement is very poor. TAR is one single operation. If you master it, you can do it for epigastric, suprapubic, lumbar hernias, colostomy, parastoma hernias. So it's a very versatile operation once you master it. So the traditional concept was, when you have more than 8 to 10 centimeter defect, only we should do component separation. But right now, it is that any defect more than 5 centimeters or any patient in which the defect is as to the divarication, any lateral defect, any pelvic or suprapubic defect, these are way superior techniques compared to the traditional approaches. Of course, difficult thing with these surgeries is they're time taking. I tell my juniors this is like the Whipples of hernia surgery. It's hernia surgery, you want to finish it, get in and out quick. It's not. There's a lot of anatomical points you need to know, and it is time taking. You have to be patient. And once you do these are usually in recurrent hernias, complex hernias. So there's no much salvage procedure. So this is not the end all for all hernias because this new tool we should not use in all. Let's say a 5 centimeter defect in a 75-year-old lady with multiple comorbidities who's going to be sitting in her house most of the time. I would not really go for complex repairs. I just do an IPOM or an IPOM. You just want to prevent strangulation and some degree of cosmesis. Well, in a younger patient, let's say a 35-year-old patient who's going to be active for the rest of the life, the same hernia, we would like to restore the muscle integrity and look at a much better, much long-term outcome. So these are all, like I said, they're just decade old. Nowitzki described the TAR and Belyansky in 2015 for the umbilical hernias. The ETEP, of course, for the inguinal hernia was described in 2012. Just before I go to the actual technique, I'll just take a few points to tell you the anatomy of the surgeries. One is you have the 3 strap muscles, the external oblique, internal oblique, and the transverse abdominis. They go join the linea alba. The rectus width is highly variable. The rectus can be 3-4 centimeters. In women, it can be 8-9 centimeters. So that also gives you an idea of how much advancement you get. For example, if I'm going in for an ETEP, if your rectus of either side is 7 centimeters, you will get about approximately half the advancement. That's a formula. So if it's a 7 centimeter advancement, you can get. Or if your rectus is 4 and 4 centimeters, you will only be able to get a 4 centimeter advancement. Based on that, you can see, can I stop with a PCS? Shall I stop with an ETEP RS or do I need to go on to a TAR? And the most important muscle is the abdominal wall corset, the transverse abdominis muscle, which arises from the lower 6 cartilages, the iliac crest, and then they sort of couple into each other in the midline. So this is the muscle that contracts the abdomen. The corset, in the European, the Victorian women, we used to tighten the abdomen. It contracts the muscle. It's the main muscle in expiration. So once you have hernia, once there's loss of domain, there's a lot of contents outside, there's a loss of domain. You want to close in a tension-free fashion. Obviously, you want to remove the corset and loosen the tummy. So this muscle is the most important principle in the surgery. few important concepts you need to remember: the neurovascular bundle, which this is the holy plane between the internal oblique and the transverse abdominis, which you should never breach. These neurovascular bundles run here, so you should avoid injury to them. One very important concept is this is a traditional schematic understanding of the rectus sheath. You have the the three muscles. The anterior lamina is formed by external oblique and internal oblique. Posterior is by these two now. But in reality, it's not like that. See in the upper abdomen, the muscle component of the posterior rectus sheath extends very much medially, while in the lower abdomen it ends very laterally. So you see this diagram. So here it's extending very much medially. So imagine if you open the rectus sheath here in the upper abdomen, you're going to enter the muscle. So you find thick muscle, you can divide the muscle and get into the right plane of the rectus plane, which is the plane between the peritoneum transverse fascia and the transverse abdominis muscle. Imagine the same thing you do in the midline. You'll enter here, and here it's so thinned out, you can mistake this thin layer for the peritoneum and get into the wrong plane, and then you'll injure the neurovascular bundle. Of course, below arcuate line, as you know, it all merges into one space, and that is the bottom up approach. I'll show that in a brief way. Likewise, in the the concept of the preperitoneal spaces, you have above you have the falciform ligament, and you have very loose preperitoneal space. Likewise, below you have the urachus in the center and the medial umbilical folds and prevesical fat. So you have big spaces. So these, when you cross over in the ETEP, obviously you enter one rectus space and you have to join it to the other rectus space. There is something called a crossover. That crossover can be done easily in these areas, because when you are crossing over here, in ETEP, the principle is to totally extra peritoneal and not to enter the peritoneum. If you enter in this area, it's so thinned out that you will enter the peritoneum. So the end of the surgery in ETEP or TAR, what we get is here, we enter, this is the posterior rectus sheath, incised medially, then here is the preperitoneal fat, then the opposite rectus sheath, that is in ETEP. While in TAR, we divide the semillunaris, go beyond it till the, if you want, you can go till the psoas muscle. So that's the kind of advancement you get. And like I said, the mesh is in contact with the varicose muscle. So just before I show the video, I'll just show a few important diagrams. So this is in the sac. These are 15 centimeters, 18 centimeter defects we're dealing with. So it's important to preserve the hernia sac as a part of the posterior peritoneum, because many times it is after all the reduction, you're not able to close the posterior sac, and in these hernias, your mesh will never be in contact. So in your traditional IPOMs, they say it's dual meshes, bowels don't enter in, but when you go for re-explorations, you know that 90% of the time they have significant additions, whether it's even for a dual mesh. In these hernias, there is zero additions because you have a peritoneum, and that's why you use a regular proline mesh. The hernia sac is preserved. So this is the initial anatomy. We've entered, this is the sac which is preserved. We've entered the posterior rectus sheath, that is the rectus muscle. You have the inferior epigastrics. Very important to sort of take the inferior epigastrics on with the anterior abdominal wall. They should not, if you push them down, you'll eventually injure them. So that's the problem. You have these T6 to T12 neurovascular bundles, you can see here. These neurovascular bundles, 1, 2, 3. So these bundles and the inferior epigastric, these are important structures to preserve during the surgery. Then, see, so these are the neurovascular bundles. You can see they're very clearly in this image. The neurovascular bundles, these are the T2, they just pierce just medial to the linea semillunaris. They pierce the posterior rectus sheath just medial. So you have to identify and preserve them. If not, you are just devascularizing your muscles. And then in the upper abdomen, here you see the posterior rectus sheath is incised, and here you have the thick rectus muscle. The thick rectus muscle is being now we're going to divide it. Then we'll enter the perfect plane. So the neurovascular bundles are there. Just medial to it, we make the posterior rectus sheath incision. We find the transverse abdominis muscle. So transverse abdominis muscle is extremely variable. In some patients, the males you find like really thick transverse abdominis muscle. In the females, sometimes you just, it's like a very thin fascia. So in those kind of patients, there's again a bottoms up approach. I'll show that. And then once you do that, you'll see in the video, we've gone beyond, and this is the transverse abdominis muscle. The transverse abdominis muscle, you divide it. It not just inserts into the rectus sheath, it also inserts into the peritoneum. So initially, there is no blunt dissection in TA. It is the initial part of the surgery. You have to meticulously keep dividing, taking the transverse abdominis muscle fibers of the peritoneum as well. See, these are all the cutted transverse abdominis fibers you've taken off the peritoneum. We go laterally. Then, once by both sides we close this peritoneal sac. The sac of the hernia is useful. If we preserve, we can use it for the peritoneal sac. And we place this is a dyna mesh. It comes 60 by 40. We use 50 by 40, 45 by 35. The mesh starts from. So in the video we can go onto the diaphragm, separate the diaphragm or much, it goes above the zubrosternum, above, inferiorly to the space of tracheus, laterally to the psoas muscle. So it's like a huge mesh we paste, always use a heavyweight mesh, and then the anterior tissue is closed easily. This is the video. So now that you understood the concept, we just show you the video briefly. So this is the posterior tissue. See, TAR can be done laparoscopically, but most of these hernias are recurrent hernias with extensive additions. So you'll rarely find a case which we do lap. Most of the time, the ones we do lap are ones we're going for an E-tap, and the defect is too wide, so we end up converting the E-tap to an E-tap TAR. So the traditional open approach, see, we're going, the posterior rectus, rectus space is being created there. And like I said, as you develop the rectus space, the inferior gastric muscles you identify and you lift up with the rectus muscles. So we identified this thing, and now we are incising the posterior rectus sheath. The moment you incise the posterior rectus sheath in the upper half of the abdomen, the supraumbilical part. We see the rectus muscles. You see right now, I think we are dividing the rectus muscles, the muscle fibers. The moment you divide the muscle fibers, see, we're dividing the shiny posterior sheath comes. Here, there are two layers. There's one is transverse fascia, which is well developed in some patients, not well developed in some patients. So if you are probing the rectus, you are onto a very thin peritoneum through which you can see the bowel. Try to just go one layer up and try to pick up the transverse fascia and get back into the right plane. So you can see that rectus is completely being exposed as we divide the posterior rectus sheath. And we are dividing the rectus muscle, the transverse abdominis muscle fibers. So doing it in this half, so because these are so well developed, you can easily identify and stay in the right place. So it has to be done very patiently, because if you have a small buttonhole in the peritoneum, you should close it immediately, because with the traction we give, it will keep on tearing, then you get huge peritoneal defects. So like I said, see, then the transverse abdominis muscle is slowly being pushed off with a combination of sharp as well as blunt dissection. Now what the thing that's coming up, that is the posterior peritoneum and the transverse fascia. We slowly taking off. In the medial part, there's a bit of insertion, but once you go about 3 to 4 centimeters laterally beyond the linea secularis, you can do it by blunt dissection. That's an avascular space. There's no blood loss. But lower down in the men, obviously, you have to extraperitonize the cord structures in the iliac vessels. In the women, you might have to divide the round ligament. So getting into this space is the main trick. Let me just put this. So see, now laterally it's just peeling off. The transabdominal muscle is being peeled off and easily separable. And I'll show you that that's the beauty of TARIS. In the upper abdomen also, for upper abdominal defects, you can separate the peritoneum of the diaphragm. You can go up to laterally in the area of the diaphragm as well and get a very good advancement.
That's funny.
Yeah.
Can be.
Done with time? Okay. Fine. So the kind of results we get in this are, for example, just look at these defects, huge 18 centimeter defects, and we get excellent results. So the kind of results we get are very good. You can do it bottoms up in some patients, when the rectus transabdominal muscle is closed. E-tap is something which I wanted to show, I think, but yeah, we don't have time for that. That also can be done top, bottom. So to conclude, basically, component separation is a standard of care for treatment of complex hernias. Preoperative CT reading is very important to assess the quality of the muscles, atrophy, and previous injuries. PCS is going to be the standard of care. It's much more popular and much better in the short term. Now we have long-term results also. And now when a patient comes, depending on each patient, there's so many procedures we have to tailor our surgery accordingly. Thank you. Actually, that E-tap is a very good video. We can go to our channel and watch it. It's a 20-minute video. I wanted to show it in 5 minutes, but it's better that if you guys go to our channel and watch the video in detail.
It's an excellent presentation.
Thank you.
However, there are so many modalities of treatment for hernia. And you told that the TAR procedure can be done right from the defect of 5 centimeters.
No. not 5 centimeters. The posterior component separation, ETEL, we can do for. So in our situation, with a younger patient, the defect more than 5 centimeters, a significant amount of divarication, we would do an ETEL, just a weave stroke. TAR is generally for more than 8 to 10 centimeters defects, we do the TAR.
I wanted to know what is the exact size.
Yeah.
Preferring tar particularly for
8 to 10 centimeter defects, and even smaller defects if they're in the suprapubic median or the in the epigastrium suprapubic median and lateral defects, an appendix scar hernia or nephrectomy. The smaller defects, scar is a much better question because in those hernias the recurrence rates are as high as 50%.
Another important question: what preoperative preparation, anything you do like serum?
So, absolutely. So the preoperative preparation is one thing. TAR is considered we have to consider the major side. Even it takes about 3 hours. TAR takes about 4 hours. Or being the preoperative CT scan. And your radiology is very good at assessing. Some people would have had a previous breach in the previous round. Some people, the previous surgeries, posterior partition will be missing at some point. Then you have to plan accordingly. I'm going to use a dual mesh. And then, so the CT is the most important preparation. And the bowel preparation, we can give some patients, but multiple failed, extensive addition. So if there's a chance of bowel is easy, obviously you can minimize the contamination by giving some pregnant.
I wanted to know whether you are preparing the patient, particularly the complex areas, like your experience in use of botulinum toxin.
Okay. So that's like a very limited area. So these is loss of domain. So in those patients, the preparation will be do a pre-op thinking. There are several indexes, component separation index, Anaka index, by which you decide that if I put this power content back, first is the reduced or irreducible. If it's reducible, no problem. However, we can again do it. If it's irreducible, bowel has been outside so long, when you put it back in, the patient is going to get respiratory distress. So it's a complex system of looking at the CT volumetry, the patient's general condition, respiratory distress. What a younger patient may tolerate, older patient may tolerate. In those patients, we do this 2 things. We do maybe 1 to 2 per year. So there's 2 concepts: progressive pneumoperitoneum and botulinum. So progressive pneumoperitoneum, what we do, we put a lab port, put the rice tube. So we try to achieve about 2 times the hernia sac volume in the intraperitoneum over the next 10 days. So every day we push it there, till the patient complains the same, tap it. Then again, next day we push in somewhere till the patient complains the same, tap it. We try to achieve.
All in caps.
So we can combine, the progressive pneumoperitoneum with the botulinum.
2 plane apart. It's meeting process. That's why they're not
Like other
asking for
preparations,
blood
this way you have to
of
consider this. You have to have DP stockings, you have to have a ERAS program, active mobilization.
moonlight plants.
Thank you.
How many of them you are able to do laparoscopy?
So, like I said, ETEP is always done laparoscopically. TAR, we almost never do it laparoscopically. The kind of patients we get, like in GI and oncopractice, you know that they're mostly post-operative cases with, and most are failed repairs, previous failed repairs and complex. So the skin is so unhealthy and the additions are so bad, the previous menstruation, that for patients who are doing TAR, it's not worth it. The only we would have done 3-4 ETEP TAR. That means ETEP go beyond the limits of the laparoscopy. Those are cases in which we actually go in for an ETEP, but at the end we realize that the posterior defect or anti-defect, it's too wide still. You're not able to. So we need more advanced. Right? And most of the time we do a unilateral tap. So if you want to do lab tests, the ideal in patients with just wide divarication, very wide divarication, women with 15, very neglected divarication for 15 years, 20 years, they have a 10, 15 centimeter defect. Those kind of patients with no addition to other, you can go for that.
Vegetarian.
But despite all this, I will say we still use the traditional women with diabetes. We still do a lot of anteropomeral separation with abdominoplasty, plastic surgery. We still use them with very good results.
This robot can help in this.
Yeah, definitely. I mean, see, all these surgeries, the ETEP and the umbilical tap, they're going to be very challenging because you're sitting on the abdominal wall, you're working this way. They're ideal for robot. With the robot we have right now, CMR, that's the robot we have. We have not been able to staff logistics. They have some 5 centimeter robot, and the driving force of an introduce for 1 protein meters is poor. So we have not been able to use our robot yet for these procedures. But I understand from my colleagues that Hugo and the Da Vinci, they're using it. These are ideal surgeries for robotics.
Any question from the audience?
Okay, thank you very much. Thanks a lot. That's like I said, this the item videos are like really beautiful video. If people are interested, should just go to our channel Panikshna Lalda and see a 20-minute detailed video with the audio. It'll be like very useful for you for your practice. Thank you.
Thank you for that wonderful session.
Also,
sir.
Mary's stuff.
I now request the chairpersons to felicitate the speaker, Dr. Fani Krishna
We used to own
Ravula.
Should we panic or no? In your laptop. How many? One is here, one is here. More I had one more. Three. One is here.
I now request
Yeah, this
Dr.
is
Shruti
another
Kamal to felicitate the
This is-
chairperson, Dr. Suresh Kumar.
அதெல்லாம் ஜூம் இருக்கும் நீ போய் எடுத்துரு figure it out. And get addresses.
Thank you, ma'am. Thank you, sir. Next, we have a case presentation on peripheral vascular disease presented by our postgraduates, Dr. Aditya and Dr. Teja. I request the examiners for the presentation, Dr. Jagdish, yes, Dr. Shruti Kamal, Dr. Ashley Solomon, and Dr. Abhinay Reddy to please come to the dais.
Okay. I'm looking for you people and panicking here. Yeah. Zoom irukum. Yeah. He doesn't know which one right. Yes, that laptop is. Anna, we will all to control all. End process. Sign into Cortana. Please Cortana. Zoom check no bro. Which is some technical song right now. Perform by network log. Either to Zoom. You go stand and talk about JIPMER also update. JC 2023 started small letters. J small down. SU SU 2023 start. What is happening to that? Okay, hold on. One of the I will leave it on.
One meeting joining.
Wait for you to check. 9 to 9. Start.
PowerPoint we are having some solution.
9, okay, hold on. 9 to 9, 3, 4, 4, 7, 3 to 9. 3 to 9. அதுக்கப்புறம் JIPMER.
A cardiac, Mr. Ramesh, a cardiac over male, hailing from Villipuram, presented with complaints of pain in right leg since 4 months. Pain in right leg since 4 months. History of discoloration of right foot since 3 months. An examination like pain right leg is the incidence answer. It was indefinite type of pain, cramping type of pain. It was activated during and relieved by taking rest initially. Initially they have to walk around the pain right leg, right lower leg. This is why just right leg is what right leg, foot, calf, thigh. Right leg is a very big part. What specifically is the real bit more specific regarding your right leg pain doesn't mean anything. The calf pain, thigh pain, foot pain. He's having pain over the calf region and foot region, sir. From past 4 months. Very independent type of pain, type of pain. It was during walking and it was actually relieved by sir.
That is all.
He basically is able to walk around
Now I'm turned it
350 meters, and it was gradually reduced to 25 to 30 meters. The history of the installation of
What is the dude?
What's
That's what we're trying to do. It should happen. It's like
You are giving a very
Anything
great
element.
development and grade 1, 2, 3.
That's what we're doing.
Grade is best.
So, I mean,
What is the first grade, what is second, third grade, what is fourth?
patient is also
What is real and standard?
patient is having a treatment for March.
What is grade 1?
Patient is
Grade 1 internal coordination.
patient is able to walk, then he develops the pain. After that, he continues to walk. That is great. That is due to
That's not grade 1.
Last time it was hanged.
Grade 1 is the
Cesareans. Now we'll follow.
That is the idea. Second one is able to walk.
able to walk with the pain.
Third one, grade 3, he has to post to rest. And fourth is the speed. So what is the purpose of grading all this? Why do you have to grade the intermittent coordination? Like other.
To know the severity of.
That you know, grade 4 is severe, grade 1 is not severe. But why grade at all? You understand? You can say severe, you can say, why do you want 1, 2, 3, 4, why burden our memory, lot of other things. For communication. For proper scientific communication, you have to say grade 1 is improved to grade.
Meeting ID.
Like lacto comma scale,
Yeah,
staging, whatever. Proper scientific communication.
Having discoloration of the right foot since 3 months. I was initially started in the grade 2 and progressed to all 4 fingers. Is having no history of Parkinson's, no history of chest pain,
No,
no history of the postpartum abdominal pain, no history of like the discoloration of the toes and planting of toes.
Just now you told color is black and now it's color is not circular. Just now you told color is dark and all that. Now it's not discoloration of toes. Can you please contact just now you told me fingers are gangly. Now you say no history of discoloration of toes. What exactly are you trying to say?
And with cold, no history of discoloration of other.
Already dark. What more dark is going to become? You understand? You started with the statement that the toes are dark. Now you're saying on exposure it doesn't become dark any further. So to me, I don't understand this. You have to be very clear.
So in the meanwhile, can you just tell us what are the various ways vascular disease will present to the OPD? What are the various presentations of vascular patient?
Usually patients presented with the history of pain in the right leg.
Yes, there are two presentation. One is chronic limb ischemia. Then there is something called critical limb ischemia. And then there is acute limb ischemia. Right. So can you just tell what do you mean by chronic limb ischemia? What is critical limb ischemia and what is acute limb ischemia?
The patient will be having the chronic history of pain and the right limb, the different parts of the pain. Persons will be people and examination.
Yeah, patient presenting with intermittent claudication is chronic limb ischemia. Okay.
We will be having a trigger any type of pain with direct features and motor features.
I think that it presents with the classical 6 P's of acute limb ischemia. Pain, pulseless, fiber, and critical limb ischemia.
Discoloration of the toes is like it was progress to
Yes, along with chronic limb ischemia, they are acutely having some problem, and either there is stimulus loss, like in your case, or there is rest pain. So, those are called critical. Among these 3, which is the commonest that we see in practice? Chronic limb ischemia or critical?
chronic
Critical limb ischemia is the commonest because nobody bothers about intermittent claudication. Most of these patients are old age, and then they are generally not very active. So this claudication will not affect them too much unless it becomes so severe that they are not able to walk to the bathroom or they are not able to go to the neighborhood shop. Most common presentation among these 3 is critical limb ischemia. When we say that it's critical limb ischemia, duration. Whatever you say confidentially.
Yeah. What is the definition of claudication itself? Please, what is the definition of claudication? During walking for some distance, you will develop a cramping cycle pain in that is will develop claudication. Pain that comes on by an effort and relieved by rest. How many minutes approximately it takes for this claudication pain to go away? Usually it will take 10 minutes. 5 to 10 minutes. 5 to 10 minutes. Is it necessary that we should sit and rest, or even by standing it can go away? Like usually they will hang the things on the usually it will go on standing. Walking is getting the pain. You can just stand in the place itself. The pain will disappear. Not necessary that you sit down and the pain should go away. Okay. What are the other things that can mimic this one? Neurological pain also we can bring this one, but it will be having insert the so it can be something to do with the venous system, it can be something to do with the neurological, or it may be the arterial. So you should know the differences between these things, because something can change with position, something will not change with position. Like neurologically, it can change with position. In a particular posture, if he lies down, that neuropathic pain will disappear. Okay. And these are the things I'm sure you know. Disturb. Let us you continue your presentation. Then we last week. He's having history of escalation of right foot for past 3 months. Initially started from the grade 2 and gradually progressed to all other foot. No history of ulceration, no history of fever, no history of paresthesia from the foot. History of paresthesia for trend in the right lower limb from past 1 month. He's having continuously picking pins and needle sensation. No history of trauma, no history of post-spinal abdominal pain, no history of syncope or blackout, no history of sudden blurring of vision, no history of gestures or palpitations, no history of impotence or sudden pain of the gluteal region, no history of pain and restriction of the neck movements, no history of pain in the upper limbs, no history of discoloration like other fingers and exposure to cold. Past history is known case of diabetic on medication for past 10 years. It is not a case of hypertensive, CV and DA, and no history of cerebrovascular infections. Personal history consumes mixed diet. He is a smoker. He smokes 20 BDs per day for past 10 years. He is a known alcohol consumer for past 8 years. Consumes around 180 ml per day. No supplement, similar complaints in the family. Summary is a 40-year-old gentleman, known case of diabetic and medication, with complaints of claudicated pain in the right foot and cough for past 4 months, and black discoloration of the right foot for past 3 months, with history of smoking and alcohol consumption. Here you were saying that he is smoking BDs. What is the difference between the BDs and the cigarettes as far as the nicotine is concerned? Anybody in the audience also can answer. What is essential? Where is the injury more in BDs or cigarettes?
BDs.
BDs. Why so?
Organic
You're
vegetable.
right. See the foil in which the tobacco flakes are put, he has to smoke and take a lot of puffs compared to using a cigarette. So the nicotine content is 0.46 or something compared to what is in a cigarette. The number of puffs that he's taking and also the long duration of the thing to get that whatever he wants to smoke, he's not only taking carbon monoxide, tar as well as nicotine. And also, what is the half-life of nicotine? It is only 30 minutes to 60 minutes. So when he stops smoking, why this is very important? Suppose somebody is smoking a BD, and they stop smoking BD. Then when you are taking for some other thing, management, the abstinence you have to take. So it's about 6 to 7 hours is good enough for a BD. But whereas for a cigarette, it is about 24 hours. So that is very important. That's why the 43 cigarettes, 43 BDs you must smoke, for it is equivalent to 20 cigarettes. That is why they never say BD pack years. You are having a cigarette pack years, no?
So it is only BD ears and not BD back ears. This you read and it's very interesting, or you should know how harmful this BD is actually. Right? Okay. So you understood what I said? How do you know that patient is not smoking? You are telling him not to smoke, but how do you know he is not smoking? He may be cheating you. Like the cheap food, like that. So examine the urine for protein levels. If that is positive, that means this guy is cheating you. So urinary protein levels will be high. Okay. And also your comorbid history, you must say some diabetes is not a past history. Right? Put it in comorbid illnesses.
Moving on to examination. On general examination, patient was examined after obtaining consent in a well-lit room after adequate exposure. Attitude of the patient was sitting with legs hanging by the side. He was conscious and oriented. He was afebrile and hydration was good. He was moderately built and well nourished. There was no pallor, icterus, cyanosis, clubbing, fetal edema, or generalized lymphadenopathy. On vitals, left upper limb BP was 140 by 80 mmHg measured in sitting position, and right upper limb BP was 140/80 same measured in sitting position. ABPI index for the right side was 0.57 and left side was 0.71. And pulse rate was 86 per minute, measured in left radial artery with normal volume character and no vessel wall thickening was. Respiratory rate was 14 per minute. SpO2 was 97% at room air. His height was 176 centimeters. BMI was 15.5. There was no inguinal lymphadenopathy. Examination of his spine was normal. On other systemic examination, CVS S1, S2 was heard. There was no murmur. Respiratory system, bilateral, no added sounds were heard. Per abdomen, it was soft, foul sounds were heard, no organ gain. This is the clinical picture of the patient. On the right side, we can see up to the midfoot, it's completely blackish in coloration on compared to opposite side. On local examination, right lower limb, the skin was blackish discoloration was noted over the dorsum of the foot, involving all four toes, extending to the plantar and dorsal aspect of the foot. Skin was dry and shriveled. There was loss of luster, loss of hair over the dorsum of the foot, and pimples. Muscle wasting was also present. Nails were brittle. There was line of demarcation. There was no ulcer or edema. Moving on to the palpation for the right lower limb. Temperature was lower compared to the left side. There was no tenderness. The inspected findings of gangrene were confirmed, and there was decreased sensation over the foot and sole of the movements of the toes were restricted, and ankle joint movement was normal. There was no edema, no tenderness around the veins. Mid-calf circumference of right side was 26 centimeters. When compared to left side, it was 29 centimeters. Similarly, mid-thigh circumference for right side was 54 centimeters and left side was 55 centimeters. Capillary filling time and venous filling time were prolonged. There was no keratitis. Similarly, for left lower limb, this skin showed some loss of luster, loss of hair over the dorsum of the foot and toes. Nails were brittle. There was no muscle wasting, no ulcer, no edema. Decreased sensation over the dorsum of the foot. Capillary and venous filling time were also prolonged on the left side. Apart from that, in upper limb test, Allen's test was positive and Edson's test was negative. This is the chart for peripheral pulses. On both sides, common carotid, superficial temporal, axillary, tracheal, radial, and under artery were normally palpable. On coming to the lower limb, common femoral artery on left side was palpable normally. On right side, it was absent. And popliteal artery was stable on the left side, but it was absent on the right side. ADA, BK, and DFDA were absent for both the limbs, right and left. Coming on to the case summary, it's a 40-year-old male, known case of diabetes mellitus for 10 years on OHA. with history of smoking and alcoholism. Complaints of pain over the right foot for 4 months and blanket discoloration of right foot for 3 months with rest pain. On examination, dry gangrene of all right foot, on toes, on 5 toes of the right foot with signs of ischemia with absent pulses of rhythm. Provisional diagnosis will be peripheral arterial occlusive disease affecting bilateral movement with dry gangrene of the right column, probable femoropopliteal occlusion in the right side and infrapopliteal occlusion in the left side. Possibly due to accelerated.
You said all the toes were gangrenous. So why did you check for the capillary lesion?
On the opposite.
Where you saw?
On the opposite was also.
You will say right side femoral you can't be. That's what it told now. And also femoral popliteal statement. It will be right side femoral is the aortic segment.
Is my phone?
You can feel if you cannot feel like femoral,
This iotoiliac, in which group of people it will come? What is the difference between the iotoiliac and the femoropopliteal and tibiopedal? What is the essential difference between this? Usually in younger patients, smoking.
Younger patients present with distal
Older patient, atherosclerotic, you can get more peripheral, distal. Okay. I'll ask you one basic question. What is the difference between an embolic occlusion and thrombotic occlusion?
embolic occlusion will be more acute.
Only one difference. Even thrombotic can come acute. Anybody?
We will have a.
Anybody? Yeah?
He might have a.
Anybody in the audience?
He's also not using my problem.
In thrombotic, you will get claudication pain. In embolic, you will not get. It's so acute, you will not get. There also it is acute, but you will get a claudication pain will be there. Okay. So your diagnosis is peripheral arterial disease accelerated by atherosclerosis. The dry gangrene of the 4-foot is called.
Accelerated, usually atherosclerosis will present in older people, but when it presents in younger people, call it as accelerated atherosclerosis. Will also have Marcus Silaris.
You speak in the mic. They also should know what you are talking about. I can't be bothered.
Please.
40 years no.
Doctors will be my second differentiation. But these diabetics and larger vessels are also involved. So I will favor the arterial occlusive, peripheral arterial occlusive.
Can somebody have a peripheral arterial disease with no claudication? You still can have, this person can have a peripheral arterial disease, but there is no claudication and all that.
Might have collaterals long.
Collaterals. Somebody very sick. He is having other serious comorbid illness. He is just not ambulatory. He is just lying down. Still he could have. So that's why the comorbid illness, whether he is moving about or is actively participating in any daily activity, all that is very important. Okay. So how do you want to proceed with this person?
I will like to do duplex scan.
straight away. You only see some atherosclerosis is there. Was he on any statins, any drugs? You have to know whether somebody is on a medication already or is not on any medication. You are the first person going to start him on some anticoagulants or antiplatelets, all that. So the history also, the whatever medication he has taken, you have not asked at all. Previously, drug history he has taken, he's already tried something. All that also you ask. Okay. So straight more from the routine investigations, always. Right? The blood investigations first, then you will do the rest of the investigations. For managing these patients with vascular disease, what are all the information that we are looking for? What are all the information that the surgeon should have for managing this patient with vascular disease? What are all the data that we should have?
So first local data like
First one, we should know whether it's pain and all those things due to vascular problem or not due to vascular problem at all. So that how do we get that data? Also, you should know about his cardiac status and also whether he's got a medical renal disease. Because suppose you cannot know many things, he is already having an advanced medical renal disease. Okay. So that also you get that data. That this is due to a vascular disease and not due to some other problem. So this we get that based on history. Claudication, so claudical type. So what is the next data that we need?
Now we need to know
Where that occlusion is.
where the operation is.
So how do we get that data?
Mm,
Like sir was asking from the claudication pain, how will you know where the obstruction is? Where is the problem?
Patient will tell where the pain is based on.
Where is the pain? Where is the pain be?
A calf pain will usually there in
Where? In which occlusion?
If there is calf pain, where is the obstruction?
That's what I.
If there is step pain, where is the obstruction? If the thigh pain, where is the obstruction? As simple as that.
Suppose you got a pain in the buttocks and gluteal region, where is the problem?
I want to ES.
Yeah. Any other way to know the location of the occlusion? Even if you are having an occlusion in the aortoiliac or still the calf muscle they can have a claudication. Why is it so? Because if you see the entire leg, the bulk of the muscle is only in the calf. That is why. So any other way to locate the occlusion? One is history, like ma'am says, they have intermittent claudication depending on location of the pain. Any other way to localize the occlusion? You have done it actually.
So imaging.
Not imaging, man. Just pulse examination. So here we know that femoral is not palpable. And we don't know how higher than femoral it is there. The other side femoral is palpable. So that means it's not there in the main aorta. So it can be either of the two iliacs. So that just by history and examination, we'll get a rough data on what we are looking for. Then we further investigate to confirm our doubts. Only if you give this data to the radiologist, they'll also give you an accurate report to you. In this Doppler, what report he will give you? Monophasic, biphasic, or triphasic? In the audience, what is monophasic?
Three pieces are there in top.
Waveforms.
The first waveform is due to this systolic contraction of the heart. The second downfall is due to diastolic.
Early diastole. And the last one is the late diastole. So you have to see whether the antegrade flow is there or not. In the monophasic, nothing will be there. That indicates a very bad situation for the patient. So the other two, the biphasic and triphasic, mild and severe. So that is the triphasic is good. Okay. Those patients the doctor is obviously not but if you have a patient the doctor will be not any other
You can break it.
in this case, you didn't know how you calculate 85. I think you.
No. Yes.
Yes, sir.
How you get all the data? How you measure the return that is not possible?
Yes, sir. Yes, sir. Pulses, but not parameters, but on measuring the ankle pressure, some sensation was there. No, after trying, no, after treatment.
What should be the ankle pressure? What should be the toe pressure in a severe disease like this?
Ankle pressure will be less than 70 mm.
70, 50. Very severe, no? Less than 50 and toe pressure should be less than 30. Okay. What is the vascular surgery like TNM staging, no? There is a Society of Vascular Surgery has come with one staging. What is that staging? Yes, tell me. What is W for?
W is for wound. I is for ischemia.
Ischemia.
Foot infection.
Infection. Okay. So that grading helps us in identifying the patients where exactly they belong. In that ischemia, all this is important. ABI and also ankle pressure, toe pressure. This is very important. Okay. Next, what investigation you want to do?
After blood investigation, imaging.
Yeah, you said Doppler you have done duplex scanning. Then
The CT.
CT angio. Between MRA and CT angio, which is better?
For intraoperative, if intraoperative MRA is
In CT angio, what will you see? Especially in an ischemic limb like this.
level of occlusion and how much segment of the vessel is.
Usually, proximal means only one segment will be involved. Higher up, iotoiliac and all, only one segment will be there. But as it comes down, more than two segments you can have. To say that this is an peripheral arterial disease due to atherosclerosis, what is it that tells us in a CT angio? You get a lot of corkscrew vessels. You get a lot of corkscrew vessels you will be able to see. Especially you are saying diabetic, atherosclerosis. So you get a lot of corkscrew vessels, collaterals. What we call the corkscrew collaterals you'll be able to get. Okay. What is it that really we want to know when you're doing an angio?
Target artery part.
You want to see the block, which segment is involved, what are the collaterals, what is the distal runoff that you are having. Are you see, because the surgeon must have a plan to do some revascularization procedure. Will he be able to do this? Because these are all tiny vessels, no? So it's very unlikely for us to do any big revascularization procedure. So it all depends upon which vessel is there. So you can put a graft or something like that, or any whether you will be able to do an angioplasty, or you can put a stent. You know, even if there is some atherosclerosis, atheroma there, whether you can do an atherectomy. All this information you get in a CT angio. You also get information about the other leg also. The opposite leg also you will be able to know. Is it not? All that information you will get. And also when you are doing something like this, you have to know about the venous system also. What information you want to know about the venous system? First of all, if vein is there or not. Because sometimes the great saphenous vein may be absent in a person. So if you want to harvest some vein as a graft, autologous graft. So you have to know whether the vein is there. And also the diameter of the vein. If you want to put a vein graft, what should be the diameter? What criteria should be there for the vein? It should be more than 3 mm. It should be distensible. It should not be diseased vein. All that is very important. So what shall we do for this?
It's unsalvageable. So we have to go ahead with the amputation.
Suppose you want to do some amputation for one guy. How will you know this amputation stump is going to heal? Any current methods of identifying whether that amputation stump is going to heal? Because you can't go on cutting the thing, no? You cut, then they'll say 4-foot amputation. This Franks or whatever you are going to do. Then you go to show parts. Then you go to meet like that. So that kind of a thing should not be done. So what shall we do? Is there anything called skin perfusion pressure measurements? Yes, it is there. What do? You inject transcutaneously, you inject an isotope like I-123 and see how much it is getting washed off. So you gentle pressure you put over the thing and see at what pressure it is getting washed off. If the pressure is less than 20 mm, this wound is not going to heal at all. The pressure is more than 20 mm. 90% of the cases that wound will heal. These are all the thing. And also transcutaneous oxygen saturation is very, very important. You have to measure that also. Okay. All this helps you, this wound is going to heal. So anyway,
Can you do a science amputation discussion? What is science amputation?
Sir belongs to our era where we are doing science amputation.
What is science amputation? Can it be done for this patient? Are you aware of science amputation?
Don't worry about that. That was always a failure amputation. And it is, you cannot fit any prosthesis. Very difficult for the patient. Even stability is not giving a great stability. Always there with the flap necrosis because the calcaneum flap, very precarious blood supply it used to have. So I think that's put it in the backyard, no sir.
Because the science amputation is a very good amputation for non-diabetic, non-vascular. It's not recommended to vascular. That's our purpose of asking for this question. The science amp should not be done. I just wanted to know whether you look at it, but you don't know what science amp is. So I said not to have it. I said trans-sensor, I use. Transankle amputation. It's not done in diabetic.
So what's the advantage of science amputation? If it is like non-case, a lot of failures are there. But if it works, what's the advantage for the patient? It doesn't require a prosthesis.
Science amputation done in non-diabetic, non-vascular, and you get something called elephant foot, and they can have a normal limb. But it's not recommended in vascular disease or diabetic because science is supplied one single artery posterior carotid. But that is involved by the disease, more carbon necrosis. But it's not necrosis in non-diabetics.
Yes.
So science amputation is not recommended. That's the purpose of asking the question. Okay.
Yes.
So what amputation to do in this patient?
So you will go for a below-knee amputation.
Below-knee amputation. Suppose it is your leg, you will get below-knee amputation. How much of the leg is involved? Put it just you show the photograph. Now this patient, half anterior foot only is involved. Why do you want to remove the whole foot? Only 4 foot is involved. Why do you want to below-knee amputation?
Yes.
So you must think of patients have to have a living, he has to go and work also. So is it below-knee is better or something less?
Less more.
We have to think on that. Now here, something like 4 foot amputation, like madam was saying, this Franks is there, so many other amputations are there. If you preserve the heel pad, then you can walk, you can do something.
Experience. So last year,
Lifestyle modification.
most of it like smoking cessation, and exercise.
I think we'll stop here. But you go back and read again. Okay.
Did you finish your examination?
Thank you, sir. I request the examiners to award the certificate of presentation to Dr. Aditya and Dr. Teja.
How to share this? Share here, then share there, then.
I request Professor Dr. Uday Shamra Cooper to kindly come to the stage. Felicitate the chairperson. Dr. Jagdish.
Audio join பண்ணல.
Dr. Shruti Kamal. Dr. Ashley Solomon. And Dr. Abhinay Reddy. Thank you, sir and ma'am. A small announcement. The owner of a blue colored Swift Desire, number KL 11818, is requested to go to the parking lot.
Mathematically,
I repeat the number of the car, KL 11818. I request let's move on to the next session. In this era of evidence-based medicine, it is imperative that we surgeons know the importance of statistics. I request Dr. Palnivel from the Department of Preventive and Social Medicine to deliver a lecture on statistics for surgeons. To chair this session, I welcome Dr. Nandakishore, Dr. Shruti Kamal, Dr. Suresh Kumar, and Dr. Vikram Kate.
So, everyone. So, I'll be covering the basic concept of statistics. So, post-lunch session, statistics and community medicine background. Okay, not a good combo. So, this is the outline. So, I've been given 15 minutes. So I cannot cover a topic in depth, very simple topic. So, I'll be based on my experiences, doing analysis from the study.
Sorry, Dr. Palnivel is Associate Professor in the Department of Preventive and Social Medicine Department in JIPMER. Sir is holding currently a Joint Member Secretary of JIPMER Scientific Advisory Committee, and he's a nodal person in the Center of Excellence in JIPMER for a National Action Plan for Climate Change and Human Health, Government of India. And he's holding various top post member in various committees in JIPMER as well as in nationwide. And his areas of interest includes tuberculosis, HIV, viral hepatitis, and operational research. And Sir is one of the important person we contact for any research related assistance. Thank you. Thank you for accepting an invitation for this.
Thank you, sir. So I'll be covering some of some of these topics, inference and observation studies, what are the issues, and considerations in calculating sample size, commonly used statistical tests, how to report the results in general principles. I'll touch upon diagnostic tests and prediction equation models. And finally, some tips about the reporting guidelines. So inference and observation studies, the study design and the statistics go hand in hand. So small statistics depend upon what kind of study designs you choose. So the topic is statistics, but without a good understanding about the study designs, it's difficult to choose the statistical test or what is statistical approach you have to choose. So these threats to validity. So I have a hypothesis, I do a study, I take two groups and compare. So the results, so whether we can trust these results or not can depend upon three things basically. One is about the bias, the way you conduct the study. You can start from design or you implement the design, implement the study. Your recruitment of participants or your performance of the experiments or data collection or even analysis and interpretation. Okay, all these places the bias can creep in. Then there is something called confounding, whether the results you are getting is because of something, the third variable, which can affect your results. And there is something called a chance factor. Okay, so there are a lot of study participants or the patient, but you're using a sample of participants. Okay, by using samples, we may make the results or the difference between the groups you are getting. Okay, maybe because of simply by chance. So good understanding of study designs again is a prerequisite to understand the statistical concepts. So when you consider sample size, the most important thing is like when postgraduates come to us for sample size, they come with the previous study. So the previous study has shown the difference, let us say, in complication rates between two procedures for 20% also on sample size for this. So that is not the criteria for sample calculation. So something called clinically meaningful difference. I've given a reference here. So it's very important what is the difference between the two groups or three groups. That is very clinically meaningful. In practice, how much, whether a difference of 5% or 2% makes it significant. Okay, to find out that one, we have to calculate the sample size. And also there are two errors which are possible when we do studies using sample individuals. One is your alpha error, otherwise called as the confidence. The second is called the beta error. So alpha error, I am not taking the null hypothesis or alternate hypothesis, simply telling alpha error is something called false positive error. So false positive error, it is something like when you are looking at difference between the two groups. Okay, in truth it is not there. Your study may falsely say there is a difference. This is called the false positive. How much error is acceptable to you? Okay, usually go by 5%. The other error is called the type 2 error, other is called the beta error. Okay, so that is in case there is a difference between the two groups. That's what you're looking for. Okay, whether your sample of your sample study will pick up all 100% of times, or sometimes it may miss the difference which you're looking for. This is called the power of the study. That is called the beta error. Okay, we can take power 80%, 90%. That means the error rate is 20 or 10%. So these alpha and power or beta are conventional. The statistician can tell you that it is 5% or you can take 10% or 20% beta. But how much difference you are looking for, that has to come from the subject expert. Okay, so you are doing the study, you must be knowing how much difference will be useful in your real world practice. Okay, that difference, that input you have to give for the statistician. And all the things depends upon the number of groups, whether you want equal size, unequal size, or it's a pre-post study, or it's a parallel design, all those things also are consideration for the sample size. And the p-value is just the after collecting the data, okay, how much is the alpha error at the end of the study? That is called the p-value, the probability of the results. Okay, just by chance, what is the probability? Is it 1%, 2%? Accepted error is 5%. That's what it is, the 0.05. Sometimes the sample size, generally we calculate for the primary outcome or the primary objective. But here, secondary objectives, we compare between the groups. If it is not coming significant, then you go back and see whether you have adequate power to compare this. This is called the post-hoc calculation of the power. At the end of the study, with the available data, you go back and see whether you have the power or not. This is also done. Next, I'll touch upon commonly statistical tests. So there are 3 slides on this. I'll touch only the important statistical tests. There are a lot of assumptions for the statistical test. I will not tell all those things, just to introduce for the residents what is the common statistical test we'll be using. When the outcome is categorical, let us say mortality yes, no, complication present absent, or there could be more number of categories, need not necessarily a dichotomous or binary. Okay, you can have mild, moderate, or severe complication. Okay, it's basically categorical outcome. And you have independent groups, 2 groups or more than 2 groups. So the straightforward test is called the chi-square test. That's what we use for the comparison of proportions. It has to be the only assumption is the independent groups and the outcome should be categorical. Example is the percentage of complications in 2 groups or more than 3 groups. We use the chi-square test. And if at all like a pre-post, in the same group you are doing a pre-post and the outcome is categorical, we use something called a McNemar chi-square test. Then for a continuous outcome, it's continuous outcome example is the blood pressure or your brain volume, hospital stay, the number of days of hospital stay. These are example for a continuous outcomes. If it is 2 groups, the groups are independent. 2 different procedures or 2 groups of patients. So it is we use independent t-test or it's called student t-test. If this outcome variable, for example, the hospital days or something like a pain score, which is not following normality, we go for a non-parametric test, which is a man-with test. Okay. So simply remember comparison of proportions chi-square test, comparison of means is some form of t-test. Okay. When it's not following normality, we go for something called a man-with test. So the dependent group, what is this dependent group? So either you match these 2 groups based on age, sex, or the disease severity. So once it is matched, it is called a dependent group or related group. Or sometimes it is a pre-post. Okay, before surgery, what are the average pain scores? After surgery, what is the average pain scores? Okay, this kind of situation is the parity test. If your pain scores are the pain scores basically score, we need not use the parity test, go for a non-parametric test. If your outcome variable is following a normality, you can go for a parity test. Next is groups more than 2. It's not like 2 groups. If you have more than 2 groups, the groups are independent. The 3 different groups, we go for something called ANOVA. If it is not following normality, use something called Trescal values. If it is different groups, for example, anesthesia or physiology, they do repeated after surgery, 10 minutes, 30 minutes, 1 hour, 2 hours. The repeated measurement, we go something called the repeated measures 1 hour. So these are the common tests you should be aware of. Next, I'll come to the reporting of results. So everyone is aware of p-value. P-value less than 0.05 statistically significant. That's a common way of reporting the results. There's another way, something called estimation method. The p-value comes from as the output of the statistical test. Okay, whether what the difference you are seeing between the groups is because of simply chance or it's really existing in the your group of patients. That's what the p-value says. Okay. But estimation gives much more information than the p values. The confidence interval, for example, between the 2 groups, we are comparing the complication rates. In one group, it is 2%, other group, it is, let us say, 10%. The difference is the 8% difference. Okay, this 8% is true in the population you have chosen your study. But how much this can be vary in the large population from this sample is derived. Okay, this variation can be this called uncertainty interval or the confidence limits that can be given by your CAs. Okay, it's better to report confidence interval. Okay, sometimes reviewers will come back or also give p values. So it's better to report our results using p values and confidence interval. But confidence interval gives more information. Okay, it gives some estimates about the uncertainty, how much it can vary actually in the population. Okay. So p-value is not enough, and also there is something called absolute measures which are very useful. Rather than reporting there is statistically significant difference in the 2 groups. Okay, you can give how much was the mean difference in the duration of stay, or how much was the difference in the percentage of complication. These are called absolute measures, along with the confidence interval. There are some relative measures. People do trial. Okay, they do case control studies and report only the p-values. You can report something like compared to one group, how the other group measured in relation to that. It's called relative risk or the odds ratios. Okay, these things come under the something called relative measures, which are easy to interpret, use more information than the p-value. Okay, so these are some suggestions for the how to report the results. And there is something called effect size. This is for continuous variables. Okay, there are different forms of effect size. Cohen's D or L. Okay, not very commonly used, but these are available. Coming to diagnostic tests, everybody is aware of and predictive values and diagnostic accuracies. Okay, so we can see studies consistently reporting these parameters. But it comes to likelihood ratios. This is again very practical, very useful measure, but it's often not calculated or reported when you're the diagnostic studies or in screening tests, the new tests we are comparing it to the established tests. So these likelihood ratios gives more information. For example, positive likelihood ratio, or for your real practice, you are doing a simple procedure or an examination. If it is positive, if you are able to calculate the likelihood ratio, the positive likelihood ratio is more than 10. It is useful for ruling in that particular condition. If the test is positive, you can clearly say that definitely this person may have the particular condition. You can go for a invasive or confirmatory test. Okay. If the particular test is negative, this likelihood ratio of the particular is the test property. Okay, the particular test or examinations, the likelihood ratio negative is less than 0.2. You can clearly rule out the disease. So you can save the patient from an invasive confirmatory procedures or something. Okay, so these two things, if residents are not aware of, go back and read. These are two important concepts: the positive or negative likelihood ratio. Okay. Then other thing about agreement is when you don't have a gold standard, for example, imperfect gold standard, whatever the current test, then we can, the new test is compared with the existing test using something called agreement. We calculate something called Kappa statistic. So then coming to ROC curves, ROC curves are used when you have a new parameter which is a continuous or something like a biomarker, and your gold standard is like let us say biopsy proven like malignancy SR is a categorical one. Okay, to assess the usefulness of this new biomarker which is continuous variable, you can calculate something called the area under the curve. Less than 0.5 is useless. So 0.5 to 0.6 also not very helpful. Anything 0.6 is good. Okay, that's how we interpret the area under the curve. And again, there are methods to calculate. For example, already there is the one test is there. You can compare area under the curve. Between two curves, you can compare which one is doing better. And it has some, for example, if you're doing multivariable analysis, okay, it's not only this biomarker. There are already multiple clinical like findings are there. If you want to add all these things, then you can calculate a combined area under the curve as well. Okay, so this is again less explored or less used statistic. That's useful. So next is the prediction scores and models. I can see many analysis coming with the usage of scores, like SOFA scores, or there are a lot of results comes with a lot of scores. This thing. So if you use either for like a diagnosis or for a prognosis or predicting mortality or complication rates, all those things. So one is the first thing we have to look at it before using it, whether it's validated or not. There are multiple levels of validation: internal validation, external validation, or whether it's validated in our setting or not. That's very important before using a score. Second is sometimes our residents do. We have a lot of the patients available. A lot of patients are available. They collect data meticulously. Then the time of statistical test they stop in between, not completing the complete analysis of the statistics. Okay. They do multivariable analysis. They are able to predict the mortality of this thing, but they are not coming with a prediction model or a prediction score. Or if they use a score, there's already an existing score. They're adding one biomarker to the existing model. Okay. Then the new model has two properties which needs to be reported. One is called discrimination, other one is called the calibration. Okay. So these things, if at all, this is a good reading materials. And then next slide, I will share some of the articles. You can go back and read. So discrimination is something like you look at the area under the curve, right? Whether this model, the combination of it could be like biochemical test, clinical finding plus biomarker, whether it is able to discriminate those with the disease or not. Okay, that's about the discrimination. Second is about the calibration. Across this scores, the scores can have a range from 1 to 20. Let us take any exam, any score, 1 to 20. Across the range of scores, whether it is predicting correctly or not. It is a comparison of the predicted versus observed. So this is another important property of the score. Some scores will be very useful, okay, in ruling out the disease. Some may be in confirming the disease. Okay, how good is the property of this particular score? That's again very important. Whether you take the score for your practice or you develop a score, this again has to be reported in your analysis. So these are the two articles. One is assessing generalizability of prognostic information, published in Annals of Internal Medicine. The second one is discrimination calibration models, published in JIPMER. These are very good, simply written in simple words, easily explainable, and there are multiple more methods there rather than what I put in the slides. The last section is about the reporting guidelines. So one is knowing statistics is if you're not very much interested in research also, to understand what the others publish, to understand the evidence published, it's good to know about some of the basic statistical concepts. Okay. So this is not like reporting guidelines, basically for when you do a study and you want to submit a manuscript, how to report it. But I also take it as an like there are detailed guidelines how to report it. So this also gives like some insight in what statistical tests, what predictors, how to the model, what thing needs to be done in a particular study design. Okay. So there are something called equator network. So this is one place where you can find the this reporting guidelines for multiple types of study designs. Okay, like PRO for the observation studies and consult for RCT. STARD is for basically standard reporting of diagnostic accuracy studies, and a tripod for the transparent reporting of multivariable prediction models for prognosis or diagnosis. Okay, so this is one place where you can go. There are a lot of critical appraisal tools for digital interventions in any field, digital intervention, qualitative research, for meta-analysis. So this is one place where you can find the reporting guidelines. Again, it's useful reading material to understand the research methodology and the statistics part. Okay. So that's all from my side. Thank you.
Thank you, Dr. Paliju, for a wonderful lecture as always, and it's open to the floor for any questions. Many of the postgraduates are writing protocols. Anybody would like to ask any questions? Some of you might be writing papers. Any clarification for any aspects of statistics? We wonderfully covered briefly, touched upon all the important aspects. Dr. Panil, I'd like to ask you that if any postgraduate residents will come to you to discuss the statistical aspect in a protocol, what points they should know before you discuss with them? So at least they will come prepared with those aspects.
So one is what is the research question or research hypothesis? That's very important. And what design they choose, whether they want to go for a prospective design or like a case control design or doing a trial. Number of groups, and the most important thing is how much the clinically meaningful difference their interest.
So many times they come when the guide has almost finalized the protocol, and they will come with the statistical aspect. They'll say, go to the department, meet Dr. Pallivel, find out the statistical components like the sample size calculation and other details of statistics. So let's say that time the design and all is already finalized. So that time, at that point of time, what are the points you would like them to know, and they should be aware of it before they discuss? Then only there will be a good, meaningful discussion. Otherwise, they will not understand exactly what you are telling them.
Though they have orientation, they have just joined, and many times will not give the information to the residents. So many times the guide always accompanies through the phone we discuss. So one is like what is the expected outcome in each of the groups? At least that information is very much needed. Otherwise, alpha and beta will like conventional we can go, but what percentage, let us say, a complication rate in this thing. So we expect what will be the in routine like standard or what will be the expected rate of complication. If you're trying with a new procedure or a modified procedure, what is the expected rate? So how much difference we're expecting?
How much difference will be meaningful?
Difference. So if we are able to give that information. Yeah. So otherwise also we'll ask like sometimes like sample size comes out to be more, and how many patients will be available during 1 year for logistic reason, like whether we able to cover it in a year or not.
And maybe some references,
based
on which you'd like to do samples. Thank you.
Some of the studies that we are doing, the duration, most of the studies which we are doing, the duration, very short, like 1 year, 2 years, and all that. Authentic is this one, and the credibility of the study, sometimes I wonder. When they come back to the elsewhere, what they're doing, it's for a number of years, 6 years, 7 years, and all that. That's one doubt I always have, because they are pushing our PTs, because they decide to choose the topic by the time the first year is over. Then he goes for the exam in the third year. scrambling for the entire statistics in a 1 year period. So, and also there's not much of a peer review and things like that. So are we losing the credibility itself?
So the,
Big question. I never, first time I'm listening to a lecture, on this and one cannot make it. It's interesting. This was very, very interesting to me actually. I enjoyed this. I'm happy that I remain to sit here and I really appreciate it. What can you-
for residents, it's basically how to do research. We are not very much really interested in to answering novelty research questions, more of feasibility. Within 1 year, whatever the topics they will be able to complete, and it's a requirement for their MD or MS. Even otherwise, also in other branches, even faculty projects, we don't have the system of following up the patient for a longer period of time. That building the cohort and long-term follow becomes very difficult because you don't have unique identifier. The patient may go to different hospitals and getting the data. And that restricts the long-term follow or the chronic condition follow.
What I want to say, because they random, some patient, some number, today some number we had. Maybe they should link his Aadhaar card with the long run. Some number should be there. Whereas the hospital, hospital. I mean, somebody else will be some other work on the same time.
Thank you.
Thank you, sir, for shedding light on statistics for surgeons. I now request the chairpersons to felicitate Dr. Palnivel.
Stop sharing.
Thank you, sir. Thank you, ma'am. Next, we have an interesting video lecture by Dr. Amit Patel on bariatric surgery, King's College experience. Sir will be joining us online from London. To chair this session, I request Dr. Fani Krishna Raula, Dr. Vishnu Prasad, and Dr. Vaidisharan to kindly come to the dais.
Sir has to share screen. Yes, sir. I think he will. Should I tell him? I think he will not, sir. He's in UK now.
But we have to make sure the screen is that we have to
No.
make
Oh,
it
like
in the
that.
full
Oh,
screen.
okay, sir.
Put spotlight.
Good morning, Professor.
Hi.
It's actually 4 p.m. here in India. I had the privilege of watching Professor Patel when I
He's not
visited
shared
King's
screen.
College in 2017.
Oh, now we can mute
Professor
ourselves.
Patel,
Hello.
came HPB. I had the opportunity of seeing him doing a laparoscopic liver resection also when I was in King's. So he has done plenty of bariatric surgery, including the laparoscopic gastric banding, laparoscopic Roux-en-Y gastric bypass, laparoscopic spleen gastrectomy, and the laparoscopic duodenal slit here. So I request Professor to share your experience in 15 to 20 minutes. I'm very excited.
I share screen.
This is connected to that, which is also connected to that. This system is also picking up your voice. Which is there in YouTube. Only answers and so.
Thank you very much. This is the. Can you see my screen?
No, we can see you only, but you have to share the screen. I think.
I thought I shared it. Okay, let me go back. Sorry, hang on a sec. Let's go to this one. Can you see it now?
No. Share.
I'm sharing the screen.
No. Sharing is
Yes, yes.
Can you see that?
Now we can see.
Okay, thank you. So apologies. This is the historical timeline for. Apologies. Okay. This is the historical timeline for bariatric surgery, and you can see that operations have come and gone over years. And the sleeve was the last real operation in the middle bypass that have been sort of instigated into the armamentarium. There are new operations like the SARDS, the SARCs, and various other bipartition operations, which really haven't been fully evaluated. I think those are slightly experimental. Our journey in bariatric surgery, specifically my journey, began after a fellowship with some eminent laparoscopic surgeons, George Fielding, Les Nathanson, and Nick O'Rourke. And that's where I learned the skill set really to develop my laparoscopic approach to various surgical interventions. And specifically, I was appointed at King's College Hospital with Professor Benjamin in 1999 as an HPB surgeon and minimal access. And my remit was really develop laparoscopic surgery, both in general and HPB at King's. At the time, we were only doing laparoscopic cholecystectomies. And really that was the remit, is to develop and enhance. And in that era, I did not just upper GI or HPV, also did colorectal and anything in the abdomen laparoscopic.
If you get the mic a bit closer.
Matrix, we were doing John Rennie, we did a small number of VBGs open. And that was
Can you speak to the mic? We have difficulty in listening to you. Okay.
The first 3 years were difficult.
Okay. You can continue. Continue.
The first, and you can see here. And you can see here that the initial curve is exponential in terms of numbers of cases over the.
I increase volume a little bit.
And you can see here that the initial curve is exponential in terms of numbers of cases over the first sort of 7 years, 8 years. And it exponentially rose and has risen since, with one exception during COVID, we had to stop all our bariatrics. These were the numbers that we performed, the case mix. And you can see banding was a fair percentage, but room-wide gastric bypass was the main surgical intervention. Revision rates were only about 6% at that stage, and there's a few sleeves and DSs at that time. The concept of centers of excellence was established, especially in the US. And the mortality of gastric bypass was estimated at 1 in 200, but with centers, established centers, that was reduced to 1 in 500. Whether that's the centers or the experience that's changed the mortality is questionable, really. This did, of course, come into the UK, and there were several centers of preferred providers for obesity surgery. And King's became one of the preferred providers in the UK. There are only 7 in the south, from Cambridge and Oxford down to the coastline. There were 7 centres, and essentially
this was competitive for us to become one of the preferred providers. In the southeast of England, only King's was the main centre at this stage. Our smaller centres have grown. The service at that stage consisted of a variety of people engaged now at this stage. So it's taken quite a while to get everybody on board. But I think at that stage, everybody could see the merits of doing obesity surgery. And our team has grown. As you can see, that's me initially started off, then Avril Chang joined me, my colleague, and she is an excellent educator and teacher, and very much into involved in training. Shamsi Al-Hassani, who was established at the Princess Royal, and he's an excellent surgeon. Then came Professor Rubina, who was the first chair of metabolic surgery at King's, and he doesn't need no introduction, really. And my two junior colleagues, Sacinda Ramar and Spiros Pantifagis, and then subsequently we got Hiba Shanti, who's from Jordan, and has just joined us. What is interesting are patients of Campbell, southeast of England, and specifically southeast London, as a very variable ethnic minority, and is socioeconomically deprived. And realistically, with that comes a lot of comorbidities, as you can see in this chart. Number of comorbidities increased. The national average is in the black line, and our comorbidity risk factors are in the purple line. And you can see that this is actually markedly increased risk for patients having so many comorbidities. If you took a snapshot of my waiting list, you would find that a third of them would be over 150 kilos, and you'd find that a third would need HDU or high dependency units following their surgery. This includes patients with cirrhosis, with renal failure, and on hemodialysis, etc. So there is a highly complex group of patients that we have catered to. And we do provide a full range of bariatric metabolic surgery. Majority of my colleagues perform the sleeve and bypass, while some of the more complex procedures such as DS and SARDS are performed by myself, and many bypass by Shamsi. So we have a whole range of procedures that we perform. Some of the endoscopic procedures are also being performed. A lot of work with stoma-fix, endobarrier, and the endoscopic sleeve gastrectomy is being performed in a trial format, but I suspect the results in the long term will not be good, not going to be as good as I would like, and therefore, until we finish the trial format, we won't expand it fully. The revision surgery has increased, as we would expect with any service like this. And the number of revisions that I do is over 30% of the procedures. The tertiary surgery for complications, we perform. A lot of patients go to Turkey because of cheap cut price surgery, and then come back. And we have to essentially help deal with their post-op follow-up and complications that occur. Other UK centres also refer to us the more complex procedures. In terms of innovation, one of the problems is bed pressures. And so one of the things that we have, our argument has been that bariatric patients just can't wait on the waiting list. And if you look at the 10-year survival of patients with cancers, these are all the different cancers, and the 10-year survival in percentages up here. You can see that bariatric surgery in high-risk bariatric patients has a mortality associated with it, and is quite is actually more risky than a variety of cancers here, while less risky than these cancers. So in reality, it isn't something that we can just leave to the end of the list and when we get an opportunity operate on. We do have to drive this, and this is one of the arguments with the management that we've had. And this is Francesco Rubino's work, and it is actually very interesting, I think. And that's the argument that we're pushing in order to get bed capacity. The other argument, of course, is if they're on the waiting list for long enough, invariably the hospital is forced to give us more operating time. And of course, day surgery, we try and utilize as much as we can, specifically in terms of banding and other procedures. Or 24-hour day surgery concept we are using as inpatients, but this true 24-hour, 12-hour day surgery we're not quite managed yet, apart from banding. In terms of other innovations that I was quite keen on single incision surgery, and did a lot of single incision surgery. And you can see that the approach to single incision is to make one cut and then do the whole operation through that cut. And then rather working in 5 ports coming in through different angles, we're actually working through one single channel. And this is difficult, and it took a lot of practice, but essentially, gastric banding, single incision takes 10 minutes longer than normal banding procedure. Is there any benefit? We think the pain is slightly less. Did it change our discharge? Not really. It's essentially the same discharge dates in the day surgery. Percentage of patients that actually got discharged was similar. Cosmetically, you've only got one incision, and initially there's a difference in cosmesis, but after a year, there's no difference in cosmetic results between single incision and multi-port. So realistically, of all the different procedures that we did, you can see the ones in blue are our bariatric procedures, and then we've even done liver resections for single port. From there, since there was no advantage, we sort of initially tried Percuvance, and I don't know if any of you know Percuvance, but essentially that is a 3mm instrument, which then we add a 5mm tip to on the outside, and then use that as a 5mm instrument. It's an excellent device, but eventually, this is the liveling that did a sleeve gastrectomy with Percuvance, and subsequently, unfortunately, the company stopped distributing it for some reason. Robotics, we've just acquired our first Da Vinci AI, and the robotic program is about to develop in general surgery. Hopefully this will help with the complex bariatrics and in terms of revisional work. My personal view is that we will use the robotic platform I will use the robotic platform to try and increase my experience, and then I use it in the HPB practice. These are all the people that have been involved and have played a crucial role in the development of the bariatric surgery. There may be some people I've missed off in terms of pictures, but it's not a fully comprehensive group. Once again, I hope you luck in your development of the bariatric program, and take any questions. Thank you. Hi.
Can I ask you a few questions?
Please, let me get rid.
Currently, if you take 100 cases of bariatric surgery at King's College, what percentage are sleeve gastrectomy? What percentage are Roux-en-Y gastric bypass? And how often you do single anastomosis bypass procedure?
So the percentage is probably a third will be revision technique, but that's different. Of the remaining 60% will probably be Roux-en-Y gastric bypass, and about 30% will be sleeve gastrectomy in my practice. Overall, my colleagues do more sleeves. If you took everybody together, it's probably a 50-50 split between sleeve and bypass. The single incision, it's too difficult. Unless there's a real reason, I won't do it anymore. Only because it's time consuming. There has to be a reason for us to do it.
Hello, Professor. Do you do single anastomosis bypass, that is mini gastric bypass?
So we do it occasionally, but I'm not a fan of the mini bypass, partly because of the bile reflux, etc. And it is there and it's present. And Mr. Al-Hassani does more mini bypasses on the Crewe site, on the King's Denmark Hill site, which is the main King's site. We tend to do the Roux-en-Y.
What is the selection criteria for each procedure? This is a postgraduate program. So if you elaborate which patients go for which procedure, it would be nice.
Yeah. So our approach is very, very straightforward in the sense that the patients who are super obese, we tend to go more for the sleeve because it's much easier to get them down a certain stage in terms of their weight.
Can you stop your screen sharing so that your image will become bigger? Can you stop your screen sharing?
Let me get rid of this stuff. Can you get rid of? Hang on. Yeah, that's better.
Yeah, now it's yeah.
Apologies. So I think realistically, in terms of what patients and why, diabetics, we tend to go more for the bypass. And for the super obese, we tend to go for a sleeve first, and then a second stage, whether it's a DS or a SRDS, is the approach I tend to take. That's the super obese. So those patients over about 180 kilos plus. And those patients who have reflux, we tend to go more for the bypass. So it's a sort of a variety of reasons that we change which procedure for which indication, really. The sleeve has its own problems. The problems of reflux are a major issue, I think, and that's the reality. If you look at 20-30% of patients having reflux, and then some of those having to be converted to Roux-en-Y gastric bypass, I think sleeve is a much more problematic operation. And specifically, my personal view is that once you actually get the reflux side of things, it becomes more of an issue. And I think the long-term data on the bypass, it stood the test of time to some extent. Yes, you do get weight regain with all the procedures to some extent. And the sleeve does give you that opportunity to do something else. So it's really a balance, and it's a judgment call as to which you go for.
I just want query about the endoscopic sleeve gastroplasty. Now it's coming up in a big way. So what do you think is going to be the future in terms of the long-term results, and where is it? What is its role going to be in the management of bariatric patients? Endoscopic sleeve.
Yeah, the endoscopic sleeve gastrectomy, I think the results are variable. And if you look at all the people that have had the endoscopic sleeve, and yes, some of the data is slightly skewed because it's based on intention to treat. And if you look at the data carefully, some of it you find that they've had an endoscopic sleeve, then had a sleeve gastrectomy. And the data comes out as intention to treat, and therefore it looks quite good. My personal view is the endoscopic sleeve is too variable. And if you're doing a sleeve, if you look at a sleeve and you look at an endoscopic sleeve, you can quite get the same degree of restriction. And the only other thing I would say is that realistically, the combination of endoscopic sleeve and maybe GLP-1 agonist may be a good approach. But for the moment, we're waiting to see what the first 50 are like in the endoscopic sleeves. My personal view is it's not the way forward. I know everywhere in the world, everybody's doing ESG. But we're sort of, I've stayed back. I've been a bit reluctant.
In India, the OAGB is so popular here. Actually, we restrict low and high gas level only for the patients with severe reflux. So that's one thing. I think in the UK, it's absolutely not at all popular. It's the average in India across the board, all surgeons have moved on to OAGBs.
Yes.
For the postgraduates, I just summarize what Professor has told. That in their center, they do super obese patients with the multiple comorbidities. They do a bypass, and the sleeve they do in less number of patients. One of the contraindications for sleeve is reflux disease. So, and around 30 to 40% of their work is on revision bariatric surgery. So, what you have to do know is what are the indications for bariatric surgery and which procedure is done for what BMI, and BMI with the comorbidities, what would be the procedure of choice. General guidelines will be this. The restrictive procedures are for lower BMI, that is less than 40 BMI. And the band in India is very rarely done nowadays, very rarely in teenagers maybe. But band as such has not been a very good procedure in Indian patients. And endoscopic procedures are still under evaluation, and maybe it will take 5 years for us to get the results of endoscopic procedures. Sleeve is a very common procedure done in India, and as already told, it is contraindicated in patients with hiatus hernia and reflux GERD patients because it aggravates the GERD. Patients with the comorbidities and high BMI of above 45, 40 or above with multiple comorbidities, are patients with BMI more than 45. Bypass would be that is a restrictive plus a malabsorptive procedure would be the correct procedure. But in India, more than a low gastric bypass, mini gastric bypass is popular because of ease of doing the mini gastric bypass. There are pros and cons. You can read up what are the disadvantages of the mini gastric bypass and what are complications of bariatric surgery, long term, as short term, as well as long term complications, and what is the follow-up protocol that is needed. These are the headings under which you have to prepare the topic of bariatric surgery. Anything to add?
The only thing I would add is that those super obese, which are, 180 plus, a sleeve is a safer option because rheumatoid gastric bypass in that group is a very difficult operation. So
Part
we
of
tend
stage procedure and staged, right?
as a stage, as a stage procedure.
Thank you very much, Professor. Thank you very much.
Pleasure. Thank you.
Thank you, sir. I thank the chairpersons, Dr. Fani Krishna Raula, Dr. Vishnu Prasad, and Dr. Vaidishan chairing the session. Thank you, sir.
Next, we have a case presentation on soft tissue sarcoma by Dr. Aishwarya and Dr. Divash. I request the examiners, Dr. Jagdish, Dr. Uday Shamra Kumbar, and Dr. Balamurgan to come to the dais.
Yes, sir, is here only. There's a my metal outside. There's a outside. There's a outside.
Good evening, everyone. Today I'll be presenting a case of a 68-year-old gentleman hailing from Sinhala, farmer by occupation, belonging to lower middle class, according to the modified on the social economic scale. He presented with complaints of swelling of the back for 1 year, ulceration over the swelling for 3 months, and pus discharge for 2 weeks. Coming to the history of present illness, patient was definitely all right till 1 year back when he noticed the swelling over the right upper back at a previous scar site. It was insidious in onset, initially of size 3 cross 3 centimeter, which was gradually increasing in size with rapid progression noted over the past 4 months to attain the present size of about 16 centimeter. He complained of ulceration over the swelling, which occurred following a procedure done 3 months back, which progressively increased in size with purulent and blood mixed discharge for the past 2 weeks. He also complained of pain over the swelling following the ulceration, which was aggravated on movement with slight relief on taking analgesics, with increase in severity of pain over the past 2 weeks. He also had complaints of generalized body ache, fatigue, and nausea for the past 2 weeks. There was no history suggestive of impairment in the right upper limb function. There was no numbness, fatigue, tingling sensation, or any swelling. There was no history of trauma preceding the onset of swelling or during the progression of the swelling. No history of fever. No history of swellings noted elsewhere in the body. There was no history of cough, hemoptysis, shortness of breath, chest pain. No history of abdomen pain, distension, jaundice, weight loss. No history of bone pain. No history of headache, seizures, or any focal neurological deficits. Coming to the past history, patient had complained of developing a similar swelling 2 years back at the same location without any ulceration, however, and for which patient underwent excision in August 2021 with an uneventful recovery. Prior to the, however, there was no workup done for the swelling. He also did not receive any medical treatment or radiation following the surgery. The nature of the swelling was not informed to the patient. He was diagnosed with diabetes 1 year back and he was on irregular medications. He's not a known case of hypertension, asthma, or tuberculosis. He had no history of exposure to radiation or any chemical exposure. Coming to the family history, there was no history of similar swelling in any of his family members. There was no history of malignancy in the family. Personal history, he takes a mixed diet. He has normal bowel and bladder habits. Sleep pattern was disturbed due to the pain over the past 2 weeks. He is habituated to chewing tobacco and betel nut. He is not habituated to smoking or alcohol consumption. He has no known drug allergies. Treatment history. For the present swelling, patient had gone to a local hospital in December 2022, wherein he gives history of a procedure being done and sample being sent for tests. Following which he was informed about the possibility of a malignancy and he was referred to a higher center for further management. He also gives history of use of native medications for the swelling following the ulceration. So summarizing the history, a 68-year-old gentleman presented with gradually progressive swelling over the right upper back at the site of a previous scar for 1 year with rapid progression over 4 months associated with ulceration, pain and pus discharge from the swelling with no functional impairment, no significant family history or any symptoms suggestive of metastasis. He also had a history of excision of swelling at the same site done 2 years back.
2 years back, swelling by the biopsy available for the
Like,
water disease. There are very unlikely somebody removes a swelling, doesn't take the biopsy. So you take proper history and find out what the patient is for. 2 years back, I'm not.
Yes, sir, 2 years back. Yes, sir.
Where was the surgery done in a government hospital or a private hospital or a practitioner or a quack or something like that? Could you get the history?
They said that it was done in local hospitals, so like local
Very
CH.
unlikely doctor to remove the tumor, not take the biopsy, not send for biopsy. It will try to probe into the history and find out what the biopsy is.
You probed, so like I asked.
You are sure you are not missed anything.
Yes, sir.
And you are told you'll be perfectly all right.
Yes, sir. Like he didn't have any imaging done or even any biopsy done, and after the swelling was removed.
Swelling was removed.
Yes, sir.
Whatever was removed, it was not sent for separate examination.
No, sir, it was not.
Okay.
What was the size of the swelling when it was excised 2 years back?
That was around 4 centimeters.
What was the duration?
3 months, sir. 3 months, but there was no ulceration at that time. Similar swelling, but no ulceration.
Was it done under GE or local anesthesia?
The local anesthesia.
The local anesthesia. So that again, that gives a clue to what can it be.
I find funny is that incidents in onset you are saying. What do you mean by incidents in onset? So many events, 2 years back, this happened, that happened, and using the word incidents in onset. So you use the term incidents in onset and swelling like this.
He had
Understand pain or something wet or but very rarely do you get a swelling and incident onset. The patient had 2 years back a swelling or excised, then went back. It's not an incident onset. Everything is clear. So you don't use the word loosely. That word doesn't have a meaning in this patient.
Another thing in the history, it was mentioned that the doctor told patient that probably it is a malignant. No? Somewhere in the history it was there.
this time, this swelling, current swelling. Sir.
Current swelling, okay, not the previous one.
Not the previous swelling.
What is the interpretation of this history?
So, like, considering that it has recurred over 1 year and the progression of the swelling and the recurrence over the same site, I would like to keep it as a recurrence of a malignant swelling. Possibly something.
Good evening, everyone. I'm going to proceed with the examination finding. He was recommended a well-night room after taking a Bhagal consult with adequate exposure. He was conscious oriented to time, place, and person. He was well nourished with BMI of 23. Good score was 1. There was no pallor, icterus, sinuses, edema, or any lymphadenopathy, cervical and external was checked. First rate was 92, bits per minute.
There is certain no or lymphadenopathy. The correct term is generalized lymphadenopathy. Lymphadenopathy alone may be related to the tumor also. But in a general example, the better term used is generalized lymphadenopathy. Because here is a lymphadenopathy, bracket, you write cervical lymphadenopathy. Say generalized no. That should be the correct way you present your case.
Blood pressure was 140/85 in the right arm in the sitting position. He was orbital at the time of examination. Respiratory rate was 16 per minute. On inspection, solitary glass, well-defined swelling was present on the size 16 plus 16 plus 18 centimeter, involving the right scapular region, extending approximately 8 centimeter from the midline to the posterior axial line, and it was 10 centimeter from the acromioclavicular joint. All the margins appear well-defined, and skin over the swellings appear shiny and stressed. And there was a previous surgical scar noted, mentioned in the yellow arrow. And also was present approximately 8 + 6 centimeter size over the center of the swelling with underlying agents and tumor tissue and necrotic slope were forming the floor. And beginning of the schema and erythema were present at the margin of the ulcer. There was no change in the size of the swelling on the movements of the shoulder joint and the upper limb. There was no any visible wasting of the limb on the affected side, and the limb structural region was normal in appearance. On palpation, there was local rise of temperature and tenderness was present over the swelling. A firm swelling of size 15 + 16 + 8 centimeter was noted over the right scapular region with a well-defined superior, inferior, lateral, and medial border. Surface of the swelling was smooth, and the skin was stressed and not pinchable over the swelling. Central ulceration was noted, and there was no any pulsations felt over the swelling. Mobility of the swelling was restricted during the extension and lateral rotation of the shoulder, and the full range of movements was present at the shoulder, elbow, and the wrist on the right side, that was the affected side, and all peripheral pulses were also normally palpable on the right upper limb. There was no any limb edema or muscle wasting noted on the right side. Sensations were intact. On auscultation, no bleed was not over the swelling. On systemic examination, there was normal cardiovascular examination was normal, and on respiratory examination, bilateral vesical bed sounds were present. On abdominal examination, abdomen was soft, non-tender, and no ergonomically was appreciated, and there was no ascites. Now I like to summarize it.
You are not mentioned about the mobility of the swelling. What are it? Is it attached to a scapula or not? Is it attached to scapula or not? You have not been made it clear in a. You got a swelling right over the scapula. What is the relationship to the scapula clinically?
Swelling was mobile, sir, on both vertical
Are
and
you saying it's 3D mobile or underlying bone?
like underlying muscle structure was visitors.
It's lying over the scapula as I can make out. Is it adherent to the scapula or not adherent to the scapula?
It's not adherent to the scapula.
How do you say that?
Because it was mobile on the both vertical and horizontal
How
direction.
do you fix the scapula?
Uh,
How do you fix the scapula? How do you know it is not adherent to the scapula? It may become chest wall. But how do you know it's not fixed to the scapula? If it's really mobile, you may be moving within the scapula or the chest wall. But how do you not fix to the this sort of case, most people fix to the scapula. So I want to know the fix to the scapula, how did you find out?
So
How did you fix the scapula?
in flexor and medial rotation of the shoulder joint, I would say the mobility, sir.
And you move the shoulder joint, what happens to the swelling?
Like I fixed the scapula, sir, by
When you move the shoulder joint, the scapula also will move. Does the swelling move the scapula? Does it remain independent of the scapula? When you try to answer mobility, you are going to move the scapula also. What I want to know is clinically, can you make out adherent to the scapula or not?
yes, sir, clinically, like it was not attached to the scapula. So
How is it?
I fixed the shoulder.
How did you fix the scapula? How did you fix the scapula? All over the scapula. How did you fix the scapula?
Medial rotation and flexion of the upper limb, sir.
You didn't get the question. See, the question is whether this swelling is fixed to the scapula or not. What is the plane of the swelling? It is involving the skin. What is the deeper plane of the swelling? Yes, you can also answer.
With the muscles in a relaxed position, then we have it is really mobile, and also like then specific actions of the muscle there was restriction like
Give us specific which muscles are there, how you have checked the mobility or contraction of those muscles, what is the relation of those muscles with the scapula. All this you should tell, which is not there in your examination.
there in that region mainly latissimus dorsi, then infraspinatus, there is major and minor muscles can be there, and supraspinatus also. So like individually we have checked the actions, but for the scapula like not sure. Sir. like there was restriction with extension and lateral rotation of the arm.
No, see, there is a usually what is abduction up to 90 degree, abduction above the 90 degree, and what is the relation with the movement of the scapula with those shoulder movements? Their answer lies now. And what is with this movement? What is the whether this swelling moves with that or not?
So
Because you are not able to fix the scapula. So you can move the scapula. If you are moving the scapula, you have to see whether the swelling moves on palpation along with scapula or not. That should be our answer for this question.
the plane of the swelling is above the muscle. So it's we can that is one way we can rule out fixity to the bone.
Which that means you are telling that this swelling is superficial to which muscles?
Latissimus dorsi and intracranial. Above this muscle.
So that's why you are telling that it is all fixed to the scapula. Okay, thank you. Why there is a restriction of the shoulder movements? Because it is not related to shoulder, it's right below.
Like extension of the movements at the shoulder joint, but extension of the arm and lateral rotation of the arm. Those types, yes.
Like to summarize, sir, 68 years old gentleman presented with gradually progressive swelling of the right upper back. At the site of the previous surgical respect for the past 1 year, with rapid progression over the past 4 months. To a current size of 16 centimeter, associated with ulceration and post discharge from the surgeon. With no functional impairment and neurovascular deficits or any picture such to males. On my professional diagnosis, I like to keep this reference of tissue sarcoma of the trunk.
We'll examine the axilla of the supraclavicular because he told the history, but the examination will notice. So axilla, clavicular region.
Yes, sir. Lymph nodes and all that. Examination. There are many lymph nodes like bilateral axilla and cervical region as well.
Okay. Any other different diagnosis apart from sarcoma? Any other diagnosis you like to keep in mind? This is the only diagnosis.
So it was a long-standing swelling and more intensity in size also, and like it was like fixed during the extension of the shoulder joint. So I like to give up like recurrence and the other side I'd like to keep soft tissue sarcoma as my first business.
Any other differential you would like to ask?
But from the examination, it is not suggestive of
I'm saying it's arising from scapula.
bony swelling.
Swelling is arising from the scapula and now this is I'm telling you the bone tumor arising from the scapula. Tell me this, you are talking
Scapula is a flat bone and only gives
I think this is yeah, you are so confident that you continue.
the plane of the swelling.
When
And
you are
that
moving the shoulder joint, what happens to the scapula? When you abduct at the shoulder, what happens to the scapula?
It is moving.
So when it moves, that the swelling move.
No, sir. Like,
When you abduct, when the scapula also moves, if the swelling also move along with the scapula, that's basically the answer.
It's just moving, but that we cannot say that it's fixed to the scapula.
Proceed.
I like to proceed to investigation, sir.
What is the consistency of this swelling?
Like bony swelling will be hard.
What is the consistency I'm asking? It's firm inconsistency. It is uniformly firm inconsistency.
Why this consistency is important? Okay, you said hard may be bone, firm may be soft tissue sarcoma. But any other importance is that with regard to consistency? Like a spectral case of sarcoma.
A malignant, like the aggressive nature of the swelling, like possibly malignancy. Like if there are like variegated consistency or hard consistency, like variegated, it could be like areas of necrosis or hemorrhage would cause it to become soft compared to the rest of the swelling. And any areas of calcification that can make it.
Okay, when there is an area of necrosis, then it becomes soft and variegated consistency. What does it tell you? Whether it's aggressive tumor or whether it's or what do you think about the prognosis?
Aggressive, it's like outgrowing the blood supply of the.
That gives you a picture. No? It's a large tumor with variegated consistency from a necrosis and aggressive tumor. Continue.
We've seen a baseline investigation, sir. Actually, biopsy we have repeated, sir. The patient presented with outside biopsy and it was. So we have done the routine blood investigation, sir. We've done this X-ray, sir, followed by CT scans.
You taken a plain X-ray. I will take an X-ray of the scapula or shoulder area. What do you see? How do you must tell all that? Before you take away of biopsy, what do you see in the X-ray? The plain X-ray, the scapula, the right shoulder, whatever, what do you see?
It was just taken as a part of routine investigation. We have done with like proceeded with CT scans for the reason.
Such a large tumor, a recurrent tumor, comes to you. So directly ask to go for a CT scan, or can you do some other basic investigation which gives you an idea about how extensive is the disease?
It's actually showed like.
Yeah, you've done a chest X-ray, right? So what does it show?
Like in the near the right bronchus, right main bronchus, like like very deposit or lymph node enlargement is very.
Right shoulder. Yes, X-ray, what is the right shoulder?
Scapular border is not. Lateral border of scapula is also not visualized.
The big soft tissue swelling,
Yes,
the
sir.
scapula is not clearly made out.
Sure.
Would you like to take any other plain X-ray before you go to CT?
Is it?
What X-ray would you like to take? You want not take X-ray right shoulder, I don't want to take. You think it is not worth it?
Yes, sir. It will be.
No, this X-ray is taken as a staging investigation or it is a diagnostic investigation.
It's taken as-
Staging. So it is a TA window. How it will give you a classical picture of a right shoulder as well as a scapula. It should not be more evident. So just specific X-ray of that region has to be taken. So with that X-ray only you will be able to comment on the scapula, involvement of the scapula or even the other bones. Yes, no. That should be your answer. But this X-ray is not taken for that. And probably that X-ray is not there. Yes, okay.
CT we have done, sir, following that. CT, it was like well-defined heterogeneous lesion was present with predominant fluid accumulating areas and few hyperdense non-enhancing areas within possibility of blood products in multiple areas in the subcutaneous brain in the right posterior chest wall region, showing loss of blood pins with right inferior spinatus and right dorsal muscle. Discontinuity in the overlying skin includes possibility of ulceration. And if you small if it is enhancing solid component with discontinuity of the overlying skin,
Split of recurrence was like mentioned, sir. And when defined heterogeneously enhancing region was noted at the hilum of the right lawn, between the right main locus and segmental locus to the posterior segment of the right upper lawn. Split of metastasis was noted.
What do you think? Arranging the bone, arranging the muscle, arranging the soft tissue, right?
It's not arising from the bone, sir. It's fixed to the soft tissue tumor only, fixed to the underlying muscles.
It's arising from the muscle, or it got infiltrated to the muscle.
Infiltrated into the muscles.
No, one of the things you told that it was a purely subcutaneous swelling in examination findings, because we are not seeing that. But your CT shows that it is infiltrating, probably involving the latissimus dorsi and your in the right infraspinatus muscle. So, I don't know. So, need to check whether your examination was right or not. Because I remember you specifically telling that it's a purely subcutaneous swelling, and when you put individual muscles into contraction, we didn't find any fixity. Right? That was a statement you made.
It was like restricted on some movements, sir, like lateral rotation and extension of the arm.
Okay, that is one thing. And second thing is, when you put that X-ray only, there were some changes with the pulmonary thing about metastasis. We did comment on that. Of course, shoulder is one thing. The lung window also showed changes in chest X, the right in chest X-ray. Right, so you didn't tell about that. We didn't note or only after CT.
We noticed, sir. That's why then like we did a CT first to like assess for both the primary lesion and the metastasis.
So what is the next line of action? What did you do next?
Like we are awaiting biopsies awaited, sir. Like
Next is biopsy. So will you do biopsy before your imaging CT or will you do after CT?
it's
When you-
after the imaging.
Huh?
After the imaging, sir.
Why?
Like to in this case it's already an ulcerated swelling, so it wouldn't be, but otherwise to prevent distortion of the tissue planes and to give an accurate picture about the
May not be more relevant in this case, but other case, better to do biopsy after your imaging. That is one thing. So generally, MR, maybe in extremity lesions, soft tissue lesions, sarcomas, what imaging is preferred?
for the primary lesion, MRI is preferred.
MRI is preferred. So when do you do CT for primary image? Which sarcomas?
Generally for abdomen, retroperitoneal sarcomas, it is preferred since it is because of the motion artifacts and air.
Okay, so in extremity sarcoma, if you do MRI, okay, what else you do apart from MRI of your local place? What any other investigation you do as part of your staging workup?
HRCT thorax will do, sir. And depending on the like the histology of the tumor, maybe we'll need a CT of the abdomen also.
So HRCT of thorax is a must. Okay, that is must in the maybe T2, T3 tumors. But if it is probably a large lesion like that, the chest X-ray shows multiple con metastasis or multiple cannonball metastasis, then definitely. So that you can order. So how are you going to proceed with this patient?
Like biopsy, we take the biopsy, sir.
What biopsy?
Like in this case, a true cut biopsy, sir. Because like in the, or like incision biopsy may not give the, because it's already an ulcerated swelling and the skin is also like undermined. So then true cut biopsy we can take, sir. Multiple
It's already ulcerated to see the tissues.
okay, sir. Like there may be a chance for there may be a chance for like missing the we can take If the, like superficially, if you have taken it, then we may.
Like a deep biopsy. Indian grafting was like a deep biopsy. I thought the biopsy report.
That was like the patient, it was done in December, so like Kruger biopsy was done.
Yeah.
Outside, so like after that only patient developed ulceration over the cells. High grade spindle cell sarcoma.
Okay, suppose this is a metastatic, no, because your CT shows there is some nodule in the lungs, which probably is metastatic. Suppose imagine if that is not a metastatic disease and not ulcerated. So how will you plan a biopsy in a patient of a soft tissue sarcoma? Any precautions you take?
Like preferably like guided biopsy would be better to identify the solid components and take the biopsy from that instead of any other part, and make sure that the biopsy track will be included in the future incision so as to prevent like local recurrence, reduce the chance for local recurrence, and
It's not the chance now, chance to reduce the chance of local recurrence. When you plan for a surgery, your surgical incision should include your biopsy site, right? Whether it's an incisional biopsy or a core-natal biopsy site. So that's why if it is done in a peripheral center, better when they suspect such a large tumor, better not to do a biopsy in a peripheral center, better to refer to a center where soft tissue sarcoma is being treated. Okay, so that the surgeon plans the biopsy, okay, where the biopsy should be done. Otherwise, if the biopsy is eccentrically placed, then your incision should include those sites also. That will lead up to a large incision or may need an additional procedure. So those things should be kept in mind. Any other precautions you take? Suppose if I have to do an incisional biopsy, any other precautions you take?
So incidence should be taken longitudinally along the muscle and it should be the central survey.
The same thing happens. No, it should come in the next incision, definitive incision for surgery, and you should not place a drain, don't raise planes. Okay, so those precautions you should take. Okay, now go ahead. What was the biopsy review?
Our biopsy is not come here. So like the biopsy report was high grade spindle cell sarcoma.
That was a report from outside. So how did this?
With metastasis. So this will be a recurrent soft tissue sarcoma trunk with solitary lung metastasis. So to plan for the as it is considering the size and the grade of the high grade, we can go ahead with like primarily for recurrent sarcomas also wide local excision is
Metastasis in the lung.
Yes, sir.
So they like to do radical surgery on this catheter.
If we are able to like we can get an MRI done, sir, to get the proper extent of the involvement, and then we can plan resection. And since we can actually first do a tumor board discussion and then decide whether the lung mets can also be are amenable to resection. And if that's the case, then we can resect, do a metastatectomy with the.
Before that, before metastatectomy, how will you prognosticate? It depends upon, see, you go and do, then again within 6 months, the patient develops some other recurrences in some other part of the lung. So this is the one which is visible. There may be some micromets somewhere in the lung. So how will you prognosticate before planning treatment?
Like the staging is there, sir. Like the first stage, like the AJCP staging is there. So our tumor falls in the stage 4 category, and apart from that, for prognostication depends on the age of the patient, his
the tumor size, the grade, depth of invasion. Based on all these factors, will decide the management.
What is this grade of the tumor, especially which is included in your TNM, your AJCC, what all things you look at in your grade of the tumor?
The tumor differentiation, the microtic counts, and the extent of necrosis, tumor necrosis.
Those are important, no, especially grade of the tumor. For that, you need to do an IHC. For that, do you need tissues?
Is INC for histology type of the subtype in the tumor, but routine biopsy can show these features, the differentiation, grade, mitosis, and necrosis, necrotic areas.
Because you are thinking in treatment in terms of even doing a resection for your lung mets, no? That all depends upon your grade of your tumor, right? The grade of your tumor. Suppose grade is high grade, then they won't venture on excising the pulmonary metastasis. That is one thing. And second, suppose if they want to start a neoadjuvant therapy and see the response and proceed for that, you need an IHC marker, right? For both purpose, you need a tissue. I don't know, either you can get the tissue from outside or you can do a biopsy here and get the tissue, do IHC markers, see the grade of the tumor, and then go for your MDT discussion. Okay, and they say histopathology is so diverse in soft tissue sarcoma now that itself is a specialty in pathology, right? So that's all important for planning your, especially in this case of metastasis. So you have to plan whether this is amenable for a pulmonary resection or whether we should just wait and watch, whether we should just treat as metastatic disease. So for that, you have to prognosticate by a grade and also by your IHC markers, and based on it, start on a neoadjuvant therapy, the MBT giving.
Sitting. Is there any sarcoma which respond very well to chemotherapy and radiation? Sarcoma at this stage you get?
In general, synovial sarcoma.
In this situation, there is a sarcoma which is extremely good prognosis. They respond very well to chemotherapy.
Synovial sarcoma.
Synovial sarcoma is not a very giving sarcoma. Extremely well respond to chemotherapy. Very good prognosis.
Synovial sarcoma is a poor prognosis. It's all high grade.
Chemosensitive, but high grade.
High grade tumors, right? You know, any tumors which can tumors extremity sarcomas which can spread to abdomen or to the retroperitoneum.
This previously known as this malignant fibrous sarcoma, undifferentiated pleomorphic sarcoma, then leiomyosarcoma.
It's a clear cell sarcoma and myxoid type. Okay, so they are known to go to retroperitoneum and to the inside the abdomen. So in such cases, you may get an extremity sarcomas. Sometimes in a high grade thing, the tumor is large, CT of the abdomen is recommended. Like you do CT for chest, pulmonary metastasis.
Is any named sarcomas which will spread to the lymph nodes?
Synovial sarcoma, sir, and leiomyosarcoma.
Angiosarcoma, epithelioid sarcoma.
The names.
Okay, thank you.
Thank you. You presented well, but you need to be more confident. Have a good knowledge. All right. Thank you.
Thank you, sir and ma'am. I now request the examiners to felicitate Dr. Aishwarya.
Hey, don't go now. Don't go.
This one will keep it there.
Wait, this is having something, huh?
This
Olympus.
Olympus.
And Dr. Divash.
Olympus.
Thank you, sirs. Now we will
அது ஆஃப் பண்ணுங்க மைக். இன்டர்ஃபரன்ஸ் ஆஃப் பண்ணுங்க. Now it's interference.
Now we're going to have a short technical demonstration by the Merrill endosurgical team. I invite the team onto the dais.
Advertisement. That is what you should know. What to say. As I was telling you, I knew that we topic. I'm going good.
Good evening to all. Thanks to the surgical committee for to show our device. Merrill is an Indian company, Indian MNC company, which we having 6 divisions in the company, 6 verticals like Merrill cardiodiagram. I mean, we have a cardiovascular and ortho division, as well as we have endosurgery and we have a diagnostics and we are now we are from endosurgery division. We are joining this company called Human Extensions, which is from Israel. We have launched a device called Handex. Handex is a device which is fully articulated 5 laparoscopic device which bridge the advanced laparoscopic system along with the it is bridging. There are, I mean, laparoscopic device along with the robotic devices. So there is advantages when it comes to laparoscopy. We have some limitation in the restrictions in momentum and wrist movements as well as the device usage. So whereas robotics, we have a long setup and the docking, maintenance, and stop the separate room for robotics. So right now we have launched a device which is called Human Extensions Company Handex. There's no need of blocking and no need of maintenance. And this device you can take it from anywhere, one room to other room, and there's no that I mean timing of usage, and it's very natural ergonomics as like laparoscopic devices. And this is the device you can use more like general surgery, urology, gynecology, thoracic surgery, and oncology. And this is our device. This is our device. So this is the device which is very simple, handy, and laparoscopic device.
After this team.
Fully articulated laparoscopic and software driven system. So this device is to 3 parts. One is a control interface and a handpiece body and disposable instrument. So in this control interface, as work like a robot, whatever you are giving a control, that will upscaling by the hand system, hand body software, and it will be mimicking the tracking body. So I'll show the device. So just no.
It's not coming there.
So this device works like this. It's a fully articulation. So it goes all the sides 90 degrees.
They don't know to show this one.
So this device you can use it for all the features, I mean, all the devices.
That can.
So this is the device. Just it's a finger pad. There's a dialog button, and it is a control interface. Just double clicking, it is having a full articulation for all the sides. Just using your pan to just rotate very minimal degree. It's like if you want to go 90 degrees, you have to use only 30-degree movement in the hand. It goes 90 degrees. It lacks complete access to all the areas. Even if you want to use in the terms of hernia surgery, you can take any way to use the arm to use suturing in abdominal wall, or else if you are using LAR surgery, we have devices like a monopolar hook and monopolar spatula. So by that you can use all the movement by this articulation. So and whatever the degrees of freedom you are getting from a robo, there are 8 degrees of freedom. All the degrees of freedom you will get it from here by this device, and it's a 3 centimeter clip only. So you can access any part of the body in a deep pelvic region. This is the product device. I will show you the demo of the instrument. Input is not on. Presentation. So this is the Windows 6 model. Thanks for the device movement, click moment. Just double clicking, you can even use the device to touch any part of the body. And it goes all the areas also. And you can touch across the body by touching the floor, and it's a positive tap. You're doing it. So this is the device. It moves fully articulated all the areas. Left and right. And there is a good full roll range is there in the middle holder. It goes up to 270 degrees. Across the sides, across the area. So it's the advantage of the device. And there are 5 instruments in this middle holder, grasper, and monopolar hook and spatula. So if you want to try this with us, you can come to our general stores. We will do a separate demo tour. Thank you. Thank you.
Thank you. Now we invite the team from Olympus India to introduce their product.
Then again, camera video will go. Good evening, everyone, and thank you very much, JIPMER and organizing Association for JC today for giving us this opportunity. I will take you through the small presentation of the latest introduction in endoscopic imaging, that is Visera Elite 3 platform. It's a small presentation to give you a idea about the features and the latest imaging technologies what are available. And so after the presentation, you can also see the same product at our Olympus booth. So to start with, Visera Elite 3, the latest generation platform. Speaker already there. Why you want to be there? So if we see the today's scenario, there are common challenges which are faced among the various stakeholders in the OR this time. So first of all, there is an inconsistency in terms of laparoscopic image, sometimes focusing, defocusing. Other part is the ergonomics. Another part is the complex cabling. So many times you need to stop in between the surgery and handle the instrument or connect different wires and check the cablings. Another very important thing is sync with the continuous evolving technology. So now, every now and then, a new technology is evolving. Every new year, new technologies come. So how can see it from there? And very important for the cost of ownership or say ROI, because it's like a huge investment when buying any imaging laparoscopic tower. So the solution to all this is our Visera Elite 3 platform. So the next is small introduction video with this, and then we'll go through this features one by one.
Yes, last week we have last week. People said it. That's something better. First day was supposed to be a very interesting display.
So this is Visera Elite 3 key components. You can see the processor there. This is a common single processor for having all the advanced imaging capabilities today. Okay, ICT, 3D, everything. Then we have a LED light source, then specialized LED light source, 5 light LED light source to give the optimum 4K image and the 4K camera head. So moving to the first feature, the 4K camera head has the resolution about 3840, which is the true 4K resolution. And the unique feature is the continuous autofocus mode. So many times you have faced challenges in the 2D that many times you have to focus, refocus. So now we are introducing the continuous autofocus mode. Once it is activated with the camera head switch, throughout the surgery, you don't need to focus anytime again. That is one of the new features. It saves your time inside the OR, and it's inbuilt with the EDOF features, which gives you a more access from the same distance. You can get a more access with the clear anatomy. It's an autoclavable camera head. Another feature which we talk about is the fluorescence. So it has an inbuilt fluorescence, white light plus fluorescence capability.
as you can see. Along with this, you can also see we have selectable IR gain. So IR gain is the adjustment level of ICG which you can adjust depending on your need. There are three different types of gain, that is low, medium, and high. Apart from the white light plus IR, the another feature is we have different IR modes also. There are three different IR modes. One is white light plus IR, another is IR plus magenta, which is our previous generation IR image, and the IR fluorescence only. So based on your needs, you can use these different modes as per your surgery for fluorescence surgery. Then another unique feature is the PIP. The same system, you can have a PIP image of white light plus ICJ on the same screen. That is one of the unique feature of Vizra Elite 3 platform. And you can alter the view, sub views and the main views in this screen. Coming to the next feature is, this is something very unique which Olympus has brought, yellow enhancement mode. So this is an improvement in the white light imaging. When you turn on the yellow enhancement mode, as you can see, it enhances the yellow color. So say about the fat colors. So this enables you to see the different fat layers in the different yellow shades. The rest all anatomy remains clear. So this helps you as a guidance tool while dissections. Since this is a new technology, so it is again under evaluation. But based on the evaluation what we have till now, it has found its clinical importance in the dissection of gibrofascia, in the colorectal surgery, in the pancreatic surgeries, and even to some extent hernia surgeries. So this is just a glimpse that how yellow enhancement changes. As you can see in the image, the different fats you can see in a different yellow shades. Coming to the next feature, so the same platform is compatible with the 3D imaging. But in 3D imaging, we have two types of scopes. One is rigid 3D and another is the flexible tip 3D. So when we speak about rigid 3D, something unique, unique technology that Olympus is having image rotation function. It's a mechanical rotation function, as you can see. Because just compared to the earlier 3D models which are available, you are not able to maintain the horizon while rotating or seeing the laterally as compared to 2D. But here with the NOR function, the image orientation remains same, even when you turn around the 175 degree, as you can see in the image. So the orientation remains same in rigid 3D. This is one of the technology in rigid 3D. Coming to the next, the very unique product from Olympus is flexible tip LTF scope. The new 3D scope, it has a flexible tip. It's a joystick model, very intuitive to operate. In new 3D, we have shortened the tip, so you can work in the narrow cavities with the 3D scope. And then just to give a glimpse what how 3D capability is there in the flexibility. So the current view what you're seeing is a 0 degree view in the 3D. So it's a straight view where you can see the anatomy. With the 30-degree view, you can have a little bit idea about the interposition of the anatomy. But with the LTF, you can even see the anatomy which is hidden. So that is what something unique advantage with LTF flexible tip 3D has. They had a bird eye view. Just to give you a glimpse of how the capabilities of 3D flex. Here, just for example, it's an HPV surgery where you can see the various possibilities with the LTF, which gives you to reach the difficult anatomy. So coming to the next feature of Israeli platform is that it, apart from the 4K 3D capability, it also has a compatibility with the flexible video scopes, which are regularly with the polydicoscopes, or the say ureteroscopes, which are using urology and ENT and different scopes. Then it also compatible with the previous 2 generations HD camera heads from Olympus. So it's a wider compatibility, which makes an effective reduction of the cost in terms of investment. So now we are talking about the platform. Since I am beginning, I have been talking about platform. So what is different from the platform? As we talked about, how can we take care of the ownership or the cost of ownership in the future with the new technologies? So with the Israeli 3, we can see just with Israeli 3 today's latest technology what we have. But in future, any new technologies which are coming up can be upgraded through a software. And as you can see, these are the possibilities which are coming in the future, like the IR, open IR extensions, molecular imaging, AI, and the robotics. So that's why we call it a platform. So this is my last slide. To conclude about Israeli 3 platform, it is one-in-all platform, can be used across the specialties. It's an advanced surgical visualization platform having 4K 3D ICG, and it's a future-ready platform which can be upgraded with the software. Thank you very much for your patience listening. If there is any queries, then yes. So we
specific features which are improvement from the last generation. We have visceral tools.
Yes, sir.
What is this specific feature in this?
So as compared to Israeli 2, sir, there were 2 different models for HD and 3D. Here the single processor where we have completely 4K 3D and HD camera video scopes. Apart from this, since upgradable with the software, so in future you don't need to add too much of hardware. That is something very unique point. And the yellow enhancement and 4K ICG modes also.
Quantification of ICG quantification.
Sir, at this point it is not there. Yeah, but in future it is going to be this AI technology are going to build up on the same platform. So whenever the technology is coming, you can just upgrade by software in this platform. So once investment is made for almost the next decade, you are future proof.
The stalls are available in the East area. They can give you a demo in case if you have any queries. Thank you.
We shall break for tea now. In the same yoga hall, the same. Thank you, sir. I request everyone to reconvene by 5:40.
Which one? Is it connected? Which one? Meeting ID.
down money already 939.
D2 gastrectomy. This picture shows the lymph stations to be stored in the case of D2 gastrectomy. And lymph node stations in stomach are classified into D1, D1 plus, D2, D2 plus, and D3. Sound. And sir, and my okay. Laptop no what is it? Kitchen me base. Mic pardon. Stations in stomach. Okay. Lymph node stations in the stomach are classified into D1, D1 plus, D2, D2 plus, and D3. Lymph node removed in the D2 lymphadenectomy depends upon the type of gastrectomy. The picture on the left side of the slide shows D2 lymphadenectomy done for subtotal gastrectomy, and the picture on the right of the slide shows lymph node dissection done for total gastrectomy. And the blue color lymph node stations are D1, yellow color lymph node stations are D1 plus, and the stations labeled in red are D2 lymph nodes for total and subtotal gastrectomy. What is the current recommendation for D2 lymphadenectomy? In early gastric cancer, which are not amenable for EMR or EST, D1 or D1 plus is indicated, and for locally advanced gastric carcinoma, D2 is a must. Do we have evidence for D2? Yes. The recently concluded Dutch trial, which has a follow-up period of 15 years, has shown that D2 is far superior than D1 with regard to local regional recurrence and gastric cancer-related deaths, but with higher post-operative morbidity, mortality, and reoperation rates. Regarding mammotectomy, what is the consensus? There is no consensus regarding mammotectomy with regard to European, American, or Japanese. Since it has been shown, it has been said that momentum plays an important role in the peritoneal primary defense, and which reduces intestinal adhesions and prevents peritonitis. Patients who undergo total mammotectomy are more vulnerable to peritoneal infections, which are often associated with worse clinical outcomes. Still, there are no consensus with regard to the oncological benefit of mammotectomy. The Europeans don't have any guidelines regarding this, whereas American, they follow total mammotectomy for all gastric carcinomas. And for the Japanese preserve momentum, which are distal to 3 centimeters from the gastric plug vessels in case of T1 and T2 tumors. In case of T3 and T4, they go for a total mammotectomy. Evidence for lab versus open in case of gastric carcinoma. It has been shown that by various class trials, Koreans and Chinese trials, which have shown that laparoscopy is not inferior to open in case of early as well as locally advanced gastric carcinoma. Moving on to the case capsule. This patient is a 65-year-old male with no known comorbidities, presented with pain and abdomen for 1 month, vomiting for 3 days, and swelling for 3 days with loss of appetite and loss of weight. On examination, no evidence of metastasis. This is a CT picture of the patient showing this thickening in the anthropallic region. The D1 is free. And you can see the tumor is stuck onto the gallbladder. And this is the same picture in the another view, which shows that the anthropallic region is thickening. This is the patient portion. It's a leg split where the surgeon stands in the center, the monitor on the head end, with the slave monitor on the right or the left side of the patient. The camera assistant stands on the right side, the second assistant on the left side. This is the port portion where a 10 mm port, subumbilical 10 mm port for the camera, the right and left working port. The right hand working port is 12 mm for introduction for the staplers, and two retraction ports, one in the epigastrium, one in the anterior axillary line on the left side. Moving on to the video. After doing a diagnostic laparoscopy, and you can see the addition to the, as seen in the CT, there is an addition of the gallbladder wall to the tumor, which is released. with a sharp dissection using harmonic scalpel. And the lesser sac is entered after cutting through the gastrocolic momentum. It is dissected along the left side till the spinning flexure is brought down. And on the right side, till all the momentum is taken up with the specimen. Now the dissection is done at the infrapyloric area where there are dense infrapyloric nodes, which are seen. The right gastroepiploic vein is dissected off from the duodenum, which will be clipped in due course. That's a lag. And the duodenum is scrutinized both laterally. This is a right gastric epiploic artery, which is skeletonized, flipped using pneumologs, and cut, which helps us to skeletonize the medial part of the duodenum. After making sure the duodenum is skeletonized, a stapler is a 45 mm blue stapler, stapler is introduced to the 12 mm port on the right hand working port. It will be seen now. This shows that the duodenum is skeletonized all around. A 45 mm blue stapler is introduced from the right working port, and the duodenum is stapled. Now the dissection is continued along the superior surface of pancreas to identify the gastroduodenal artery, which is seen here. That takes off from the common hepatic. This is the GDA, the common hepatic and a proper hepatic, which is being the GDA is being put to the vessel loop. The dissection is proceeded along the proper hepatic artery. All the lymphatic tissues along the proper hepatic artery is being dissected off. Proper hepatic artery is looped by a vessel loop. The lymphatic tissue along anterior and the posterior aspect of the proper hepatic artery is being dissected off in the portal vein. Now the right gastric artery is skeletonized, which takes off from the proper hepatic, which is clipped by hemorrhage. The dissection is continued along the proper hepatic until the bifurcation of proper hepatic into the right and the left hepatic artery is seen. The common hepatic is hooked by the vessel loop here. The dissection is continued along the superior aspect of the pancreas, and all the lymphatic tissue along the superior aspects of the pancreas where the common hepatic and the splenic artery lies is taken off.
They can play any from this.
As the left gastric vein is visible after.
You can see the
And the lymphatic tissue along the common hepatic artery is being dissected.
The translate and the refer.
There's a lag in the video. It's not properly translated.
We'll connect it this. In detail. Oh, okay. Into which? Stop shares. ಇದು ಅವ್ರದ್ದು ಪೆಂಡ್ರೈವ್ ವಿಡಿಯೋ ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಸರಿ ಫಸ್ಟ್ನೇದೇ video. Okay, the videos. Okay, open the video. You could just hear this PPT. But audio is connected to that.
There's no lag now. Sorry for repeating it. This is the Galvin addition seen on the CT, which is being taken down, after which the lesser site is entered. Then it is dissected off, the entire great momentum is dissected off the colonic wall. Still the screen picture is down on the left side. And to the right side also. This is the intrapyloric nodal dissection. Which will be taken up with the specimen, dissecting off the left, right gastric vein and the gastric artery, which is visible now. The right gastric artery will be clipped with humolock. The duodenum is dissected on the lateral side. This is a right gastric artery which is being telephonized here. Ligated using humolox. And cut, which helps us to dissect the medial wall of the D1 segment. You can see the duodenum being skeletonized, and the other side of the anterior aspect of the duodenum is being seen here. That's the head of the pancreas seen near the dissecting area. After skeletonizing the duodenum, a glue stapler 45 introduced to the right hand working port, and the duodenum is stapled. After stapling the duodenum, the D2 dissection started. The key here is to dissect along the gastroduodenal artery, which is being done here, which bifurcates from the common hepatic artery and continues as a proper hepatic artery. The GD is being hooked with a vessel loop. The lymphatic tissue along the proper hepatic artery is being dissected. The proper hepatic artery is being hooked. All the lymphatic tissue medial to the portal vein is being stripped off, and this is the right gastric artery taking up on the proper hepatic is being clipped. The dissection is continued along the proper hepatic till the bifurcation of right and the left hepatic artery. The common hepatic is being looped, using it as a guide. The peritoneal covering on top on the superior surface of the pancreas is being scored here with harmonic, and all the lymphatic tissue on the superior surface, that is 8A station, is being removed here. This is 7 left gastric vein seen here. We can see that the common hepatic is slowly visible to the left of the screen. The lymph nodes along the left gastric artery, as you can see there, it's being lifted off with the specimen. The left gastric vein is skeletonized and will be clipped using hemologs. The structure behind the left gastric vein is the left gastric artery. This patient had a lot of lymph nodes there around the. These are the lymph nodes to the left of the portal vein, which is being taken off. Which is proceeded along the there is a left gastric artery, which is being isolated here. Clipped. And that is this is along the hiatus. This is a fatty tissue along the lesser omentum. It is being taken close to the liver. A suitable place on the stomach on the greater curvature is being selected after giving a 7 cm margin using an umbilical tape from the proximal edge of the tumor. And the lesser curvature is skeletonized, devoid of any lymphatic tissue around the lesser curvature. up to the hiatus. That is station 1 node. These are station 3 nodes. This is the picture showing the dissection area there. An endo-GI green stapler is applied. Sometimes you may need 2. Here we have applied 2 staplers, green staplers. After skeletonizing the lesser curvature, you can see the lesser curvature here is devoid of any lymphatic tissue there. So, you can see that that's the right side structure is the CBD, below is the portal vein, and these are the arteries. And that's the celiac node below the celiac axis being dissected off. Now it's better to dissect the splenic nodes after doing the gastric analysis. It will be difficult to lift the specimen. So the splenic artery dissection is being proceeded here. That's the splenic vein which is visible here. That's a splenic artery. This is a splenic vein. The dissection along the splenic artery is continued up to the distal spine. It's devoid of any lymphoid tissue. And that's a spleen. You can see that's a spleen, not station 10. Structure on the right side is CBD, the portal vein, hepatic artery, proper hepatic with bifurcation, the common hepatic, the left gastric being ligated to the hemolog, left gastric vein, the splenic artery, and the vein onto the hilum. The lymph node dissection is complete. Station 10 nodes no need to be removed, as I told earlier, for subtotal gastric. These additions were there in the gallbladder to begin with, so I wanted to dissect it off from the gallbladder. Then jejunum is cut 20 centimeters from the DJ fracture using a white or a blue stapler. And a GJ is constructed using the distal loop. A side to side, anti-colic, isoperistaltic, and posterior GJ is constructed using a blue stapler.
So I can clear there's a lot of time.
Yeah, that's it.
Yeah.
GJ is done.
Yeah.
And after which a GJ is constructed, 40 centimeters from the GJ. Right.
Nice demonstration from Dr. Rajkumar. The people who don't know Rajkumar is more in doing a more advanced GI surgery and medical invasive approach. And regarding this, I have few points to carry. So in patients who have got a replaced right left hepatic artery, how do you go about in doing a detailed lymphadenectomy?
We have to dissect the nodes from the origin of the left gastric, see to that the bifurcation is taken. And beyond the bifurcation, we have to cut it. After dissecting all the lymph nodes, it's tested.
So we have to be very sure it's
a actually we left replaced hepatic should be diagnosed before, not intra. CT, taken triple phase CT will tell you the replaced hepatic preoperatively, and it's as Professor Jagannath said, the planning is done before, not intra, it is pre-op. So the mind prepares and the hand does. So
whenever you do gastrectomy, you have to look for these variations in the hepatic artery. Sometimes it may be a replaced left hepatic artery,
when you do something going as usual, compromising, considering it to be accessory, it will be mostly an only sole supply. So there will be a greater chance for ischemic injury to the liver. So we have to be careful and identifying the branch of the left lateral sectoral artery or the left hepatic artery till its bifurcation, the ascending branch of left gastric. We have to isolate the lymph nodes and then divide the left gastric artery. And regarding the left gastroepiploic artery and the lateral extent, you go till the origin of the left gastroepiploic and take down, or because in this image we couldn't appreciate.
This I went till up the distal spinning, but left gastric artery is not the left gastric artery.
And for total gastrectomy, how do you do a esophageal gastrostomy?
Yeah.
Or technique, how do you
It's a side to side posterior using a linear step.
So it is usually a technically challenging thing when you do esophageal gastrostomy laparoscopically. There are different techniques, either a circular stapler or you can use a linear stapler. When you use a linear stapler, you should have an adequate modulation of the lower esophagus and the hat and resections. So otherwise, it may end up in doing a technically difficult to do, and sometimes it will be done without dividing the jejunal tube before you make the rolling. Finally, after the anastomosis, we can raise the rolling. And post-op, how do you manage to do a total gastrectomy the patients?
I usually have an HA reconstructed, so the feeding purpose will be taken care of. And after post-op day 7, at the end of the first week, we'll do an oral contrast check whether the anastomosis is intact, and then we start it.
Usually better to have a oral contrast assessment of the esophageal anastomosis in the post-op, and then go ahead with the oral internal nutrition.
What about the complications when compared to the routine that you're doing?
With regard to D1, sir, D1
D2.
Complications, as in the initial post-op period, there will be a lot of fluid in the drains. It takes 3-4 days for it to calm down actually because of these dense lymphatics there. It won't be lymphatically gastric, but because of the dissection there will be peritoneal fluid, ascitic fluid. That's the main morbidity I've seen. And usually settles down once the patient starts taking orals and the abdomen improves.
How about the dissection when you're doing the lymphadenectomy? I saw you're using harmonic. Sometimes the harmonic tends to club the tissues together. Sometimes monopolar or bipolar dissection.
I have not used monopolar. I've used harmonic or ligase. And not under the.
Right. I saw that. What is the message that you want to convey to our postgraduates in regard to laparoscopic treatment gastrectomy?
It's a safe and a feasible option after a period of learning curve. Everybody should do laparoscopy.
Before attempting this,
at least 5 to 10 cases of open surgery and good sound knowledge about anatomy of the vessels, the preoperative planning. As you said, for left gastric and left replaced hepatic, all these things to be done preoperatively, and then after a few cases of learning curve, then have to proceed.
Thank you, Dr. Ashai.
Thank you, sir. I request the chairperson to felicitate Dr. Rajkumar.
Laptop. Just attached to recording.
I now kindly request Dr. Vishnu Prasad to felicitate the chairperson, Dr. Senthil Kumar.
Thank you, sirs. I request Dr. Senthil and Dr. Shanmugam to kindly remain on dais for the next lecture. Moving on to the last lecture for the day. We have an intriguing video lecture on robot-assisted GI and HPP surgery by Professor Dr. Vishnu Prasad. I request the chairpersons, Dr. Fani, Dr. Vaidishwaran, Dr. Senthil Kumar, and Dr. Shanmugam to the dais.
Happy to tell a few words about Dr. Vishnu Prasad. He was a teacher and he finished his MS from JIPMER, I think S2. Then after that, he did his MCH GI surgery at All Institute of Medical Sciences. I also happened to be at AIMS those days and we used to meet often. Then after that, he went on to train in liver transplantation in Paris and also in King's College. Then from that time, I have seen him. He's one of the person who is extremely focused and always wanted to do advanced thing. Right from the time he joined as assistant professor. And he has achieved, I think, ticked all the boxes and achieved what all he wanted to do in the last 20 years. And needless to say, his focus area has been HPP surgery and minimal access and robotic surgery now.
Thank you, Vaidishwaran, for the kind words. So, my dear residents, dear colleagues, and my friends. So, it's my pleasure to speak on this topic. So, robotic assisted GI and HPV surgery. I have nothing to disclose. I'm not propagating damage. So, the outline of my lecture is like this. Let me first tell you about the current trends of GI, robotic GI and HPV surgery. And then, since many of the residents have not seen the robot, let me just tell you briefly about the basics of the robot which we have. And then I just tell you about the pathway which leads to do a robotic pancreatic duodenectomy, and end with a few minutes video of the pancreatic duodenectomy and gastrectomy which we have. Right? So this is the one extract from the JAMA surgery, the recent JAMA surgery. You can see the trends. Can I find that? You can see the you can see the trends in the robotic surgery from 2012 to 2018. So you can see it was 1.5 and it has increased to nearly 18. Right? And you can see at the same time the decline in the open and the decline in the laparoscopic surgery. Right? And you see when the robotic surgery was started, there's a decline in the open as well as in the laparoscopic surgery. And you can see the fold of this the trends. If you look in the difference, there's an 8.4-fold increase in the robotic surgery. This is in the Michigan state of USA. In USA, the robotic surgery is being used most often compared to the rest of the world. So you can see the change is more in the inguinal hernia, 41.1%, ventral hernia, 44.8%, colectomy, 6.5%, reflex surgery, 4.8%, proctectomy, 8.6%, cholecystectomy, 3%, and complicated cancer resection, so nearly 2%. And you can see the cancer surgery, so the esophagus, stomach, pancreas, colon, rectum, nearly 20 quadruple, it's almost 25% increase in the robotic surgery from 2010 to 2014. Similarly, for the liver resection using robotic surgery, it's a four-fold increase, right? So let's focus on the robotic pancreatectomy per se. So you can see the number of centers and the number of surgeries done from 2010 to 2012 or 2015 to 16. You can see 16% of the total, right? And the number of surgeries is close to 400. And similarly, the trend in the pancreatic adrenectomy. So you can see 2015, 16. So nearly more than 400 surgeries, and the proportionate surgeries of the total is 8%, right? So, and if you see in a center in Korea, right, the number of robotic laparoscopic surgery in the open surgeries, you can see the increase in the robotic surgery, and currently 30% of the gastrectomy is done robotically, right? So there is actually, if you look into the cost effectiveness, so I cannot say anything because the robotic surgery is costly. There is no evidence to advocate robotic surgery, but once the cost comes down, probably we may be able to advocate robot. But the current trend is that the trend is like that, and which is likely to persist. And one day, it may be we may have to advocate robotic surgery, right? So let's look into the basics for those of our residents. Some of them who have not seen the robot. This is the Da Vinci X-ray robot which we have, and you can see the surgeon console, patient site card. So can you know how to decode this? This is the vision card, and you can see the surgeon console is a 3D display. There is support foot pedals, and we use the manipulate instrument there. And usually this instrument these instruments have got a 7-degree movement. So when we start a surgery, we use usually the fenestrated bipolar scissors, progress for a carrier, and exchange the instruments with either the Maryland or the tip of grasper or other instruments. So we can use usually a bipolar with a monopolar. Right? So that's the advantage of. So that's in brief with the Da Vinci X-ray remote, which we have currently and which we are using. So if you look into the training, there are some training pathways given in the, if you go to the countries like Japan. So this is the pathway which they advocate to master robotic pancreatic adrenectomy. So which comprises of this initial training. So initial online training followed by on-site training, all the sitting on the console of the robot, doing the this thing. There are certain exercises doing that. Off-site training on the cadaver, and then a simulation exercises, 24 simulation exercises, you should get more than 90%, followed by that an anastomosis on a biotissue, PG and HJ, followed by observation of the video of dissection, reconstruction, and then you will be taken to the case observation, participant as an assistant, participant as an operator, with a stepwise approach using a proctor. And this is a biotissue, you can see. So doing the PJ and then the H. So yes, if you go stepwise, so then you can master even the pancreatic adrenectomy. So this is a small video of our, which we have done here in our department. So that was the initial, this is the patient cell. This is how we place the port, starting from the anterior axillary line and to assistant port and the HV operator. You can see the initial gastrocolic ligament being divided. We do the extensive cauterization, move the colon, mobilize the colon completely down. You can see the gastrocolic momentum being divided. And the gastrocolic trunk which is being dissected, clipped and cut. So actually we have used two patients video here just to show the extended catheterization, and actually the first jejunal loop is pulled up into the supracholic compartment and divided. You don't go in intracholically at all. You can see that. So that's the gastrocolic trunk being divided. So attempting catheterization, mobilizing the colon. You can see the right colon is almost completely mobilized. You can see the duodenal and the jejunal loop appearing. We pull the jejunal loop into the supracholic compartment and then dissect further. Pulling the jejunal loop. And then the hepatoduodenal dissection. The right gastric artery will be dissected and it will be healed. Let's see, the right gastric artery will be clipped and divided. Gastroduodenal artery being dissected. Checking for the patency of the hepatic artery before being clipped. The bile duct will now we are dividing. Then we come down to divide the neck of the pancreas. I think before that we're dividing the stomach and the antrum. Tunneling below the pancreas and cutting at the neck of the pancreas. I have to thank my senior associate for editing this video and taking the trouble of condensing it and so that the jejunal loop. Then we come to the uncinate process, the jejunal loop being concentrated. Now, uncinate dissection. Uncinate process being. Problem is when we do this procedure and it usually goes up to say 6 o'clock, and if you delay the dissection, if the OT exceeds 8 o'clock, we will lose the next day OT. So we may sometime have to convert to hasten the process so that we will not miss the next day OT. That's it's being backed. Thank you for doing it to be specimen. And then so we reconstruct, before reconstruction, mobilize the pancreas and then take the loop. And so most of the time what happens, the reconstruction we gets delayed and we end up opening. But I'm sure after another few cases, you'll be able to finish the entire procedure before 8 o'clock and say overability. Currently, we are unable to say the overability. You will end up hopefully. But I feel once we bring this loop up, it's very easy to do the anastomosis here and there. The anastomosis will be like this blue wash gas flow regionostomy, right? So which many of you may be knowing. Like we take the transpancreatic sutures and fix it to the jejunum, and then so take the pancreatic type to the jejunum. So Bloomberg's type of anastomosis. Let me show the next video, which is a very short video, 3 minutes, I think. The video of the hernia which we do. So I have used two hernias in one video, 3 minutes. So you can use just like mimic the laparoscopy by putting 3 ports, taking all in the beginning itself, taking the self-gripping mesh and the suture, and then start dissecting and put the mesh. So if you want to put a 3D mesh, you need to put assistant port. So if you have a self-gripping mesh, there is no need to put assistant port, just a 3 ports technique. Just you can just mimic a open laparoscopic tap procedure. Right? This was a direct hernia. You can see the effect. The robotic, the platform is very stable. If you do this hernia on a robotic platform, I don't feel like doing a hernia on a laparoscopy. That's what I felt after doing hernia on a robotic platform. Very stable, and even our Uday has experienced. So as I'm mentoring him currently, so he also feels that after doing this, very difficult. So if you want to put a 3D mesh, you need to put assistant port. So that's because the 3D mesh is little bigger. So this is another video fused with the previous video, just to show you a 3D mesh. And the main thing is to parietalise this peritoneum till you see the iliacus. Otherwise, the mesh will get lifted up and there will be recurrence. That's the most important technique, right? So complete parietalization, the key for a successful hernia surgery in putting the mesh. If you put a 3D mesh, actually suturing is not necessary, and a self-gripping mesh also not necessary. Usually we start the year in this video is not showing. We take the suture of the pectineal ligament. The video is here shown on the lab side. Currently, we are fixing the mesh. So when you use a 3D mesh, will not be necessary. But still, we are fixing the mesh and then suturing deep. And when we do the case in robotic, this thing we are highly selective. We take up cases. The previous one which I showed you is a small tumor in the duodenum. So we had harvested about 10 or 12 lymph nodes in that. The margins are all clear. And the next video which I'm going to show is a carcinoma which was just a T2 lesion. So highly selective in that. After this actually. Probably with time we'll be able to overcome all this limitation and we'll be able to do it. So difficult cases also. This one is the robotic assisted gastrectomy. You can see the procedure starts with opening gastrocolic. And this was a very small tumor. So in this, we had harvested about 24 lymph nodes. Right? It was a D1 plus sort of lymph node thing. So it was very small lesion along the incision angularis. So it was since the margins were, it was close to the G junction, we have to do a total gastrectomy. So that is the gastroeploic vessels being dissected and cut. In our department, we have done nearly 165 cases of the robotic surgery. But because of COVID, the number became less. So we get to operate one OT every week, shared between me, Kati, and Line. See, Milan is a great example. This patient had accessory left hepatic artery, which is we sacrificed and then dissected around the left gastric. Left gastric, we dissected. Clipping and dividing. We have also done a robotic assisted esophagectomy, done a APR and anterior sections. We are trying all sorts of almost entire spectrum of GI surgery. Probably the time has come to try on liver resection as probably. There's a dissection around the. We are trying to release this renal circulation. After that, we'll be cutting the G junction using this thing, linear cutter. Endo G. And then the reconstruction will bring a sigma loop with Jejana. So initially we'll anastomy using the J and then cut and then bring it down for the jejunostomy. So we have made a steady progression. Probably days are far away when we'll be able to do the entire procedure within the allotted time, and we'll be able to say the OTR. So the next day, so this is the springtime in JIPMER campus. You can see the beautiful flowers. Thank you very much for your kind attention.
Firstly, I'd like to congratulate you for doing amazing work. And thanks to you, I think generations of postgraduates in doing surgery are going to be inspired to, think of lot of winning in the surgery departments in the country. Probably JIPMER and AIMS are keeping flag flying very high. So great videos, excellent. One small suggestion is actually nowadays a lot of people with robots. We don't have the Da Vinci, we have CMR, but one thing is the resection is much faster in laparoscopy than the robot.
So in your OT time, if you want to say that's a very good idea, which now everyone who's been doing a lot of robotic methods also saying that do the resection lab, it's much faster and then use the robot for reconstruction.
I've seen that, yeah.
We've done just some 5 lab methods only in our unit, but the resection time has come down to like 2.5 hours, 3 hours. Because we select usually good patients, right?
Yeah.
That's one.
But the problem is we have a dedicated robotic OT type. If you don't utilize that, it's gone from our hands. And our Dr. Rajkumar is the dedicated laparoscopic surgeon who does the, it's like that. And now we have got another hands in the form of Dr. Shanmugam. We will be competing with Dr. Rajkumar. Both are great guys in laparoscopy. And probably it will be taken to new heights.
I'm very, very happy to see this department of surgery. Keep it up, sir. And I'm sure by the time you next JIPMER surgery update is there, all the surgeries, liver section also will be demonstrated.
And our he does a fantastic laparoscopic kind of thing. Dr. Rajkumar, I don't know where he has not put the video.
I think students are really lucky to have a department like this. 25 years ago, I think we didn't have all the facilities that are available here, and we had to go out and learn something apart from whatever was available here. I think now the JIPMER surgery department is among the top. Hats off to you for the team, sir. Thank you very much. Thank you.
Thank you, sir, for that interesting video lecture. With this, we conclude day 1 of JIPMER Surgery Update 2020. I thank one and all present here, and we are looking forward to your presence for day 2 of JS. Thank you.